Good morning, everyone. We will start the KUA-AUA resident review course. I'm the training and the education director, Kwan Jin Park. And this is the time for welcome remark. So I will introduce the Hong Jun-hyuk, the president of KUA. Please.
안녕하세요. Good morning. Korean resident and foreign young doctors who are both online and offline. Several years ago, AUA and KUA made some agreed on MOU. And one of them is that KUA support AUA membership for all Korean residents. And another one is this review course for residents and fellows. For this, great scholars from AUA visited here. I'd like to express my deep gratitude to them all. And also, I hope this session will be a great help to you all. Please enjoy. Thank you very much.
On behalf of AUA, Dr. Ashim Skura will give a nice address. Yeah, please.
Good morning, 감사합니다, Dr. Hong and Dr. Park. Thank you for this opportunity to be with all of you. It's great to see so many residents here already, early. More will come, I'm sure, but for the pediatric session, I'm so happy to see such a nice response. If I could get my first slides. Yeah, okay, excellent. So over the next hour, please just set my timer for 1 hour, so that way I stay on time. We're very particular on that. So I'm going to try to get through as much as I can. If not, you have my slides and you may utilize them as you see fit. I hope to share some pediatric urology, some basic, some little bit advanced. But my hope is that this will prepare you for your exams, and also perhaps put some interest in you in pursuing pediatric urology as a specialty. Here in Korea, like Dr. Park, there's a very strong presence of pediatric urology in this country. I've been very impressed by the level of the standard of academic knowledge, care, abstracts, so congratulations to all of you on that. So I wanted to start where it all begins, prenatal hydronephrosis. This is where many pediatric urologists become involved. There are many, it is quite common to see some sort of anomaly in prenatal screening all over the world. And most of these turn out not to be very significant. But once in a while, there is something that we have to be thoughtful about. And how should we be thinking about it? What are the step-by-step approach is something that I'll be discussing today. So as you know, the kidneys first become visible on prenatal screening at around 12 weeks of age. Usually there isn't much hydronephrosis, but in about 8%, at 24 weeks there can be some mild hydronephrosis. And then the bladder becomes visible at 14 weeks. If it's not visible, as you know, then that's something important because you might have bladder exstrophy or conditions like that. But typically the bladder should be visible. And then the genitalia and sex determination is possible, by a few more weeks after that. Now, when we think about prenatal hydronephrosis, the most important point that we are considering is what is the amniotic fluid level? Because the early amniotic fluid is just a transudate. Later, there's fetal urine and lung fluid. And then you have urine production. For the 5th week, at the 5th week, it's the first urine becomes visible. 20th week, it's 5 cc's an hour. 40th week, it's 50 cc's an hour. And what matters is really at, as you get closer, what is at 30 weeks, what are we looking at? At about 30 to 34 weeks, oligohydramnios is less than 500 ml. Polyhydramnios is more than 1.5 liters. And that is going to really make a determination as to what the prognosis is, whether some intervention can be considered, and really what the diagnosis may be. So this is a very important inflection point in deciding the care of these children. Now, polyhydramnios we don't fully understand. It's diagnosed when the uterus is too large. You have to rule out esophageal obstruction. A multicystic kidney can cause this, mesoblastic nephroma, and some obstructive processes can cause polyhydramnia. So it's something that's not as well fully understood. Oligohydramnios, as I mentioned, that's a small number of pregnancies, but this is the most profound because this could lead to some important diagnoses. And it can be due to amniotic fluid leak, amnionodosum, but if it's there, you have to think about bladder outlet obstruction if it's a boy, fetus. So these are the things that we are thinking about because oligohydramnios can cause some serious things. As you know, it can cause pulmonary hypoplasia and it can cause Potter syndrome. Why does it cause pulmonary hypoplasia? It's not because the hydronephrosis is pushing on the diaphragm and not allowing the lungs to expand. This is what we used to think. Now we know that when you have oligohydramnios, the amniotic pressure between the uterus and the outside of the skin of the infant, there's a negative pressure created. And this negative pressure affects the stenting of the alveoli. And that's why you get pulmonary hypoplasia. So it's a differential of pressure across the uterine wall. When the infants are, in rat models, we have seen that when you have this lung hypoplasia, you have decreased expressions of extracellular matrix, TGF, beta, and some of these things are some of the biomarkers that are depressed when you have this problem. And so as I was mentioning before, 30 weeks is the key. If you see oligohydramnios before 30 weeks, this is pretty significant, and there is still time to consider intervention. If it is after 30 weeks, no intervention is going to help. But really, should you consider intervention? Well, this question will show up on many of your exams if you're a resident here, and something to be aware of, right? Because you have to see, should you consider fetal decompression by doing a vesicoamniotic shunt? Well, is it a dilated bladder with hydroureteral nephrosis? Is it a boy? Is it a male fetus? Is the karyotype normal? Is it a singleton? Is the oligohydramnios before 25 to 30 weeks? And then the favorable urinary indices, is it even worth it? Because if the indices are not favorable, doing some sort of intervention is not going to help you. So sodium less than 100, chloride, all the numbers are there. Now, should you do something, that's a whole different question, because as far as doing something very fancy, in many places you have excellent fiber optic scopes and laser scopes, and they're able to go into the infant's, not the infant, but in the fetus's bladder, and even go and ablate the valves in utero. You wrote a paper on this when I was a resident in 1995. Those things are probably not worth it. It puts a lot of risk on the fetus, and you might not be able to, the fetus may not survive. However, vesicoamniotic shunting can work in certain situations. But there's only been one trial that's really looked at it, the randomized trial, Pluto trial in 2013. It was affected by poor recruitment, so it never got enough patients. But what it did show is that if you can successfully do this, you do reduce pulmonary hypoplasia. So the chance that this fetus will have a better outcome at birth in the first month, yes, they have a better life survival. But long-term renal function is not affected because this is already baked into the kidneys. So if you think you're going to help the kidneys, you're probably not doing the right thing. But if it's severe oligohydramnios, you can consider that as a way of protecting the lungs, which is what causes mortality. So the basic principles, the problem, the hydronephrosis, we have to know that dilation is not equal to obstruction, and that doesn't equal damage. Because a lot of times when we see this, parents get very concerned. We do a lot of prenatal counseling. And it's very important to know that, okay, listen, most of these are going to be fine, but there are the certain things that we look for. And how should we really be talking to families? We've known that normal is that the AP diameter is less than 4 millimeters at 16 to 27 weeks, less than 7 millimeters at 28 weeks, and less than 10 millimeters postnatally. This is normal, okay? Now, the rest of it, we have to think in terms of risk stratification. So if this is normal, remember, here's the kidney on the sagittal image. You can see a little bit of the hypoechoic spots. These are the medullary pyramids. Here you see the medullary pyramids. You see mild dilation. That's normal, okay? That's not something that we need to be worried about. Here, 3.75 is still less than 4 millimeters. This is probably within normal. Here's again the medullary pyramids. But then, when is it abnormal? And when it's abnormal, when should we be thinking that there's a risk of UTI, that this infant's going to need surgery, the risk of renal deterioration? And so we want to propose a follow-up recommendation based on this risk stratification. So you may know that we used to, when I was sitting in your shoes as a resident, we were using SFU, Society of Fetal Urology classification. Now we've changed more to the UTD. Why did we do UTD? Because the UTD also looks at the ureter and looks at the bladder. If you're only looking at the kidney, that's only half of the story. Because you can look at the kidney, you see hydronephrosis, okay, but is the ureter dilated? Is the bladder thick-walled? Because these things are going to have more impacts on outcome rather than just looking at the level of hydronephrosis. So, 16 to 20, so at 16 to 27 weeks, 4 to 7 millimeters, or greater than 28 weeks, 7 to 10 millimeters, with just central calyceal dilation. Just central calyceal dilation. You don't see the peripheral calyces dilated. See, the peripheral calyces are not dilated. This we call UTD-A1. Why A? Because it's antenatal. So UTD-A1, this is green light. You're okay. Probably going to be just fine. You don't have to worry. A family should not be thinking like, oh my gosh, I have to, I'm going to have some serious problem afterwards. And then there's yellow. Yellow would be at greater than 7 millimeters before 27 weeks and more than 10 millimeters at 28 weeks. And you have peripheral calyceal dilation. Parenchymal thickness is a little bit less. Your ureters are abnormal. Bladder is abnormal. You might have oligohydramnios. All of this goes into UTD A2 and A3. And these are examples of that. You can see how the calyces are dilated. There's a little bit of thinning of the parenchyma. The parenchyma itself is more it's more echogenic. The color is different. It's not darker. It's too light, and that is echogenic, and that's more worrisome. So that's antenatal. Okay, there's no red because we know that it's yellow means that you have increased risk. There's some things we're going to have to do afterwards. After the baby's born, what should we be doing? So postnatally, if you have 48 hours later, you have 10 to 15 millimeters of dilation, it's only central, this is okay. Probably going to be fine. I usually don't do antibiotic prophylaxis if it's a circumcised boy. If it's uncircumcised or it's a girl, you might consider for 1 month until you are sure that you repeat the ultrasound at 1 month. It's still like this, I might consider stopping it. There's a lot of options. Yellow would be peripheral calyceal dilation and the ureters are abnormal. So in this situation, I don't have a good picture of the ureter being dilated, but these are mild megaureter, and I'll be talking about megaureter later on. And this would be a yellow. And then red is severe dilation, thin parenchyma, the bladder wall is thick, and now you have the peripheral calyces, parenchymal thickness, ureters, and bladder, all abnormal. Then we give it a red, and we call it P3, postnatal 3. What should you do? Well, for green, as I said, 2 additional ultrasounds, at 48 hours and at 1 month, and then perhaps 6 months later, at least as a minimum. I still watch them because even mild hydronephrosis can flip on you. So I keep watching them until it improves, but not so much every 6 months, every year. Keep an eye on it. Don't forget about it. If there's aneuploidy or something else, then of course it can change. But you know, if you're worried about valves, it's bilateral, it's a boy, but then usually the bladder is also abnormal. Now, let's just put all of them up, red. So yellow, it's UTDP2. It's up to the clinician. You have to put your best mind at work. You have ureters dilated. If it's a boy, you can probably watch it if the bladder looks normal, but if it's a girl, you might be worried about reflux and you might want to do a VCUG. If it's red, that's significant. And for that, of course, we're going to do antibiotic prophylaxis. We're going to do renal scan. We're going to do VCG, MCU, and you're going to do a full workup, right? So you have to use your judgment. It's not a cookbook, but this kind of gives you a better idea of where you should be. So here's the prenatal on the left, the postnatal on the right. This is a guideline, right? I mean, we all have to ultimately utilize our best clinical sense and be thinking about what is driving the dilation. That's why UTD is good, because it looks at the bladder, and that becomes a very important part of the picture. I have seen children with mild hydronephrosis. You say, oh, everything is okay, SFU1, but the bladder is thick. It turned out it was posterior urethral valves. So you don't want to miss something like that. So what can cause prenatal hydro? You know, for us as pediatric urologists, these are things we deal with: UPJ, obstruction, UVJ, ureterocele, ectopic ureter, MCDK, all of these things. And you know, it can, UPJ is the most common, and then you can see all the other percentages. But remember, overall, the #1 most common is normal. That is just going to get better by itself. And when you look at all hydronephrosis, the chance that it's a UPJ obstruction is usually less than 20%. So 80% are going to be just fine, but you need to know as you follow them, because some of them can change on you. And now this is a good slide, because this will be on your exam. You know, this still comes on the in-service exam in the US. It might be on your exam that you should know the radiopharmaceuticals that we use for MAG3, which is, well, MAG3, DMSA, DTPA, and gadolinium for MRU. And the most important thing is, you know, MAG3 we use a lot because it's cleared by the proximal convoluted tubules and secreted. So it gives you functional information and obstruction information, you know, clearance from the kidney. DMSA is excellent for renal parenchymal imaging. If you think you have pyelonephritis, you want to know if there's any kidney damage, then we get a DMSA. And then DTPA is good for ruling out obstruction. It doesn't give you good functional imaging. And then gadolinium is something that does both. It is secreted and it's cleared, and it's used for MRI mostly. So again, the DMSA, it's an IV injection. Immediately after pyelo, you will start seeing changes. It can recover, and it's a good way of looking at scarring. And then here's, you know, the MAG3, you know, and oftentimes you can have a curve, but you can't really rely on the T1/2. Many people still use that. Oh, it's 21 minutes, obstruction, do pyeloplasty. No. That's not how we look at it, right? Because hydronephrosis is not obstruction. You have to get serial imaging. Sometimes an MR urography can be helpful. For example, in this case, you know, pretty obvious. You have a infinite going curve. Though the function is normal, with a curve like this, I think you're going to operate on that. However, you often have a curve that's partially obstructive. T1/2 might be greater than 20 minutes, but it can be greater than 20 minutes in 20% of newborns. So just because you have a high T1/2 doesn't mean you have obstruction. And nearly 60% of non-obstructive severe hydronephrosis can show an obstructed trace or washout time. So you have to be very careful in just jumping. In those cases, we are more interested in what's the function. If the function is 20% and you have this curve, maybe this is more, significant, and you have significant hydronephrosis. But if there isn't a lot of hydronephrosis and your function is down, then you might be thinking about something else. But that's a whole different discussion about when to do pyeloplasty. And it's not just so simple. You have to look at the level of hydronephrosis, the renal function, and the T1 half. So you take all three, and then you look at, and if the function is normal, at least do 2 more ultrasounds to be sure the hydronephrosis is not improving. You have time because the kidney function is normal. So there's many things that go into that. Now, the other thing is unilateral renal agenesis. When I was in your shoes as a resident, well, most of you are residents, not everyone, we were taught that if you had unilateral renal agenesis, that you're okay. You have 1 kidney, no problem, everything will be fine. But now we know that there's contralateral things you need to be thinking about, and very importantly, I bring all of these children back later on because they can have, 40% of girls can have a Mullerian abnormality, because if you have unilateral renal agenesis, you have a mesonephric duct problem because the ureteric bud never took off. And so when you don't have a ureteric bud, you might have other problems. So bring these girls back to check for unicornuate uterus, Mayer-Rokitansky. And in boys, you have to think about whether they check their vas deferens. Do they have a vas deferens? Is there a seminal vesicle cyst? Is the ejaculatory duct look okay? So I do MRI on these children as they reach puberty. And then the duplex system is 2 ureteric buds. The lower bud is absorbed rapidly, but in the terminal portion of the mesonephric duct, that's where the epididymis, the vas deferens seminal vesicle is in boys. So in boys, you might see an ectopic ureter there, epididymis, vas deferens seminal vesicle. In girls, you might see it at the Gardner's duct and anywhere more proximal from Gardner's duct. And the upper bud absorbs slowly with a long tunnel. And so we think about a child with, a second opening below the urethra, above the vagina. This might be a classic place where you find an ectopic ureter that can lead to continuous dribbling. I have to be honest, these days, this is not the most common finding. Most common finding is upper pole hydronephrosis on prenatal screening. That's how we find most of them, but still once in a while we will find this. And then again, as I was mentioning, unilateral renal agenesis, you can have these types of things. If you're not careful, they can come back with dilation of a unicornuate uterus or a bicornuate, and one of the branches may be dilated, may be obstructed, abdominal pain, amenorrhea. So these are things you always have to think about in a child, or a child who presents with amenorrhea, you better check ultrasound of the kidney, because you might be having unilateral renal agenesis that was undiagnosed. So prenatal hydronephrosis common, rarely of clinical significance. Proper counseling is critical. Heroic antenatal interventions are not very efficacious, so don't underestimate unilateral renal agenesis. So we'll do the reflux talk number 2. So I'm going to take you straight from here to another common area. And I don't know if Dr. Amling is here, but for a cancer surgeon, many of us went into pediatric urology because, we thought that prostate cancer, we don't know, there's so many questions, should you operate, should you not operate? And so we went into pediatric urology thinking everything would be clear, that, oh, you have a hypospadias, you fix it. You have undescended testicle, bring it down. However, there is something like this called vesicoureteral reflux from UTIs, and how do we think about that? Because for this, it's a little more complicated. So as a basic that urinary tract infection and vesicoureteral reflux are very interconnected. Urinary tract infection in children, it affects 5% of all children under 6 years of age. Dr. Yair Santiago is going to talk about in adults, and because it's all connected. But in children, this is what we see. And there is some risk stratification in the U.S. So white children, And I think Asian children go right with the white children, and we've looked at those statistics. We don't have a huge number in the US. As you know, Asians are only about 3% of the population, so they don't often fit into these numbers. But if you look at per country, Korea, China, India, we are looking at about that. So you can consider them within the white children category. Girls have a higher prevalence than circumcised boys. White girl with a temperature greater than 39 degrees could have a 16% chance of having a UTI. So any girl presents to the emergency room, about a 16-20% chance if they have a high fever that they have pyelonephritis. Now, why do we care about urinary tract infection? Well, if they get pyelonephritis, it can cause kidney damage, and if you have severe kidney damage, you can, perhaps have a big problem on your hands. Now, we've been thinking about reflux and UTI for a very long period of time. Since 1960s, this has changed, and you can see over 50 years how our thoughts have changed, and these have been landmark moments in the history of UTI and reflux. Concept of antimicrobial prophylaxis, antenatal ultrasound, VCUGs. And the pathophysiology was understood that when kids had UTIs, they might have reflux because of bacteria, and it could cause kidney scarring. What are the chances? Now, if you have UTI, the chance that you have reflux is about 40%. Okay, so if you have a bunch of children, if all of these children had a UTI, about 40% of them are going to have reflux along with UTI. But a smaller number are going to have scarring. So who gets scarring? Who gets, reflux? How do we know, and how should we find out? How should we manage them? And which child? Because we know that we have treatments available, and I showed you this before. And in 1972, Ledbetter and Politano described creating an intramural tunnel for the ureter and doing a reimplant. And the first reliable surgery in 1972 was described. So you can get rid of reflux, but do you get rid of the bacteria? And what does the kidney do? If you fix reflux, do you save the kidney? I don't know, right? Because we realize that while it is a very effective surgery, and it can be safely done, the cost is immense. If you did every child with VCUG and had reflux and you did surgery, the cost you can see would be $1.3 billion. I made this slide about 7 years ago, so it's probably changed since then. There are other things that came out. Antibiotic prophylaxis. Now you could get rid of the bacteria. You still have the reflux, but you can get rid of the risk of infection. What does that do? Well, the problem is when do you stop the antibiotics? You have to do more VCUGs, checking, right? When does the reflux go away? And that caused so many children to get so many VCUGs. If it's almost, you ask some parents, they feel it's terror to have a child go through a VCUG, a catheter, sleeping on a cold table, taking x-rays while their bladder is being full. So is that really the best treatment? And the cost could be immense for that. 38,000 gallons of Bactrim, $600 million in surgery. So the costs can, continue, and you still have to be a little more careful because, and so thinking about all of these things, in 2011, the AAP guidelines changed. They said if you have, you should not just do everyone has a UTI. To know that you have a UTI, you have to get a cath urine specimen. Peeing into a cup, bacteria, UTI, no. You should do a cath specimen because bagged specimens have an 88% false positive. You should look at the risk factors, and a UTI is only if the urine culture is greater than 50,000, if there's pyuria and there's bacteria. And then you had to look at the risks stratification again. We already talked about it. The risk factors for boys, risk factors for girls, the probability of UTI, uncircumcised, circumcised. Look at all of that and then decide if they need a VCUG. So they're trying to reduce the number of VCUGs. And so they said, okay, this is 10 years ago, 12 years ago now, this came out, that 7 to 10 days of antimicrobials, do a renal and bladder ultrasound. and no VCUG after only the first UTI if the ultrasound is normal. But get a VCUG if they have a second UTI. We used to think, oh my God, one UTI, you already destroyed the kidney, you got scarring, why would you do that? We said, no, you know, actually, if the renal ultrasound is totally normal, the risk of renal scarring with a single UTI is not that high to say, hey, everybody should get a VCUG. In fact, it's about maybe 2%. So this, you know, this is the original model of care. UTI, you have reflux, you get renal scarring, you get end-stage renal disease, hypertension. And in the future, you might have preeclampsia and lose pregnancy. This is what I was taught when I was a resident, so we were very aggressive about treating reflux. But there were problems with this model of care. Renal scarring is associated with UTI, but it's less common than reported. Renal scarring is observed in children who have had UTI but do not have reflux, and very little evidence that interventions for children with reflux are even effective. And VCUG and treatments for reflux have potential harms and definite costs. And you know, you can see this number here that renal scarring with reflux is maybe not as common as we used to think. If you have reflux, the risk of renal scarring we used to think was somewhere between 40%, 30%. Then there have been some studies that show it's only in 5%. Mm-hmm. I think that the number is probably around 10%. Okay, if you get a kidney infection, the risk of renal scar is probably around 10%, small scar. But it's not as high as we used to think. And if it's only 10%, 90% have no problem, right? They got a kidney infection, you treated it, they did fine, and you don't have to worry about them. And one thing is very important. If you diagnose a UTI and you begin treatment very quickly, you can save the kidney. You can reduce the risk of significant renal scar. And there's also a lot of ecological evidence showing that every child does not need every child with reflux is not going to have renal scarring. But let's look at some of the data. What causes UTIs? Abnormal bladder function is associated with more UTIs. So if you have a child with the reflux, you put them on antibiotic prophylaxis, bladder function is the biggest driver of increasing your risk of recurrent UTIs. If you have dysfunctional elimination syndrome, almost 40% of these children will get a breakthrough UTI. If they don't have dysfunction elimination syndrome, it's about 15% will get recurrent UTIs. So you really need to work on the bladder. What causes scarring? You know, you're always worried about scarring. Oh, you better do surgery because your kidney might have scarring. Well, UTI and reflux causes more scarring than UTI alone. That's true. You know, and you can see the odds ratio of scarring with reflux. Overall, it's about 5%, right? 5 to 10% risk of having scarring if you have reflux along with UTI. And more UTIs, more risk of scarring. And if we delay diagnosis of reflux, now, it's also important to know that if you don't diagnose a UTI, you have a higher risk of scar, but you also have to be very careful saying, okay, it's just one UTI, don't worry about it. That's not my message also. Because a recent study from Boston Children's Hospital showed that if you had, looking at the AAP guidelines, renal scar used to be about 5% when they used to be very aggressive about treatment. When we become too non-aggressive, it went up to about 12% risk of getting a renal scar after a kidney infection. So you have to be pretty careful. So this is after the AAP guidelines. And so who got the risk of a scar? It's higher grades of reflux. And so my message is not that don't do VCUG, but we have to be more careful about who needs treatment, what level of reflux, how many UTIs. So all of that and what is their bladder function? So that's kind of the matrix that we need to be thinking about. Now, we know that reflux can get better by itself, but whose reflux gets better by itself? Well, lower grades of reflux, a very high rate of the reflux improving by itself. Higher grades of reflux, low risk. In general, this shows you that a grade 3 reflux it has about a 50% chance of improving over 5 years. 5 years, 50% chance, spontaneous resolution. Well, not everyone wants to be watched for 5 years getting antibiotic prophylaxis, VCUG every year. But how can you help the reflux resolve? Well, abnormal bladder dysfunction, again, so working on timed voiding, working on constipation, making sure they're drinking lots of water, so they're going to the bathroom every 2 hours, not holding for too long. All of these things can really reduce the risk, and we can really improve the chance that the reflux goes away. So if you look at my clinic, it's more like Dr. Santiago's clinic. When they have reflux, it's not surgery. It's really working on bladder dysfunction, really trying to get them to stay on antibiotic prophylaxis, and hopefully this reflux will resolve. Even if you do surgery, your risk of having a breakthrough UTI is higher if you have abnormal bladder dysfunction. So you can't just fix it by doing surgery. They're still going to keep, in our studies at CHOP, 20% of kids who have had successful reflux surgery get a breakthrough UTI. So you can get a UTI even after surgery if you have bladder dysfunction. And so there it is again, increased incidence of UTI after surgery. And as I mentioned, it's about 20%. It can be reduced to 5% if we really work on that. And also, remember, every child who gets a UTI probably had a lot of UTIs before. So we have to continue to think about, you might have a genetic risk factor. So you can do surgery, you can put them on, bladder dysfunction, and a few percent still get UTIs. And I tell them that if you had 5 UTIs before, there's probably a chance you're going to continue to have some UTIs, so we're going to have to keep working on that. And these are modifiable risk factors that we can talk about. Now, let me just skip here. So UTI and reflux causes more scarring than UTI alone. More UTIs, more scarring, abnormal bladder dysfunction. Okay, we all agree on these findings. So we want to prevent recurrent febrile UTIs, we want to prevent renal injury, and we want to minimize VCUGs, minimize treatment and interventions. So what helps? Antibiotic prophylaxis is a mainstay. You've heard me talking about that. Does that really help, and what are the risks? So there's one big study, right? It's very uncommon in pediatrics to have randomized controlled studies like you do in cancer. It's just the reality of how the practices are, how children are, and the types of interventions available. We don't have, all these new drugs on the market. But this one study looked at 600 children with reflux, and the primary endpoint was recurrent febrile urinary tract infections. And what this showed is over the study period of 2 years, they found that if you were on antibiotic prophylaxis, it reduced the risk of UTI by 50%. So, it's not great. It's not like it's eliminated because you have antibiotic prophylaxis, but it's not bad. It does reduce the risk by 50%, and reduces the risk of 1% to about 10% over 2 years, that you're going to get a breakthrough UTI. So that's good. But you have to know that this study actually showed that the risk of a new scar was about between 5 and 10%. And there was no difference between the treatment groups. Putting on prophylaxis didn't reduce the risk of a renal scar. And of those with recurrent UTI, many had resistant to Bactrim, and 8 children had to be treated for 2 years to prevent 1 recurrent UTI. It's a pretty large number of kids are getting antibiotic prophylaxis. So we need to be even more focused. Who needs antibiotic prophylaxis? Who can just be watched? Well, we know you can do a circumcision in a boy, and that will reduce your risk of UTI. So that's a #1 thing that we do in the US. If a boy gets a breakthrough UTI, has reflux, we recommend circumcision, and then you can stop all antibiotic prophylaxis. Their risk of UTI is very low. However, you don't have that option, of course, in girls. The QD trial, which was looking at the same patients if they were in the RIVER trial, and the QT, which was a British trial. And it showed that children with reflux had higher 2-year rates of recurrent febrile UTI. Okay, so if you had reflux, you did have a higher rate of recurrent UTI. At the end of a 2-year follow-up period, 8 children in no reflux and 24 children in the reflux group had renal scars. So again, if you had reflux, you had a 10% chance of developing a scar. But even if you didn't have reflux, you had a 6% chance of developing a scar, even with no reflux. So it does, you're a little bit close to double the risk if you have reflux. But this again, gets back to the point that it's really about treating the UTI, work on the bowel dysfunction, try to limit the number of UTIs, because scar, that's not what's really driving me to do surgery or all of the interventions that we often talk about. And then another randomized trial was just published last month in the New England Journal of Medicine. So this, we're still, in pediatric urology, we're still digesting this study. This was a randomized study comparing infants with reflux with no previous UTI, with or without antibiotic prophylaxis. The reason this study is an Italian study, we thought it's kind of a European study. We thought it a little bit funny because why did they even diagnose reflux in these children? These were children with prenatal hydronephrosis that they were doing studies. We don't really work up all of these children anymore. If some child with antenatal hydro, we don't automatically get a VCG. They did, and now they found all this reflux, and they said, do we need to put them on prophylaxis? But it gave us some interesting information. The first UTI occurred in 21% of the patients, and 35% of the patients in the untreated, no antibiotic prophylaxis group. New defects, okay, new DMSA, 18% of patients who had no UTI, and 19% of patients who had one UTI. So these are children with reflux, already have a chance of having a scar just because they were born with dysplasia, okay? So they didn't even have a single UTI. They already had scar because they had reflux. But there are some flaws in the study. The study also showed that girls with higher grades of reflux, grade 3 or more, had a much higher risk of getting febrile UTI than lower rates of reflux. So what do we do with all of this information? I've given you so much information, it's all out there, I probably confused you, but here are the things you need to remember. If you have no bowel and bladder dysfunction, you have recurrent UTIs, you have renal cortical abnormalities, you can put them on prophylaxis, you can put them, you can also stop the antibiotic prophylaxis after a certain point of time. But if you have bowel and bladder dysfunction, you better put them on prophylaxis, and you can't take them off of observation. And so, what do? I don't diagnose children with reflux after workup for antenatal hydronephrosis. But if you do, they tend to do better. And they have a high rate of spontaneous resolution. So I might watch them on prophylaxis, and the study that I just showed you from the New England Journal showed that most of these kids will improve if they have lower grades of reflux. And I'll stop prophylaxis early depending on the grade. If they have reflux and no scarring after 1 or 2 UTIs, if it's low-grade reflux, and we're doing a study right now at CHOP looking at about 3,000 patients that we treated with reflux, and we stopped their antibiotic prophylaxis if they had less than grade 3 reflux, and the chance of a recurrent UTI was less than 10%. So you can stop their antibiotics if they're doing well after toilet training. And grade 4 to 5 reflux, I'll consider surgery, okay? I'm not gonna stop their prophylaxis, especially in a girl. In boys, you can stop it. Reflux with scarring diagnosed after a UTI, higher grades of reflux, even in a boy, you're gonna consider surgery. So reflux remains a clinical challenge. It's a wolf in sheep's clothing or a sheep in wolf's clothing. You can't simply treat based on grade. You have to look at the total patient, special emphasis on avoiding dysfunction, history of UTI, presence of renal abnormalities. And really, there's no code. And so this is probably the biggest art in our work, is really trying to decide who needs surgery, who can be followed, taking lots of data into this. It's hard to put it all together. However, the take home would be that if you have a girl with grade 2, grade 1 reflux, stop antibiotic prophylaxis after toilet training and see how they do. Grade 3, it's on the, depends. If they have excellent control avoiding dysfunction, they're doing very well. They've never really had a UTI, you can consider stopping antibiotic prophylaxis. But if they've had multiple UTIs, you do surgery. And higher grades of reflux, we're not going to be very comfortable watching that after age 3. In boys, circumcision, normal upper tracts, nothing. We stop antibiotic prophylaxis. Let them prove that they have a problem, and then we will do surgery. We're not going to be doing surgery based on the looks. All right. So hopefully we'll see you all in San Antonio. Just the slide there. And I think with all of you are AUA members sitting in the room, so you get, I think, very low registration fee, almost free registration for residents. So you just have to pay for the flight to San Antonio, and hope to see you there. Okay, next talk on valves. All right. So you're doing great, you're hanging in there, there's 17 minutes left, okay? You just have to stay awake for a little bit longer, and then we'll be done with pediatrics. I have another talk on megaureter. I don't think I'm going to get to it, but it'll be here, and it can be, you can borrow it, and we'll talk about that. But I wanted to get to most important things, and I think that's prenatal hydro. We talked about reflux, UTIs, and now we'll talk about posterior urethral valves. And this is, a subject that's important to me. Those of you who read Campbell's, I've written this chapter about the last 3 editions. So it's something that I try to keep up with. I'm reading about valves a lot, trying to see the latest data, latest information. So I thought I would sort of put that together here. So posterior urethral valves. It's one of these things that the initial surgery is very simple, right? You go in there and you snip the valves. But that's just the beginning, because the most important things that we have to worry about are later on. What happens to the kidneys? What happens to the bladder? And if you focus too much on the kidneys, the kidneys are so dilated, they look terrible. With valves, you have very horrendous looking kidneys. But you forget about the bladder, and now you're really going to have a problem. So really, we need to be thinking it's a bladder problem that's causing all of the upstream effects that we discuss. So how do you triage a child with valves? Well, you have valves. It's a pretty serious thing, and you get caught up looking at this. But really, the most important thing is that the lungs are the most important thing in the newborn. Are they going to do okay in the beginning? And that's going to depend on whether they have pulmonary hypoplasia. And then we can start thinking about the kidneys. Do they have, a large amount of hydronephrosis? You can even have, like I told you, you can have mild hydronephrosis, but you have a huge dilated bladder. They can be tricky, and you think, everything is okay, it's not so bad. And then you realize that it's actually posterior urethral valves that can be pretty significant. And later on, so first you worry about the lungs, then you worry about the kidney, thinking about what's your, we'll talk about that, but what is your lowest, your nadir creatinine, because that's going to tell you what your renal outlook is. And then the last thing, but the later thing, not the last thing, but what's coming up later after you worry about the lungs and the kidneys, you worry about the bladder. Because in the newborn, you have this full bladder effect, and then they go through some dysfunctional voiding during toddlerhood, and then as an adult, they can develop a valve bladder that we will discuss. So what are the types of valves? You know what? You don't have to worry about this too much. I think that type 2 doesn't exist, and I think maybe type 3 and type 1 is always a big discussion. Some people think that type 1 is really a type 3 valve that was perforated when the catheter was put, and so it created the valve effect. It doesn't matter, okay? What you need to know is that type 2, there's no such thing. What you commonly see when you look inside and you see the valve leaflets, that's the most important thing that you need to know about. How do you diagnose it? Well, there are many different ways, VCUG, but now we also have CVIS, the contrast-enhanced ultrasound, voiding urethrosonography, where we can even find these valves very nicely without radiation. So we're doing a lot of that at CHOP now using CVIS technology, which reduces the amount of radiation that these kids get. And when you look in, this is a child who did not have a catheter put, and you can see that this is a type 3 valve, right? It's a little annular narrowing. But you know, this is what we more commonly see. The catheter has been in here a few days, so did it perforate that and create this? I don't know, but here are the valves, right? Here are the valves here, and then you have 12 o'clock valves as well. You know, usually I make an incision here, and an incision here. So this is cysto after 7 days of catheter drainage. What is the pathophysiology here? So as I mentioned, you know, a lot of these things start because of the valves causing bladder obstruction, which alters the contraction, reduces the detrusor blood flow, causes ischemia, and we're going to talk about all of these things. You know, the extracellular matrix is a very complex process that you don't really need to know for your exams, but it's good to know that a lot of things are happening, and we might come up with many more biomarkers that can tell us that this bladder is worse than that bladder. We're not there yet. Right now we're just working on urodynamics and looking at bladder function, but we're coming on to those types of things. This slide you've already seen, so I'll skip it, but this talks about how oligohydramnios, and then we can skip this one because it's a repeat of the prenatal hydro talk. So oftentimes when you have a baby with valves, you'll see something like this at the kidney, and that's a urinoma, right? So the obstruction is so high that the kidney is kind of smushed here, and you have a lot of fluid that's already escaped because of the pressure, a pop-off. This is 3% to 10% of valve cases. What do you do for this? No, I don't think you should be perking this. Sometimes we have to perk it when the child is in distress because it's such a big urinoma. But 99% of the time, all we do is restore urine flow, put a catheter, and wait, and all of this urine typically gets resolved. Once you get the antegrade flow going, urinomas will start to reduce, so you shouldn't worry about that too much. What about reflux? We get a lot of VCUGs in these children, we worry, is this bad? You know, and there's a 80% incidence of reflux in valves. It implies that there's bladder dysfunction. Duh, you have posterior urethral valves, so you have bladder dysfunction. And you can reduce the intravesical pressure by considering anticholinergic treatment, but really I want to stress that we want to work on the bladder function. Don't think about the reflux. And there has not been a study that reflux worsens long-term renal outcome in these children. Yes, kidney infections can, but should you fix a reflux for that? And you know, this is the VERD syndrome, where you often have massive amount of reflux on one side, and it's a pop-off. The reflux goes on one side, the other side might have reflux, but when you do the renal scan, there's no function on one side. Okay, so that's called the vesicoureteral reflux dysplasia. We used to think that if you have that, it protects the contralateral kidney. Now we don't believe that anymore. We think that, you know, these kids are going to have the same outcome whether they have VERD or not. So don't focus on that. But an important point that I want to stress is that if you have reflux, okay, if you have this, if you have this and you have UTIs, you need to be thinking about what's going on with the bladder. I'm more likely to do a vesicostomy than I am to do a reimplant. In fact, I almost never do a reimplant in a child with recurrent UTIs and posterior urethral valves. You're going to have a bad outcome, you're going to have persistent reflux, or you might end up with obstruction. You're going to hurt the kidney even worse. So almost never. In these types of children, I do vesicostomy, I start CIC, I might even consider a Mitrofanoff, but I'm not going to consider reimplant. Reimplant is a bad idea in this situation. Now, clinical presentation, as you know, you're going to have this valve right here. You're going to have very high pressure, so you can see ejaculatory duct reflux. You have all these diverticula and a very trabeculated bladder. And when you go in, you're going to have high bladder neck hypertrophy, right? You have to crank that scope all the way down to get inside there. And so some people have thought, would a bladder neck incision help at the time? That the child is not having good bladder function, should you cut? There are some people, you know, Iranian studies have shown some improvement, but really no other studies have shown that these children do better in the long term. It increases the risk of retrograde ejaculation, and there isn't really improvement compared to controls, and it might cause incontinence. So I never do that. You just know that you have a high bladder neck. It can be hard to pass a catheter. How should you do the incision? You can use the knife, you can use the bug bee, you can use a laser, it doesn't matter. You just need to cut those. And like I said, the vesicostomy is something that I use quite often. It's not just in low birth weight infants. That's where you have to do a vesicostomy. But when you have, you know, the renal function is not improving, the upper tracts are very dilated, I'll consider a vesicostomy in those kids to just get, you know, decompression at that point. But only if there's a lot of urine in the bladder. If you have a lot of hydronephrosis and you think, let's just do vesicostomy, don't try to make the kidney look better, and we'll talk about that. One thing about vesicostomy, it does not defunctionalize the bladder. Many people think, oh, don't do vesicostomy because the bladder is not going to be working, the urine is just coming out, and it's better that the bladder squeezes. Well, it actually does continue, because if you make a good vesicostomy at the dome of the bladder, you're not going to have that problem. Should you do hydroversion? You know, sometimes we get very caught up, I want the hydronephrosis to go away. Then I feel happy. We're urologists. We want to get rid of hydronephrosis. You know, we're on a mission to rid the world of hydronephrosis. But if you put, you know, we used to do pilostomy or ureterostomy. I feel like all of those treatments, well, not I just feel like, the data shows that it does not improve over ablation alone. So, you know, just ablate the valves. A big study with Graham Smith in 1996 when he was at CHOP showed that if you look at ablation versus ureterostomy, loop ureterostomy, versus a pilostomy, they all do the same. And in fact, there's no protective benefit in making the hydronephrosis go away in valves. So don't be chasing hydronephrosis. Focus on the problem. One thing also to remember is that even at CHOP, okay, with all the prenatal hydronephrosis that's available today, 43% of the children that we see with valves present later. So it's not just prenatal hydronephrosis. If you have a child with LUTs, with recurrent UTIs, overflow incontinence, get an ultrasound, especially a boy. With these symptoms, you have to still be thinking. In a girl, it's a little different, but a boy, you still have to be thinking that, am I missing valves? So you get an ultrasound, look for bladder wall thickening, and go from there. So, as I mentioned, this is often on your test. There are three major patterns that the bladder goes through in posterior urethral valves. In infancy, you have detrusor hyperreflexia. In childhood, they actually go through a normal period where they'll toilet train pretty normally at around age 3. They don't have delayed toilet training often. They do okay, but that's where you can get into trouble. Oh, they're doing fine, don't worry about it. If they start holding and they don't have the same sensation with the bladder, oh, I'm full, they have to remember to empty. And I tell all the families, you have to give them a watch with a timer, so every 2 hours they go urinate. Because if they start holding, because they can hold, they can then end up with hypocontractility in an atonic bladder, what we call the valve bladder. And this is the worst problem, because what does this do? Well, you know, here's a 7-year-old boy with valves and worsening upper tract changes. It's worsening instead of getting better. And you can see that the detrusor, you know, can hold, you know, larger and larger amounts of urine. However, the pressure is not going up, and they're not mounting good contractions. And what happens with the valve bladder? So you have high post-void residual, right? The child is not voiding, he's holding a lot of urine. That causes stretch, that causes collagen filament changes, that causes bladder wall hypoxia, storage pressures. Those pressures are transmitted to the renal pelvis. You start getting renal tubular damage. What does that do? When you have renal tubular damage, you get polyuria. Polyuria leads to more attempts to void at high pressure. That leads to more urine being stored because they're not able to empty all of the urine. And then that causes a high post-void residual, and you get the vicious circle. This is very important, and I want you, the residents to know this, because you'll be asked questions about this on your exam. And why a valve bladder causes the diuresis, which makes it even worse. You get polyuria, then you get high post-void residuals, you get more polyuria, and it creates a big problem for these children. And how do you manage that? And so, this polyuria from poor bladder compliance, nocturnal bladder drainage is the most helpful thing for that. So we put a catheter in these children at night. They may urinate perfectly normally during the day, but at night, by putting in a catheter, they have 8 hours, 10 hours of continuous bladder rest. And that's how you break the cycle of high post-void residuals causing more damage. These children will do better. They'll stop their progression of renal disease for a little bit, and it's a really nice thing. It doesn't end it because, a lot of this kidney damage is already baked in. However, nocturnal bladder drainage, sometimes the children will refuse to put a catheter, parents refuse to put a catheter. Then I often will do a mitrophanol for these children. Not so many, but maybe 2 a year. But these are kids that will need a mitrophanol, so they will at least do the overnight bladder drainage. It becomes and if they refuse that, I do vesicostomy. And we now do this robotically. I have about 2 minutes left. So, the appendix is, I used to do it with a staple. Now I just use cut it intravesically, but this is when I used to use a staple. And then, you mobilize the bladder, drop the bladder down, and then, let's see here, okay. And then I'll make a detrusor tunnel like we showed yesterday when I do a reimplant, make an extra vesicle. Here I'm putting the appendix in the posterior wall. Oftentimes I put it in the anterior wall. So it just depends on the length of the bladder, how big. This was a very small bladder, tight, thick-walled bladder. So I said, okay, let me just put it on the posterior wall. And then, we're just testing the appendix, making sure the feeding tube goes. And I'll put a hitch stitch to lift it up to stabilize it. And then here's the anastomosis of the appendix to the bladder. And then, we'll put it into the intramural tunnel, just like we talked about yesterday, as we do for reflux. And you want to advance the ureter into the detrusor hiatus. And then the last thing is I just bring the appendix through my camera port. I put a long Prolene stitch, go in with a side port, and then pull it up into the appendix, into the umbilicus, and then stitch it right there. And that's how you get, this appearance here. These are the side ports for the procedure. So no more midline incision for these kids. And they love putting the catheter through that, and they'll leave it in there overnight. Now, what are the prognostic indicators in my last 1 minute? Lifetime prevalence of end-stage renal disease is 20 to 50%. Overall, it's about 30%, right? We tell a family 1/3 chance that they're going to get a kidney transplant. 2/3, they'll do okay if they stay on top of it. What is the best risk factor for prognosis? It's going to be the nadir creatinine at 1 year of life. That's going to give you the best prediction how this child's kidney will do. There are other things that we're thinking about. However, the 1 year is the most important, and less than 0.8, you have the best prognosis. Now, somebody will say a 1-year-old with a 0.8 creatinine, that's not very good, okay? But it's the best number that we have right now, that they have a better chance than somebody who's higher than that. But 0.8 to 1.2, more than 1.2, very high risk of renal disease. Between 0.8 and 1.2, it's a question mark. We don't know for sure. So there's a lot of new data going on right now looking at parenchymal. We're using machine learning to look at measure the kidney, subtract out the black area, the hydronephrosis. So just measure the parenchyma and utilize that to guess what the kidney health is going to be. And we need to continue to improve on that, but these are new areas that we're looking at, and especially for those people between 0.8 and 1.2. And finally, in transplant, there are some challenges. The one thing that I want you to know is that if you look at kids with transplant, they do have a higher risk of ureteral obstruction if you look at the reimplant. So you have to be very careful when for my program, when the transplant surgeon is doing a transplant, I like to be present if it has a valve bladder, because I want to be very careful how we do the ureteral anastomosis to be sure that you don't create a long tunnel and cause obstruction. So you have to be a little careful in how we do these children. You know, so this is all the study that we're showing here, that they have the highest rate of ureteral obstruction. And the other important thing is, if you look at these children, whether they had a vesicostomy or they have other types of reconstruction, there's no difference in outcome in terms of rejection. So these kids do okay as long as you manage their bladder very well. So before they go for transplant, I do urodynamics on them. I make sure they're on a good voiding regimen. And if they need if they need to do overnight drainage or they have a tonic bladder, I put the Mitrofanoff before transplant. So everything is ready, and then they can go in there and have a much better outcome at the end. So this is another paper that we had done looking at graft survival, seeing that voiding dysfunction information was available, and that you know, when you looked at graft failure, bladder dysfunction was a little higher if they had bladder dysfunction. So really working on that is important. That's why I said I do the Mitrofanoff, start them on CAC, even vesicostomy. Oftentimes I do transplant straight into vesicostomy, leave the bladder open, and then close it and do vesicostomy when they're, Mitrofanoff when they're older, if they really need a transplant sooner. So we have no hesitation doing a transplant into a vesicostomy bladder. Keep the bladder safe, then you're going to improve graft survival. So I'm going to leave you with these last 4 points. How many high diversions have I done for valves, meaning ureterostomy or pilostomy? 0. Okay, I do vesicostomy or valve ablation. Usually just valve ablation and then monitor them. But if you have to, vesicostomy. Don't do high diversion. How many ureteral reimplants have I done? 0. It's not something you should do in posterior urethral valves. And I travel a lot. And I see many places they do heroic, excellent surgeons. And they do, you know, they go, oh, the child has so many UTIs, so we did it. No, that's going to cause bigger problems than managing the bladder. How many bladder augments have I done? None. Okay, I don't do bladder augmentations for valves. It's very rare. I shouldn't say none, maybe 1. A very unique situation. In general, again, manage the bladder, do Mitrofanoff, overnight bladder drainage, oxybutynin. But some people say Botox. I don't think Botox works very well in valve bladders. And how many bladder neck slings for incontinence? None. Okay, so these kids, you have to manage the bladder. It's not a problem that they're having leakage from, that they have some sort of pelvic floor dysfunction. They have a bladder problem. So I think these are common things that, you know, we have to always be thinking about when we think about valves. Think about the bladder as they get older. And if you manage the bladder well, your long term is going to be much better for these children. So, I think I'm going to stop there, and I'll be around for questions, you know, up to lunch. Feel free to find me, and happy to talk about it. But now we'll move on to other areas of besides pediatric urology. To me, it's the only thing that matters, but I know it's a lot more than that.
Thank you. Thank you. Yeah. Although we have a little time, we have let's have the group photo. So all speakers are. I invite all speakers to coming up front to the chair, and yeah, we have two group photos in front and behind. And we have after the group photo, we have the toilet break. cholesterol for the speaker of the UTI, urinary tract infection. Yeah, this is the. I'll give a brief introduction to her. She graduated from the University of California, San Diego, and she trained the University of Michigan and Harvard, and she is now working in the University of San Diego, right? And I heard about her. When I heard about her, she see the many kind of patient, and she even the poor on the so very wide spectrum of children, a wide spectrum of patient, and also see she has many she also dedicated in the educational program. So she is now the president of the recurrent urinary tract infection and other aspect of the UTI. Please.
Thank you.
Please give a big applause.
Thank you very much. So I changed the agenda a little bit so that we would have time for everything that we need to discuss. So in this talk, we're not only going to talk about recurrent urinary tract infections, we're also going to talk about genitourinary syndrome of menopause, which if you think about recurrent UTIs in women, that goes hand in hand. And we're also going to talk about fistulas and diverticula because they typically will present with infections as well. So first of all, let's think about the fact, and for those of you who were at my talk earlier this week, some of the slides are very similar, but the takeaway here is that this is a really common problem. And as urologists, we like to solve surgical problems, and this doesn't always tend to be a surgical problem. So at least for me, it can be frustrating, right, to have a full clinic of women with recurrent UTIs because I know that that's not going to utilize my surgical expertise, but you can make such a big difference in your patients, and if you're very smart, you can educate the doctors that refer to you. So some of this educational concepts today you can share with your medical colleagues. And you can also educate your nursing staff and even the patients so that they understand why these things happen, and that reduces the burden on you to be the one that's having to solve the issue. Really important as well is antibiotic stewardship, because we don't want to have more and more patients with resistant infections if we can avoid it. So we're going to go through some of the important updates to the guidelines, and I have a QR code here for those of you who want to read those guidelines. When you're studying, I think the AUA core curriculum is essential. It's very easy to read, and then the guidelines. Sometimes reading Campbell's can be a bit much, right? It's very long and a bit overwhelming, but those two things were developed for you to be able to learn those basic concepts and apply them. So that's a QR code for the guidelines. So we're going to talk about some of the updates to the guideline that I think are very important for you to know. So the first takeaway concept of today is urine is not sterile. The urine has a diverse microbial community residing within it. And through things like next generation sequencing, we actually know that sex, gender can impact the flora that are in our urine and our genitals. And as such, right now we don't really recommend things like a test of cure in patients with recurrent UTIs who don't have symptoms. And why is that important? If you look at, for example, the KUA guidelines from 2017, which is pretty recent, the test of cure is still recommended as something that can be helpful. As those guidelines are updated, you'll see that now we know that many patients are going to have bacteria in their urine, and that can actually be protective for them. So that is another takeaway. Clinicians should not treat asymptomatic bacteriuria. If you have a positive urine culture, but you don't have symptoms, you don't have a UTI. Next question, okay? Antibiotics and giving antibiotics to patients without symptoms don't improve outcomes. And in fact, we also know that asymptomatic bacteriuria can actually help prevent future infections. And it makes sense, right? Having flora within the urinary system probably helps protect the pathogenic bacteria from invading and causing issues, and that's going to be relevant for women who are in menopause. So let's learn, right, with one of our patients. This is a young woman. She has symptoms of urinary tract infection. She has a positive urinalysis with pyuria, comes back positive with E. coli. She's had this several times a year. She's been treated with antibiotics, but she experiences recurrent infections. She's tired of this cycle, this process, and she's asking you what she can do. And that's one of the next takeaways that we're going to discuss. What do we do for prevention? What can we do that's not giving antibiotics? This is a really nice algorithm, again, from the Asian Association of Urinary Tract Infection, another good resource to study about this concept, very testable. We see here that essential in the beginning is to perform a thorough history and physical examination. We'll see later on in the talk some of the findings within the physical examination that may reveal some issues predisposing to UTIs, but most of the time, the pelvic exam, totally normal. So it's not an anatomic problem, and often it's not a functional problem either. So that's different from what Dr. Shukla was mentioning in children, where you really have to suspect that there is a bladder issue when they're having infections. In adult women, not necessarily the case. So there are some genetic factors that make bladders more susceptible to UTIs. The pili and bacteria tend to be more adherent to certain urothelia. So, you know, it's important to remember that the physical exam may not harbor anything. You still have to do it because we're going to talk about other findings that may reveal that, but most patients are going to have a normal exam. So then they're having recurrent infections, the exam is normal, what do we do? The first inclination is to want to give antimicrobial prophylaxis, and we can do that. We could do it either post-coital, so after intercourse, or we could do continuous. And it's really important, next takeaway for you, is to understand the data behind it. So there have been many studies, most of them are older studies before 2007, but there are at least 28 trials that show us that if you use preventive antibiotics, it actually does make a difference, but there are a lot of adverse events. So that's the issue. Bacterial resistance is a reality. And nitrofurantoin, which is typically the antibiotic that is mostly studied, has to be used with caution. It has a risk of lung disease when you use it long term, another potentially testable question. And it's also contraindicated in patients with low creatinine clearance. In the United States, as I mentioned here in this slide, a lot of times our decisions about what antibiotics we give to patients have to do with what their insurance covers and what they can afford. In your country of origin, it may be a little different, but here you can see from the KUA guidelines the evidence-based antibiotics that are options to give during prophylaxis. And there are studies that look at fluoroquinolones like Cipro, levofloxacin, but in general, because of the side effects associated with them and the resistance patterns, it is not considered a first-line agent. So obviously, if you're answering a question, you can see correct answers highlighted here. So you talk to your patient, you mention the risks and benefits, the resistance, the side effects from the antibiotics, and she's like, I don't know, I want to hear about other things. I want to hear about other things that aren't antibiotics. So here we have different interventions that have been mentioned in the guidelines as being helpful to prevent infections. Cranberry supplements made it into the guidelines. Note that the studies looked at juice, and they also looked at cranberry supplements and tablets. Be very careful about giving patients a recommendation to drink cranberry juice, because most of the time it has a lot of sugar, and so that's not a great option. And then not all cranberry supplements are made alike. Some actually don't have very much of the active ingredient. So take that with a grain of salt. But there are trials that show, 8 trials to be precise, that there is a statistically significant clinical improvement in recurrence of infections with cranberry supplementation in women who experience recurrent UTIs but don't have any of the anatomic or functional problems. There's also increasing water consumption. Also be careful in patients who might have overactive bladder symptoms, and we'll talk about that later. Vaccination did not make it into the guidelines or probiotic use, but if you look at the KUA-UTI guidelines, that is included there, and there are some clinical trials suggesting that there's a benefit. But one takeaway about the vaccination is that it doesn't last. So you actually have to repeat it over time for it to be effective, which makes it very costly and burdensome. One thing that's very important that is not in the guidelines that is probably going to change is the use of methenamine. Methenamine is something that you certainly want to have in your toolkit. There was a recent ALTER study that showed that methenamine is not inferior to the current standard of care, which is preventive antibiotic, either postcoital or continuous, in preventing the recurrence of urinary tract infections. So my recommendation, it's not made it into the guidelines because this study was published in 2022, and that's when the guidelines came out. It will likely inform the next one, is that methenamine is associated with fewer adverse events and is not inferior to using antibiotics. So that has been a practice change for me. Instead of proceeding with antibiotics, I consider the use of methenamine because it has none of the adverse events associated with antibiotics, and there's a study that shows non-inferiority. So that's great news for patients who want to avoid antibiotics. So when we discussed with this patient that we mentioned, she actually chose to do antibiotics, macrodentin, after having sexual intercourse, and she did great for 25 years. Then at age 50, she starts having infections again. And then she comes back to the urologist and is like, what am I doing wrong? The infections are back. So now we're going to get into the next wave of our talk, which is genitourinary syndrome of menopause. Estrogen plays an essential role in the vaginal microbiome. It's very important. Vaginal epithelial cells secrete glycogen in response to estrogen stimulation, and in another slide we're going to talk about that even more. So estrogen is the foundation on which normal flora occupy the vaginal epithelium, and the bladder is also sensitive to it. If you want to read more about genitourinary syndrome of menopause, another QR code so that you can access a review article that was written. Note that there are no current guidelines for genitourinary syndrome of menopause, but they're coming. And so it's very likely that during your time training to be a urologist, that's going to be another guideline that will come up that you will want to learn. Low-dose vaginal estrogen is very safe to use. I'm going to skip this slide because I'm going to go more in depth into genitourinary syndrome of menopause, but one takeaway is that there are a lot of options. Now, in talking to many of you, I realized that in Korea, in Uzbekistan, and in some of the other countries for our colleagues that are here, there aren't a lot of available options for vaginal estrogen. And in fact, in the United States, sometimes none of these options work for my patients, and they report a lot of symptoms of irritation when they apply it. And so we actually have a compounding pharmacy make it especially for the patients. One glimmer of good news, though, that I will tell you is that during my walking around the exhibit hall, I ran into a generic compounding pharmacy who was here talking about the medications they produce, and they would be very interested in providing estradiol if there was a need or a desire from more urologists to prescribe it. So I think that if that is something that, as you all who are the future of urology here in Korea and adjacent countries are interested in providing more options for women, that there are going to be pharmacies that are really interested in collaborating with you to provide them. Okay, so treating infections is very expensive. That's another takeaway. If we don't treat the root cause of the problem, there are incredible costs associated with it, money-wise. So it's a big monetary cost, the healthcare system, a lot of money. It's going to take up space in your clinic because those patients will be sent to a urologist for a non-surgical problem, and that can be tough when you're trying to get patients in who need surgery. There's been a rapid increase in antimicrobial resistance, including enhanced extended spectrum beta-lactamase E. coli organisms. And then women who experience recurrent UTIs actually get more of them when they are overtreated with antibiotics. So it's kind of a self-perpetuating cycle. It's actually on the World Health Organization's top priorities, antibiotic stewardship, particularly for urinary infections. So everyone here will experience this problem in their clinics with patients, and it's important for us to take a stand on behalf of our patients. So just to underline those takeaways from the guidelines that are important, avoid antibiotic use in asymptomatic women, and as I emphasized down here in bold, there are a lot of preventive strategies that work, especially for younger women, but the most important takeaway is that if you have a postmenopausal woman with recurrent urinary tract infections, low-dose vaginal estrogen should be the first line of defense against those infections. So let's talk a little bit more about that. Menopause and postmenopause symptoms, at least in the United States, is starting to gather more attention. And I think around the world it'll happen. As you know, in Korea, you are approaching or have approached a super aging society. You have a lot of aunts, mothers, who are incredibly interesting in aging with grace and who do not want to be suffering from these problems. So patients are going to, as our populations get older, they're going to start to think about these things and they're going to want to have a solution. So it's important for us to be prepared. Genitourinary syndrome of menopause is a chronic and progressive disease, and it'll affect up to 50% of women. We don't exactly know why some women are affected more than others, but it is going to be an issue for at least 50% of them. The diagnosis can be made by physical exam, and we're going to go over that. Low-dose vaginal estrogen, again, is the most effective way to reduce symptoms. So you may have women who are not having infections, but who are having symptoms, urinary symptoms, painful pelvic symptoms. All of those are amenable to vaginal estrogen supplementation. And it is safe. For a long time, there was a fear about supplementing estrogen for women, and the reality is that it can be safe, even for women with a gynecologic or breast cancer history. And apologies for the misspelling. That drives me bananas. So whenever I have a typo, it's going to derail my whole train of thought because I hate it. But back to genitourinary syndrome of menopause, these symptoms, they can be urological or gynecological. It's this specialty that I'm a part of, urogynecology, female urology, pelvic reconstructive surgery, it's a shared specialty between urologists and gynecologists. But really, when the problems get really complex, guess who has to manage those problems? It is always going to be the urologist. So this is our lane. We have to be the ones who set the tone for how this needs to be treated. Previously, this was a syndrome described as vulvovaginal atrophy, but that doesn't really describe it as well. Genitourinary syndrome of menopause underscores that the problems are not just vaginal, they're also urinary. Can include dryness, burning, irritation, urgency, dysuria, infections, as we discussed. And there can also be sexual symptoms, loss of lubrication, dyspareunia, decreased libido, etc. I take care of a very unique population in the United States, mostly Spanish-speaking women. Many of them are from Mexico. And in Mexico, culturally, sometimes talking about vagina or sex or anything like that can be very embarrassing for women. I know in speaking with some of you, that is something that your patients also share. It's not a topic that they want to talk about, even, especially not with a male urologist. So it really is up to us to figure out ways to ask the question so that we can really help them. The other thing is, it's not just a menopause problem, or it's not just, ending your periods that can cause you to have menopause symptoms. So you kind of have to broaden the categories. So risk factors can be even for women who are not at the age where they would stop having periods. For example, there can be premature ovarian failure, women who have had their ovaries removed for cancer reasons, Postpartum, very common for a postpartum woman because of the prolactin, because of breastfeeding, to experience symptoms of atrophy that can be really uncomfortable for her, sometimes presenting with infections, but sometimes just presenting with pain, and that can be addressed as well. Patients who have chemotherapy or radiation, patients with lupus, rheumatoid arthritis, and other autoimmune conditions can also have low hormone levels. Patients who smoke, patients who abuse alcohol, and then all sorts of other conditions, and I will show you those in a few slides. So even though up to 50% of postmenopausal women can have these kinds of symptoms, really less than 10% of women will be prescribed vaginal hormone, and that's a shame. Such an easy intervention, very few contraindications, and can make a very, very big difference. The time to onset of improvement with vaginal estrogen is very similar to other hormonal treatments that we give. For example, finasteride. When you start to give it, you know that the prostate size reduction is going to take a few months. Similarly, with giving vaginal estrogen, the patients are not going to see the results right away. So it's really important to encourage them to stick with the supplementation for at least 6 months before they can see a benefit, and maybe starting them on something else that's preventive in the meantime so they don't get discouraged. So these are all factors you should consider in premenopausal women that can cause them to have genitourinary syndrome of menopause symptoms, even when they're not at an age where you would characteristically expect them to be undergoing menopause. And you can see there are systemic states that can induce it. There are pharmacological states, and in bold I put here, again, once those guidelines come out and we start to underscore how important it is for our urologists to understand this, use of oral contraceptives, which is very common in younger women, can bring on these genitourinary syndrome of menopause symptoms. So that is important to include in your history taking if you have a young woman with recurrent UTI symptoms for unexplained reasons. And then there can be iatrogenic reasons. Post-radiation and chemotherapy are very common ones. So the symptoms arise from a decrease in circulating estrogens and androgens. So this is another news flash that I actually learned not when I was a resident, but actually when I was already in attending, very late in the game. And it's that the microarchitecture of the genitourinary tract is maintained by hormones, and the most common hormone after menopause is not estrogen. It's actually dehydroepiandrosterone, and that DHEA for short. DHEA is the highest circulating hormone in the vaginal area, and there is actually a way to give and supplement DHEA to women. Much less research has been done on this. There is an FDA-approved suppository that can be given. I do not know if that is available for use in Korea, but it is a part of the guidelines. So my assumption is that it is available. So that is another thing to keep in mind, particularly in patients who also, in addition to the symptoms that affect the bladder or the urethra, also have sexually uncomfortable symptoms like painful intercourse, for example. Age-related decline in hormones has great impact on the genitourinary system. Estrogen is essential. So how does that work? Firstly, estrogen stimulates the vaginal epithelial cells to produce something very important called glycogen. Glycogen is the building block of vaginal lubrication, and it is also the main nutrient for lactobacilli. So those cells produce that glycogen, and then the lactobacilli, which are even in menopause always present in small numbers, numbers greatly reduced, that's part of the issue, but even in those greatly reduced numbers, they will convert that glycogen into lactic acid. What lactic acid does, it's an acid, so it lowers the vaginal pH, and that is where the vagina likes to be, in an acidic pH. So when the pH is acidic in the vagina, that then stimulates other commensal organisms and bacteria to colonize the area, and it makes it much more difficult for pathogenic organisms like E. coli, Proteus, Klebsiella to colonize the vagina and subsequently potentially cause infection. So the urethra and bladder, in addition to that, the urethra and bladder have estrogen receptors, and they play a really important role in maintaining a healthy urothelium. And if evolution didn't want to kind of kick us in the you know what, the process of losing estrogen actually makes the nerve fibers in the vagina, the urethra, the bladder proliferate even further. So that's why a lot of patients may start to experience more noxious vaginal and bladder stimuli after menopause. It's because there's a proliferation of nerve endings in the area stimulated by a lack of estrogen. It's like almost like they're roots of a tree searching for water. And I always tell my patients, you know, estrogen is to the vagina and bladder and urethra like water is to a plant. It's an essential part of a healthy environment there. So when those estrogen levels are reduced, there's a reduction in collagen in the trigone area of the bladder and thinning of the urethral mucosa. That's why a lot of women post-menopause can have urethral caruncles, which is an outpouching of the urethral mucosa that can bleed and be very uncomfortable. So to diagnose genitourinary syndrome of menopause, this is a primarily clinical diagnosis. It's based on history, what the patient is describing, and we went over the symptoms, and also by physical examination. Patients will tend to feel embarrassed about this, as is very natural. So having a conversation about this is usually best if the patient is dressed so that you can have a conversation. Sometimes even that day will not be possible to do the exam that you need to do. Sometimes it's just an educational visit, and the patient can come back later when they're a bit more prepared to address the issues. A complete history will also include that sexual history because, as I mentioned previously, many of the symptoms will be sexual in nature in addition to the urinary symptoms, and that can help you pinpoint, oh, this may be genitourinary syndrome of menopause. I guarantee here every single urologist in this room has many patients that are reporting these symptoms. You can see the urinary symptoms here, frequency, urgency. It kind of sounds like interstitial cystitis, kind of sounds like overactive bladder, and I bet you a lot of patients you think have interstitial cystitis might actually have GSM, including recurrent infections. But there are also gynecologic symptoms. And decrease in vaginal moisture, loss of the vaginal rugae, some sexual concerns. And then we can see here in one of my patients a very sad and extreme case of vulvovaginal atrophy or genitourinary syndrome of menopause. And I will tell you, this patient was 40 years old. So not in the age group that you would expect to have these symptoms, but it was mostly due to iatrogenic reasons because she had had breast cancer and was on an estrogen receptor blocker. It's very important to consider those things. So the visual examination offers most of the diagnosis. So I'm going to show you real quick some of the things that we look for on the exam. Obviously, we want to do a sensory examination. Often with a Q-tip test, if you touch the area of the introitus or next to the urethra in the vestibule, that can be extremely painful and uncomfortable and actually mimic some of the symptoms of urgency, dysuria that patients experience. Another thing that can just tell you visually how well estrogenized your patient is the length of her labia. You can see me there measuring the labial length. That actually tells you how well estrogenized they can be. So when you have menopausal atrophy, the labia will reduce in size and actually sometimes fuse. So you have fusion between the labia majora and labia minora, and that can also help diagnose the symptoms. As with the evaluation of most pelvic floor disorders, you also want to make sure there's no pelvic organ prolapse, look at pelvic floor muscle tone, look at the vaginal discharge. Sometimes there can be dysbiosis and bacterial vaginosis as well, and you want to look at the rugae also. I'm going to fast forward because I have some other videos and I want to make sure we get through everything. The main purpose of treatment of GSM is to relieve the symptoms in the vagina, restore the pH because lactobacilli like to proliferate in an acidic pH, and prevent recurrence of urinary tract infections, and low-dose vaginal estrogen is the mainstay of that, and you can see the different formulations with which you can get this. What is the data behind it? So there have been several systematic reviews of vaginal estrogen therapy, and they've revealed improvements in these parameters: the symptoms of vaginal dryness, sexual discomfort, urogenital symptoms, including dysuria, urgency, and frequency, thickness of the vaginal tissue, increased lactobacillus proliferation in the vagina, and decrease of the vaginal pH. The urogenital symptoms in particular, I think, is what is most surprising sometimes to us, because we're so used to prescribing anticholinergics, beta agonists, Botox, sacral nerve stimulation in countries where it is approved. But estrogen can be very helpful for that too, for women who have low vaginal estrogen. Studies of the effectiveness of vaginal estrogen show that improvements occur in approximately 90% of women who use the medication. So it's very effective. There have been 19 efficacy trials that have shown that all products, whether it's a tablet, whether it's a cream, whether it's a ring, they all work similarly. I have a bias towards the cream because I think it's easier to get the estrogen to the area of the vaginal vestibule where it's most important for it to be. But the reality is that the data hasn't shown that one is better than the other. Certainly, vaginal estrogen is superior to oral estrogen. And when we talk about giving women estrogen for GSM, we're not talking about estrogen pills. We're talking about vaginal estrogen, low-dose vaginal estrogen, which is 0.5 to 1 gram of estradiol 2 or 3 times a week. That is the typical dose. So for urologists, there have been several trials that have shown a reduction in the incidence of recurrent urinary tract infections, and the main benefits, as we discussed, is that it restores the urobiome, it decreases the vaginal pH, and it reduces dysbiosis by restoring adequate levels of lactobacilli and other protective vaginal flora. Sometimes those protective vaginal flora are actually the coliforms that we fear. As we know, not all strains of E. coli are pathogenic. Many people are colonized, and it is safe for them. But the reality is that estrogen helps stimulate an environment where those commensal bacteria can grow. All right, vaginal estrogen also improves lower urinary tract symptoms by directly affecting vaginal innervation, as we discussed. That it will reduce the innervation in the area and make women have more comfortable with their symptoms. And there's minimal systemic absorption. But here's the reality. When women first start vaginal estrogen, that vaginal tissue is very thin. And so it is very likely that in those first few weeks of starting supplemental estrogen, they may experience these side effects. And it's really important for when you do any sort of test as a urologist, or when you're talking to a patient, really essential to always counsel patients on risks and benefits. So if you have to take an oral board exam or you have to take an examination, always remember before you're intervening and you say, oh, I know the right answer, this is what I'm going to do, always remember that before that decision, the risk-benefit discussion has to be had with the patient so that you can make the right decision, and they are on board with that decision, and they are comfortable and knowledgeable of those risks. So these are some of the side effects associated with it, and sadly, sometimes these side effects are so bad for women that they don't want to continue the vaginal estrogen, and that is why often I will rely on a special pharmacy who will make the estrogen cream in a water-based solution so that it's less caustic to the patient. Not sure if that will be available to you, but at least informing the patient that initially as they started there can be some burning can help them not discontinue the medication. So here are some precautions. Firstly, and very important, there is no correlation between low-dose vaginal estrogen use and the risk of developing breast cancer. That's a very big item that comes up for women all the time. They get very concerned about that. And there's sufficient data to support low-dose estrogen that the American Menopause Society recommends it universally for women who are in menopause. So it is very reasonable for you to recommend it for any women who present to your clinic with these types of symptoms if they have the findings to support having that diagnosis. This is that medication I mentioned, the DHEA. Its name is prasterone, and there have been some non-randomized studies that demonstrate effectiveness for urinary tract infections. There isn't as much data for DHEA or prasterone as there is for estrogen, but as time goes on and there's more data, it may actually be more beneficial because that is the predominant hormone after menopause in the vagina. This is the algorithm for treatment for patients who have GSM symptoms. So first line obviously will be low-dose vaginal estrogen, but there are some alternatives, the prasterone that we discussed, which is a DHEA. Ospemifene is a selective estrogen receptor modulator, and it's an oral medication. Not something that I try to do first line, but like I said, some women just don't like the feeling of applying the cream or the tablet or the ring vaginally, and the only option that's available is to use this receptor modulator. Testosterone has some benefits as well, and in the United States, some urologists will also use laser treatment. I don't think that the results of the laser treatment have shown that they last long enough for it to be something that I particularly recommend, and they are not a part of the recurrent UTI or GSM guidelines, but they are part of the armamentarium for women who might not be able to use estrogen otherwise. For example, someone who has metastatic or active breast cancer who absolutely cannot have estrogen, that may be an option for them. But sometimes, just to switch gears a little bit, sometimes there's a surprise. This is not the most common thing. The most common thing is what we just discussed. But sometimes you do that physical exam, which again is you have to include anytime you're asked what you would do to manage a patient who has pelvic floor symptoms or UTI symptoms. You get a post-void residual urine volume, you get a urinalysis, and you take a history and physical. That should be automatic. Every question you're asked, that has to be included. Sometimes we'll see these little surprises. So let's talk a little bit about those. When you have a patient who presents with a vaginal lump or a vaginal mass, or someone who's referred to your clinic to rule out a urethral diverticulum, there are so many different things that can be. For example, if you look, let's go back one. I still wanted to show that one. Okay. So if you look at this case, you would say, this looks really thickened. It's abutting the urethra. It's so close. That must be a diverticulum. This was actually a Skene's gland cyst, which is incredibly close to the urethra as well. They can be very large. And sometimes it's really impossible to distinguish them until you either get imaging studies, MRI is a frequently obtained study, or you do a cystoscopy to look for ostia. So you have to have a really wide differential of what it could be and kind of be prepared to determine what it might be and to understand the decision-making that has to take place when you do this. Here I included, what the diagnosis would be, the location, and then what the treatment might be like. Urethral diverticula are interesting because my preference usually is to encourage patients to consider removing them, because I have had 2 patients in which inside the diverticula I found one low-grade and one higher-grade urethral carcinoma. So that's typically something I advise patients. But if it doesn't bother the patient and the cystoscopy or the MRI look pretty normal, you can't observe it until they have symptoms. But that's something to know. As you can see, there's also the urethral mucosal prolapse, which is also known as similar to the urethral caruncle. And that can be very uncomfortable and also require surgical excision. So it's important to have this wide differential when you see these lesions. So this patient who presented with that mass, she desires to have it excised. She doesn't want to see it. Often patients will complain that it deviates their urinary stream, so it's impossible for them to have the urine land in the toilet and it splashes everywhere. That's a very common symptom. So when you are counseling patients on treatments, either surgery, medication, et cetera, for their pelvic floor problem, whatever it might be, counseling about risks and side effects is extremely important. So if you're taking, for example, an oral boards in your urology certification, or you are getting tested by your faculty, you need to show that you understand the risks of every intervention that you make that could potentially cause harm to the patient. So these are some of the risks of excising some of those lesions. You can see the risks are incredibly low, but they can include recurrence of a diverticulum if they have it. It can include incontinence, in some series more than 10%. And then stricture can also be a risk. So very important to counsel on that. So let's look at a video on case presentation. So this is a 39-year-old woman who presents with those symptoms. And this is the exam findings. We're going to look at them shortly. So this is the MRI. You can see like a horseshoe-shaped diverticulum, which is very, very large. That's another takeaway point. Here's the cystoscopy that's showing you this big cavern. That is actually within the ostia of the diverticulum, and you can see it all around. Very shortly, you're going to see me turn the cystoscope upwards, and you'll be able to see that's actually the urethra. So that's a pretty big diverticulum, but as you could see on the MRI, I'm not seeing the horseshoe that's going around the urethra. So that's why sometimes MRI can be helpful if you have a big lesion. So here, sometimes palpating the anterior vaginal wall, you can see some fluid being expressed from the urethra, but not always. And that can be uncomfortable for the patient too, so may not be something you want to do in the clinic. An inverted U-shaped incision with hydrodissection can be really great so that you can develop a really nice, thick vaginal flap that's well vascularized. Very important in women, that, like we talked about, who have vaginal atrophy. This woman is young, she's 39, but with women who are postmenopausal, the vagina can be really thin. And so you want to make sure that your flap is nice and thick, and you can see here excising the pubocervical fascia in order to remove the diverticulum. And I'm going to move ahead because the principles of the case really are here in this area. Some people will put a small Fogarty or Foley catheter in big diverticula to kind of identify them. You can do that with a cysto. Other people open the diverticulum and paint it with marker so that they can follow where they painted and make sure they remove all of it. So there's different strategies, different approaches. The important thing is to make sure that, number one, you close the urethra watertight, and also that if this patient develops incontinence later, that you do not use synthetic materials, because that is a urethra that will not heal well from a synthetic material if they've had previous diverticulum surgery. And may develop what we're going to talk about now. This is a different patient now, again presents to you with recurrent UTI symptoms and persistent urinary incontinence after hysterectomy. And these are the additional symptoms that patients report with this diagnosis. And I already told you what we were going to talk about, so you kind of already know. But the constant urinary drainage per vagina is a huge one. Like Dr. Shukla mentioned, ectopic ureters, high on the differential in children, not as high in women. That if there's any suspicion for something iatrogenic or oncologic or post-obstetrical, that the fistula diagnosis is higher on the differential. And these are some additional symptoms that patients can present with. Just as a tip, if a patient is complaining of constant urinary drainage after a hysterectomy, like our patient in this scenario, typically those fistulas are very high in the apex of the vagina, near the vaginal cuff. That is typically where the injury occurs, and also higher index of suspicion, always when evaluating for fistulas, for ureteral fistulas. You can miss them. And so it's very important to do a cystoscopy and some imaging, either a retrograde, CT urogram, et cetera, to make sure that concomitantly you don't have a ureteral fistula as well. I've seen those missed many times. So these are different etiologies for urinary fistula. In Korea, as in the United States, it's really common for them to be iatrogenic, not as much for obstructed labor or obstetric trauma. There are still some countries in the world where that is not the case, where obstetrical trauma is the most common. But here, as in the United States, it's mostly iatrogenic. We are the ones who are responsible for them. And it can also be a very devastating long-term consequence of radiation. One of my students is actually working on a project where he's looking at the long-term sequela of cervical radiation for cervical cancer, and by far the most common devastating complication was development of a fistula in a very delayed fashion, decades after the initial radiation. These are the different types of fistulas that can occur, and they all present a little differently, right? For example, a vesicouterine fistula, you may not see that constant vaginal drainage. They may actually have pyometria or endometritis. But for the vesicovaginal fistulas, you would see more of that constant urinary drainage. And I also included rectovaginal fistulas because that is also commonly sent to the urologist, and the principles of repair of those are pretty similar. I always tell my residents as well that all of you probably are going to be really good surgeons. That is, we as urologists, we always tend to be very good surgeons. We get a lot of operative experience. But struggling in the operating room isn't as much having to do with if you can tie the best knot or if you're a whiz on the robot. It really has to do with the decisions that you made, the questions that you asked, and how you examined your patient. And so the success is determined before the operating room, and there's no single approach to fixing a fistula that I can tell you applies to all situations. But what I can tell you is what's going to be a simple fistula versus a complex fistula. So if a fistula is small, supratrigonal, so not involving the trigone, which makes it much difficult. The patient has not been radiated. If they have a normal vaginal length, their tissue is healthy and well estrogenized, and you have good access to it, probably very amenable to a transvaginal repair and a successful repair. A complex fistula will be large. It may involve the trigone, so you have to start thinking about stenting and how it's going to affect your ureteral drainage. If they've had a history of radiation, you may have to start thinking about flaps, either a Marcius or even a gracilis or a vaginal flap. If they have a shortened vagina, that can be an issue because your repair may shorten their vagina further, so then you have to talk to them about sexual function and how you're going to help them manage that. If they've had a previous repair by someone and it failed, that's going to make it harder. And if it's associated with a ureteral fistula or with a rectum, that's also going to add some complexity to your repair. These are different ways that you can detect a fistula. I think this is something you can kind of look at later to determine what your favorite way to do it. I use any of these. It really depends on the patient. If I think a patient is not going to tolerate a physical exam because they've had radiation and I don't want to hurt them in clinic, I might say, hey, let's go for an exam under anesthesia. And that way I can really calmly find out where it is, do a retrograde, do all of my exam. Sometimes just a VCUG, cystography, will show it to me, will show the drainage into the vagina. An IVP may show you a ureteral vaginal fistula. So there's different ways to diagnose the fistula. You should know all of them so that you have a wide toolkit that you can use. You can also give the patient a dye like peridium and do a tampon test and see, does the peridium stain the tampon pre-voiding? Then you have your diagnosis, did not order any expensive tests. So there are many options. And these are some of the principles of surgical repair. So you want to expose the fistula tract, you want to debride the devitalized tissue, you want to send it for pathology, especially in patients who have a cancer history. Any foreign body or synthetic materials that are associated with that fistula should be removed, like, for example, synthetic mesh. You want to dissect carefully and separate the organ cavities. So, for example, if you have a vesicovaginal fistula, separating those two planes so that you can close them in different directions will help in your repair. You want to have a watertight closure. You want, if you need to, have some healthy flaps. So I have learned to do many flaps across my career, but often will bring the plastic surgeons with me to do a nice, healthy gracilis flap to place, particularly in radiated fistulas. As many layers as you can get safely will be really helpful. Don't overlap your suture lines. And then stenting or drainage to allow that area to heal so the bladder doesn't cycle and put your repair under distress. And then obviously, let's go back one. Keep clicking. And in patients, I'm going to present to you a nightmare case, but I just want you to see how decision-making before a surgery can actually make you successful, and you don't have to be, Dr. Shukla or Dr. Amling to do a very good job for your patient. You just have to be prepared. You have to prepare ahead of time. And then hemostasis, as we've all learned. So let's look at the application of these concepts with a very difficult case that I had to perform with my residents. This was a few months ago. You can see it took a village from start to finish, and we're perfectly on time. The video is about 10 minutes. It does use sound, if we can turn the sound up. And this is one of my residents narrating the case for you.
During this surgery, prompt identification and repair can help mitigate risk of adverse long-term sequelae. Our patient is a 35-year-old with a history of 3 prior cesareans who presented to an outside hospital for her scheduled C-section and tubal ligation. Intraoperative events were notable for a hemorrhage requiring transfusions, placement of a Bakri balloon, and she was transferred to the SICU for monitoring.
When the obstetricians are placing Bakri balloons, it's bad.
Which was complicated by multiple bladder cystotomies. Urology was consulted intra-op for repair of a large dome cystotomy and partial repair of another cystotomy on the posterior wall, given extremely friable tissue. Given
This was a
suboptimal
case
repair,
at
bilateral
another
PCs were
hospital.
placed with drainage.
So a
Postoperative
friend of
course
mine
was
had to
complicated
take
by
care of the
hemolytic
patient
uremic
initially
syndrome,
and then
acute
sent her
renal
to
and
me.
respiratory failure,
And that will happen a
anterior
lot to
abdominal
you.
wall abscess, and a
Someone else will
prolonged
attempt to
hospital stay.
repair, and then you're
6 weeks
called
postpartum,
to
she
help with
presented
that,
to
and
our
that can make it
hospital
even
and a
more
C2
challenging, and you
pelvis
have to be
showed an
ready.
abscess communicating with the bladder. The bladder was irregular in appearance and not well defined. There was also a fistulous tract noted between the bladder and the vagina. IR drainage was done, and the subsequent CT cystogram showed contrast extending from the bladder dome defect into the pelvic collection and also tracked into the vagina.
Another
Patient was
really
admitted for
common
IV
teaching
antibiotics
point
given
that
consent to
I was
sepsis. We
taught
then
that
performed
doesn't
an
apply in
exam
every
under
case is that
cystoscopy,
if you have a
bilateral
case
retrograde
like this,
pyelograms,
you want to
and
wait
found a
3
vesicovaginal
months for the
fistula,
infection to
defect
cool
at the bottom
down,
of the
but
bladder.
sometimes the
The
patients
right
keep
distal
coming back
ureteral injury,
with
and
infections.
were unable to locate
They're
the
not going to
left
get the
ureteral
3 months
orifice.
to cool down, and you have to
Given no
address it.
clinical improvement in readmissions related to persistent urinary leak, plan was made for surgical intervention. We consulted IR to place anterograde stents, and she was consented for the following surgery.
These cases, 6 weeks out from the initial
On
injury,
abdominal
look at
entry,
all of
dense
this
adhesions were noted
adhesive
involving
disease.
small bowel and omentum,
Stents
which
are
limited
your best
visualization of
friend
the pelvis.
because it's going to be almost impossible for you to find those ureters
Careful adhesiolisis was performed
without
along
them.
the anterior abdominal wall. Multiple loops of small bowel were involved.
And in my practice, I do just as much open as I do robotic surgery. This case, the patient was aware that I might have to convert to open, and I was very well prepared for that. We were lucky that we didn't have to
Note
do
the
it,
upward movement
but it's
towards the
important to
anterior
always be
abdominal
ready.
wall to ascertain the plane of dissection. This portion of the
See, the
case was
tissue's
challenging
very
and
friable,
lasted for over
bleeds
2
very
hours.
easily, super stuck. This took a long time.
As the dissection was advanced, the cephalad border of the phlegmon was then visualized. Vaginal exam was done to help determine the planes of dissection.
So the vaginal retractors can be super helpful because in cases like this, you don't have tactile feedback because you're on the robot.
Here you can see us
And
dissect
you
out the
need to
borders of the
identify those
phlegmon.
planes, and having a bedside assistant place a vaginal retractor can help you. And here you can see so much
Large amounts of
phlegmon
necrotic
there.
tissue
That's
was
why we like to
encountered
wait
and suctioned
a few
out.
months for that to calm down, but sometimes you just can't. And for those of us that do pelvic reconstructive surgery, and you know, pediatric urologists are included, a lot of times the reconstructive field has been operated on multiple times, so you have to work
Eventually,
with
the bladder
an
cavity was
area that
visualized
doesn't
underneath the
necessarily
necrotic
look as
tissue.
pretty as
A
you
large
want
portion of
it
the
to.
bladder dome and posterior wall was affected.
So knowing
and
your
had to be
anatomy is
excised.
essential. More of this necrotic tissue that we had to excise. So you can see the Foley, the entire dome of the bladder is gone because of that initial hysterectomy
Vaginal
and
exam was done
injury.
again to identify the vesicovaginal plane.
So now we're starting to see something that looks
During
like
this dissection,
bladder and
the
vagina.
vesicovaginal
You can
fistula
see the
was
fistula
identified.
there.
A Brysky retractor was placed in the vagina for traction.
And see how that retractor really helps you identify what's vagina and what's bladder so that you can
The
spare it.
vesicovaginal plane was then developed. For tension-free repair of the cystotomy, the anterior wall was also mobilized by dissecting into the retropubic space.
One thing that you'll also see me do in this case that is not in the guidelines, but I've found to be helpful, is injecting Botox to the bladder to help with bladder capacity, because one of the things when
Note
you
how the
counsel
stent helped in
patients,
identifying
when you
the
do
right
these
ureter.
big fistula repairs, is that they're going to lose bladder capacity and have a lot of urgency and frequency afterwards, so you want to be able to help them with that.
With further dissection, the right ureteral injury was identified. Formal ureteral reimplantation
See
was
how
not
we found the
performed,
stent
given that
almost
the
by
ureter was in
accident. So
continuity
it's,
with itself, and
again,
given the loss of
essential to-
overall
to
bladder
use
capacity
that as
with
your
the large
tool.
cystotomy. The right ureter was then repaired with a total of 3 layers. The edges of the bladder were refreshed until healthy tissue was
And
noted.
again, this is one of the
Given
other
the loss of bladder
concepts
capacity,
about
100 units of
ensuring
Botox
adequate
injections were
closure of
performed
your
throughout the
fistula,
bladder.
which is to make sure you debride
cystotomy
all
was
of
then
the
repaired in
edges and you
multiple
have fresh
layers.
edges to reoppose. And you can choose to interrupt your anastomosis, so you can choose to run it. That hasn't been shown to make a difference, but what is important is for it to be watertight, the suture lines to not overlap, and if you can, use some form of interposition to healthy tissue to allow that area to heal.
An omental flap was then
So you can
mobilized
see
to
us
overlay the
here
repair site.
developing an omental flap. Sometimes you have a lot of omentum to work with. This patient had very little, but all we needed was for a little bit of it to overlay in the area.
Given the extent of repair, a
And then you
peritoneal
also
flap
have
was also
peritoneum,
mobilized.
which is a flap that urologists will very frequently use as well to
Edges of
bring
the vesicovaginal
over
fistula were then refreshed
the other
and was
suture
repaired in
line
the
and
layers.
make sure that they don't overlap. This is, again, the vagina, refreshing the edges so that it heals nicely. And much like an open surgery, your first layer you can run, and then you can imbricate using a Lambert type layer to have another layer of closure. Particularly important when you're dealing with a case that started off as infected. You want to make sure that you have multiple layers to aid you in getting that patient to heal. You can see the two flaps there.
Post-op, the patient did well and was discharged home on post-op day 7 with indwelling PCNs.
And the last concept of the fistula repair that we reviewed is to maintain drainage for the bladder. Leave a drain, leave a Foley catheter, keep those stents, allow the patient to heal,
4 weeks post-op,
and then remove sequentially so that you can ensure that it heals nicely.
Ultrasound was noted and her PCNs were then removed. At her 8-week post-op visit, patient was doing very well and will continue to follow up for repeat Botox injections.
She never actually needed any more Botox.
The
she
main
did
learning
really well.
points of our video are: early identification of GU injuries is of paramount importance. Preoperative workup in the form of examiner anesthesia and imaging help in surgical planning. The ultimate timing of repair is dictated by the overall clinical picture. Placement of anterograde ureteral stents by interventional radiology can be helpful. Intravesical Botox injections can help overcome loss of bladder capacity. And one could plan for open surgery, but always consider starting with a minimally invasive approach. Lastly, collaboration and teamwork makes the dream work.
All right. All right, well, that's the end of this first lecture. Thank you so much for sticking around and listening to it. As I mentioned before, I practice here in California right at the border here with Mexico. But I'm originally from Puerto Rico, which is an island in the Caribbean, very small. It's probably about a fifth of the size of South Korea. And hopefully I can see many of you at the AUA in San Antonio. Thank you.
Yeah, thank you for your excellent and comprehensive lecture, and also I appreciate your effort to include your Korean letter in your slide. Yeah, I'm very amazed. Yeah. Yeah. We are for short of time. Then I invite Dr. Christopher Amning for the oncology lecture. Yeah, he now his role for the prostate cancer. Yeah, it's a brief introduction for him. He graduated from the University of Oregon, and he completed his residency in Duke, and he's now working as the professor and chairman in Oregon University, and he is now the director of the robotic surgery system. Yeah.
Great. Thanks. Thank you for the introduction, and it's a great honor to be here. It's nice to see so many of you here today. I know that our trainees, our residents, really enjoy these review courses because it really prepares them for their tests, but also just general knowledge of urology. So glad to see so many of you show up. And again, a pleasure for me to be able to do this. It's hard to talk about prostate cancer in an hour. I'm going to try to be a little short of an hour to get us a little bit back on time if I can. But it's hard to talk about prostate cancer now. There's so much to talk about and so much going on, so many new things developing that it's difficult. But I'm going to give it a shot. I want to acknowledge Kristen Scarpato. She's at Vanderbilt. Many of the slides that I'm showing today, she created. I modified many of them and added my own, but she created many of the slides that you're going to see today. Resource is really important. I think you all have the access to guidelines, the AUA guidelines. These are really, really important to review. I've been fortunate to be on the exam committee, and now I'm on the American Board of Urology, and we write questions for examinations. And one of the things that we really look at is our guideline statements to draw these questions from. So really important to know the guidelines. And then very importantly, the core curriculum, really a great source for everything that you need to know, really. And so reviewing the core curriculum is really important, too, to do well on your examinations. So the outline today to try to cover what we're going to cover, first about epidemiology and risk factors for prostate cancer. Then we'll go into talk about screening and diagnoses. We'll talk about treatment, surveillance, active surveillance, radiation, surgery, talk about androgen deprivation therapy, talk a little bit about treatment failure and recurrence following treatment, and then touch on advanced prostate cancer as well, an area that's really advanced a lot with new medications over the last 5 to 10 years. So a lot of excitement going on in that space as well. Epidemiology. So globally, in 2012 at least, 1.1 million new cases in 2012. Second most frequently diagnosed cancer worldwide, and the most frequently diagnosed in more developed countries. And you can see that here on the graph on the right, how the more developed countries have a higher incidence of, or detection incidence, however you want to describe it, of prostate cancer. And it's the 5th leading cause of cancer death worldwide. Now you can see that I think Korea would be Eastern Asia. It's down the list here away. I can't remember where it is. Way down the list actually here in terms of the incidence and the mortality of prostate cancer compared to some of the Western countries. What about Korea? I just dug into some of the data to just try to get a sense for the epidemiology of prostate cancer in Korea itself. And in 2023, it's estimated that there'll be 22,000 or so new cases and 2,400 prostate cancer deaths. It's the most commonly diagnosed cancer in men in Korea, just like men in America. But it's down the list of ways in terms of causing cancer death behind a lot of other cancers, liver, lung, colon, pancreas, stomach, gallbladder. So difference in terms of the cause of death, similar in terms of very, very high incidence. In the United States, prostate cancer is the most diagnosed prostate cancer, and it's the 2nd leading cause of prostate cancer death. And it's been that way for quite some time. Lung cancer leads the charge in terms of death rates for cancer. And then colon and rectum is pretty close actually to prostate cancer, but not quite there in terms of the number of men who succumb to that disease. Think about this, 1 in 8 men are diagnosed with prostate cancer. The mean age of diagnosis is 66 years. 2.4% of men in the United States die from prostate cancer. So very prevalent, not insignificant. I think often there's the assumption that prostate cancer is an insignificant cancer that doesn't even need to be looked for or screened for or dealt with at all. And this continues to suggest that it's a very important cancer, has a dramatic impact on cancer death in our country. Reviewing the incidence and the mortality trends is also interesting. You can see this incidence of prostate cancer that peaked in the early 1990s because of PSA being available. So you can see the prostate cancer incidence dramatically increases because of the availability of a screening blood test. So we diagnose more and more prostate cancer. And you can see that there's a spike then, and then it's sort of gone down over time in a jagged way up until 2019. If you look at mortality from prostate cancer, you can see that this red line is lung cancer, and you can see this peaked and actually is dropping significantly since 1990. This is the prostate cancer trend, and so again, the early 90s or mid 90s, along with the increased incidence, we're seeing a high sort of this increasing mortality from prostate cancer, but then following introduction of PSA and screening, there seems to be an improved treatment. It's not all about screening, it's improvements in treatment that we're able to provide, but this trend in mortality is continuing to trend downward since the early 90s for prostate cancer. Now, what are the risk factors? I think we'll all accept the ones on the left. Age, of course, is a risk factor for prostate cancer, and ethnicity. Black or African American men have at least twice the chance of dying from prostate cancer, and a much higher incidence of acquiring prostate cancer as well. Family history is important. If you have a first-degree relative, male relative with prostate cancer, your risk is about twice as high as if you didn't have that first-degree relative. And if you have 2 first-degree relatives with prostate cancer, your risk of developing prostate cancer is about 4 times as high. Now, what other risk factors might be in play? Some have talked a lot about inflammation. There hasn't been any direct correlation between prostatitis, for example, a prostate infection, and the development of prostate cancer. That link does not exist. Some have pointed at smoking, particularly in the case of prostate cancer recurrence, perhaps, but again, kind of a weaker link there. And obesity, I think the link is pretty strong in terms of obesity and its relationship to the development of higher risk prostate cancer. Not prostate cancer in general, but for development of higher risk prostate cancer. That means higher grade disease, which therefore is associated with higher treatment failures and rates of recurrence and also mortality. What about staging and diagnosis? Well, let's first talk about diagnosis with PSA. I'm sure you're all familiar with PSA, but it's a glycoprotein. It's produced by prostate epithelial cells. It's really important to note that it's not produced by prostate cancer epithelial cells. It's produced by prostate epithelial cells. So it comes from all the cells of the prostate, which is why it's not specific for prostate cancer when it's elevated. What happens is the disruption of the glandular architecture of the gland and the loss of the basal cell layer of these glands allows the leaching of PSA into the bloodstream, and that's how we detect it. And that's how the PSA increases in prostate cancers, because of this breakdown in the architecture of the glands, which allows the PSA to enter the bloodstream. Interestingly, prostate cancer cells make less PSA than normal cells. If you actually do immunohistochemical staining and you look at normal cells make more PSA than prostate cancer cells, but prostate cancer leaches more PSA into the serum. Other things also cause elevation of PSA, as we know. Inflammation, infection can result in an increase in PSA. So again, emphasize that it's a marker for prostate disease, but not necessarily a marker for prostate cancer, as other things can be associated with an elevated PSA. And again, we talked about this earlier, but I was a resident in urology between 1990 and 1996. And this was just the start of when PSA was becoming available. I remember when we used prostatic acid phosphatase as the marker, much less sensitive and specific marker, and then PSA became available right in the middle of my residency training. And so I was sort of involved in this evolution of which marker do we test, and we really relied on PSA at that time. I thought it was a huge breakthrough in the ability to early detect prostate cancer, which it has been. Now, does screening make a difference? Well, there's been some randomized trials with a lot of the design of these trials are not optimal, and there's some issues with some of these trials. But the PCLO trial, the ERSPC, the PCLO trial was an American trial. No difference in prostate cancer mortality with yearly PSA testing. I'll talk a little bit about that here in the next few slides. The ERSPC was a European trial, multi-center, multi-country trial, which did show a significant survival benefit from regular prostate cancer screening. And then the CAP, or the cluster, quote, cluster trial, showing no difference in mortality if you just did a single PSA test. So that was the point of that particular trial. It was just men were invited in the UK to come in and have a single PSA test, and then looking at the long-term outcomes. And there was no difference in mortality by just getting a single PSA test rather than a series of PSAs or monitoring PSAs over time. This is the PCLO data, and the problem with this trial is what we refer to as contamination, meaning that if you're going to have the perfect randomized trial and to assess screening, you're going to have one group that gets screened and the other group that does not get screened. But if most of the people in the group that are not supposed to get screened do get screened, then it sort of messes up the conclusions of the trial. And you can see here that the screening group had a higher chance of developing or being diagnosed with prostate cancer, which makes sense. But there's no difference in prostate cancer death. And in fact, if you look at this, it suggests a little bit that the screening population may have had a higher risk of prostate cancer. But that was not statistically significant. But the criticism, again, is contamination. The degree of screening in the control arm, both before the study and after the randomization. So 10% of people had been screened in the control arm of this trial, but even before they were entered into this randomized trial. And then during the period of this trial, 80% of the control group, again, those who were not supposed to be getting screened, 80% had screening. So 85% were screened in the intervention arm and 90% were screened in control arm. So overall, there was no real difference between the number. And so it's not surprising that this study was negative in terms of showing any advantage or disadvantage to prostate cancer screening. Now the ERSPC trial, again, the European trial, multi-center, multi-country trial, did show this, decrease in the relative risk of prostate cancer death of about 20 to 21%, which has been persistent. Even here, this is the 13-year follow-up data. But the critique is always, okay, well, you have a 20% decrease in dying from prostate cancer, but wow, we got to screen all these people, and we got to screen all these people to diagnose this number to prevent one prostate cancer death. Seems like a lot to do to prevent one prostate cancer death. If you look at the Goldberg subset of the ERSP, Goldberg is in Sweden, and it was the largest and the longest followed, and they actually found it in their subset, a 46% decrease in prostate cancer mortality at 4 years. So this is a positive study. And importantly, when you look at these randomized trials where they show that the curves are trying to separate, you know, the longer that you follow it, and you're looking at the number needed to screen and the number needed to diagnose, the numbers get smaller and smaller and smaller. So for 16 years, it was 540, 18 to diagnose, and 1 to death. And there was a modeling study that was done. If you looked at these guys who, again, had a 21% decrease in prostate cancer mortality, and you looked at their lifetime risk, well, there was still a decrease of 21%, but there was eventually only 5 diagnosed to prevent 1 death. So this number needed to diagnose, needed to screen, needing to diagnose, progressively decreases over time, making it, you know, more acceptable, more reasonable in the general sense. This is the cluster trial I was talking about with low-intensity PSA screening. Again, a single PSA test in 415,000 men in the UK. There was more cancer at 10 years in the intervention arm, as you would expect. Again, if you're checking a PSA, you're going to be more likely to get a biopsy and therefore being diagnosed with prostate cancer. But importantly, mortality and survival, there was no difference. So again, the takeaway from this trial is that a single PSA is not the way to screen for prostate cancer. There's no there's randomized trial level 1 evidence that that's not the way to decrease prostate cancer mortality. Now, the United States Preventative Services Task Force, and I'm not sure what sort of guideline group you have in Korea, but this is a group that all of our primary care community listens to very closely in terms of what their recommendations are in terms of screening. And in 2008, they recommended against prostate cancer screening in men who are 75 years and older. In 2012, they decreased to what we call a grade D recommendation, which basically they recommended against PSA testing based on concerns about overdiagnosis and overtreatment. And we could see the decrease in the incidence of prostate cancer, but during this time, after these 2 recommendations, we also saw an increase in the aggressiveness of prostate cancer. The number of men who were diagnosed with metastatic disease, you know, initially, or higher grade, higher risk cancer increased. And so in 2018, looking at this data, they came back with another recommendation in 2018 saying now that screening should be a shared or informed decision-making process. So you have to sort of discuss with patients the pros and the cons of prostate cancer screening. The pros is we might detect a significant cancer that could be successfully treated. The cons being that we may detect cancers that don't need treatment and expose you to the adverse effects or side effects of that treatment. But again, the current recommendation from this group is 55 to 69 years shared decision-making. Now, the truth is that most primary care doctors that I talk to, and they're the ones that are ordering these PSA tests, they're not sitting and talking for long periods of time with their patients about the pros and cons of PSA testing. So they either do it or they don't most of the time. Now this, in terms of screening, this is hot off the press, the 2023 guidelines that were just published in the Journal of Urology 3 or 4 months ago and just presented not that long ago. So brand new guidelines on prostate cancer screening. And there's significant differences made. Here, it was decided based on this guideline panel that we should offer PSA testing to people between the ages of 40, initial PSA testing between 45 to 50. You can see from the previous guide, that last guideline was age 55 to 69 was a period of so this is a significant, we've always, those of us who take care of prostate cancer have always believed that, you know, that you should have one PSA sometime in your 40s, you know, mid 40s, because that PSA level then can predict your chance of developing and dying from prostate cancer 20, 30 years later. So waiting until 50, and I see a lot of guys coming in the doors at age 50 and 55 with very advanced prostate cancer. So again, the guideline has changed, 45 to 50. If you have, if you are a high-risk subset, Black ancestry, mutations, germline mutations, and family history of prostate cancer, then the recommendation has always been to start screening early. Again, according to this guideline, between the ages of 40 and 45. In general, it has been for a long time recommended that PSA be tested on a yearly basis following the initial screening PSA. But again, a change with this guideline is that you can probably, particularly if the PSA is in a reasonable range, go to every 2 to 4 years in screening. Again, that's how you can tailor the screening interval, and that's what bullet number 2 there says. Basically, you can tailor the screening interval based on what that initial PSA is and other factors, you know, like family history and life expectancy and PSA level. So, and the other interesting thing in the new guidelines is clinicians may use digital rectal examination alongside PSA. So it was always, I was always taught to believe that, you know, a digital rectal examination was a very important part of prostate cancer screening. I think it is important, particularly if the PSA is elevated. If the PSA is elevated, I think somebody definitely needs a digital rectal examination, but they're saying that, you know, does every man who gets a PSA test need a DRE? And the guidelines now are saying, well, that you may offer it, but you don't necessarily have to. What about other non-PSA biomarkers for screening and diagnosis of prostate cancer? They're not recommended by the guidelines unless further risk stratification would influence decision regarding whether to proceed with prostate biopsy. So these are the markers that help you decide whether you should proceed with a biopsy. You have this elevated PSA. Is there another blood test or urine marker or something that we can get to help us decide whether that PSA is real, meaning representing prostate cancer or from some other condition? Definitely, if you use these biomarkers to screen folks for whether they get a prostate cancer, you're going to be doing less biopsies. You're going to be finding fewer cancers, of course, so limiting over-diagnosis. But you will miss some aggressive prostate cancer. So the argument is always, well, we can be more specific, but there's a subset of young men, perhaps, who are going to have aggressive disease that if we just use these tests to decide to biopsy the prostate, then we're going to miss this subset of aggressive prostate cancer. So these markers are not yet recommended as first-line screening tests, but again, occasionally it can be used to further stratify risk if it's going to help you decide one way or another. Perhaps an older man that maybe you're not real motivated to do that biopsy. Maybe there's comorbidity, so maybe you want to sort of get further stratification of that risk. Now, these are some of the biomarkers: the prostate health index and the 4K score, common serum biomarkers, and then the urine biomarkers. You can see them there. Most of these are after a digital rectal examination. So DRE, prostate massage, essentially, and then these urine tests, and then confirm MDX is actually a test of benign tissue. So somebody's had a negative biopsy, so you have PSA is elevated. Somebody has a biopsy, negative, benign. You can actually test the tissue to see methylization. You can look for methylization to sort of help you decide whether you should do another biopsy or not, and that's what confirm MDX is. And then these last three, Oncotype DX, Pluraris, and Decipher, are are, and we'll talk about that here in a minute, but those are tests done on tissue. Those are tissue-based markers, biomarkers, genomic in general, on cancerous tissue after a positive biopsy comes back. Let's talk a little bit about that. PCA3 is a score based on the PCA3 versus the PSA level. That's one of the older tests used much less commonly now. Prostate Health Index, a blood test looking basically at pro-PSA, which is another form of PSA in addition to free and total PSA, which we already have. And the higher value, the higher risk of having significant prostate cancer. Again, these are trying to determine for us the risk of having a significant prostate cancer. We're not looking for the low risk Gleason grade 3+3 low volume cancers. And then the 4K score is 4 kallikrein tests. Basically, these are derivatives of PSA, and they're put together in this blood test. It also incorporates other clinical variables to predict the risk of significant prostate cancer. So these are some of the commonly used ones if you use them. I have to say that I use these rarely, but they are certainly available. And then the genomic tissue-based tests, Prolaris, Oncotype DX, Decipher. Prolaris it looks at 31 genes that are associated with proliferation or cell cycle progression. Oncotype DX is a multi-pathway signature assessing 17 genes. Oncotype DX was primarily a test to predict the likelihood of higher grade cancer if you were to perform a radical prostatectomy. And then Decipher, and Decipher is the one that I use most commonly when I use it, a 22 gene panel score from 0 to 1. But again, it has been associated with the genomic score comes back as high, medium, intermediate, or low risk. And sometimes that can help you, particularly in trying to select somebody for active surveillance. Say somebody has a grade group 2, Gleason 3+4 cancer, and are they a good candidate for active surveillance? Sometimes these tissue-based genomic tests can be of value in those populations, but again, not commonly used, at least by me. Now, MRI is commonly utilized, and I don't know how commonly utilized it is here in Asia, but this is becoming almost standard of care to try to get an MRI. I know we try to get an MRI prior to prostate biopsy in every case we possibly can. That's not standard of care yet, don't get me wrong, but we get it because if we can find a target, we can do a targeted biopsy, and we do what's called fusion biopsies where we target the lesion, but we also sample the peripheral zone in a standard way. A MRI, multiparametric MRI, the quality varies dramatically. So I get referrals from all over that come in with these MRIs from outside hospitals, and the quality are really poor. And sometimes they're overcalled or undercalled, so the experience of the radiologist who actually reads the images is very important in keeping the quality of MRI where it needs to be. And it's really important that this is multiparametric, so there's T2 weighted images, also T1 weighted images, but T2 weighted images, T1 weighted images we just use to decide whether their blood is complicating what we're interpreting in the prostate. And the diffusion weighted images are, when there's cancer, the water diffusion is inhibited, and that's how it detects these sort of dark areas here. This is the DWI here. And this is the T2 area, and you can see this is anterior. So these are the kind of cancers that can get missed on a standard transrectal type of biopsy. And this is a classic patient where the PSA continues to go up, and we're just not finding it, but MRI is able to detect it. And then the contrast-enhanced images are difficult because they don't usually. A lot of prostate cancer doesn't enhance, so this doesn't add much. In fact, many people say we should just go to the T2 weighted images, T1, T2, and diffusion weighted images, and not do the contrast enhancement, which is gadolinium, which requires an IV and IV administration of that agent. PIRADS is a way that we look at these lesions on the MRI and grade them according to whether we think the risk of having prostate cancer is high or low, and so there's a PIRADS score of 1 through 5, and this has been updated recently with the version 2.1, but it's really important when we report out these MRIs that we report them out according to this PIRADS score. Now, the question then arises, if you have an MRI lesion that you see, do you need to, if you target that area, is that any better than doing a standard 12-core biopsy? And again, the standard biopsy for me and most, I think, in the United States at least, is 12-core biopsy, which is a templated type biopsy, 6 on the left, 6 on the right. And that obviously mostly samples peripheral zone, but that's the standard systematic biopsy. So if we do that, are we going to detect as much as if we have an MRI that shows something and we target it as well? And so this is data from the NCI looking at that, and what was found, and most studies have shown this, is that if you have a target, that you're going to detect more high-grade cancers when you do that biopsy, and you're going to detect fewer low-grade prostate cancer, and that's ultimately what we want to do. So here you can see that the sensitivity is high of the combined, what we call the fusion biopsy. Fusion biopsy, maybe you're not familiar. Fusion biopsy is a biopsy where we electronically overlay the MRI images on the ultrasound images, so we can do targeted biopsies, and we can do standard systematic peripheral zone biopsies at the same time. And that's become the standard for us, at least, for folks that have an MRI lesion for their first biopsy, even their second biopsy, again, to target that area and sample the rest of the prostate is important. Further investigation of the value of MRI, the PROMISE trial and the PRECISION trial, or trials that you might want to be familiar with. This was a big trial where there was saturation biopsy, transperineal biopsies, and then transrectal ultrasound biopsies, and an MRI was done. So you had like 70 biopsies done, transperineally, and then you had the standard 12-core truss biopsy at the same time. So they tried to correlate, how much did the truss biopsy, 12-core biopsy find, and the saturation was to sort of document that is there cancer there and where is it? Well, what was found is you can avoid 20% of the biopsies if the MRI is negative. So if the MRI is negative, then it was found that you could potentially avoid biopsy. And again, it showed that with MRI guidance, you were more likely to detect significant rather than insignificant prostate cancer. And the PRECISION trial, again, another randomized trial. In this trial, if you were enrolled in the trial, if your MRI was normal, you didn't get a biopsy. If you had an MRI target, you got a biopsy, and it was randomized to that, and it was just the targeted biopsy. It wasn't additional prostate sampling. So compared to that MRI targeted biopsy versus standard biopsy, that was the comparison here. And clinically significant prostate cancer was found more often in the MRI targeted group than the standard biopsy. And the standard biopsy found more clinically indolent or insignificant prostate cancer. And they made a point in this study to sort of say, well, if we used MRI as a screening tool to decide who to biopsy, we could avoid 28%. The problem with that is we don't know what the negative predictive value is because those people didn't get biopsies, right? Negative predictive value mean if you had a normal MRI, did everybody not have prostate cancer? There's a subset of those guys that have prostate cancer. And again, the quality of the image is important as well. This is something that we talk about a lot, the PI-RADS. What's significant PI-RADS score? If you have a PI-RADS score of 4 or 5, then the chance of having clinically significant prostate cancer is significant. I usually tell patients that there's an 80 to 85% chance of clinically significant prostate cancer on targeted biopsies of that area if you have a PI-RADS 5 lesion, and about a 60% or so chance of a clinically significant cancer if it's a PI-RADS 4 lesion. Now, PI-RADS 3 lesions and below are much less often clinically significant. And then this trial, called the TRIO trial, compared the targeted to the systematic to combining them together in terms of prostate cancer detection. And the targeted biopsy led to detection of significantly more cancers than a systematic biopsy in the higher grade groups, just like all the trials have shown, and also led to more cancers. The systematic biopsy, the non-targeted biopsy, found more cancers that were low grade, grade group 1. But the cancer detection was optimized by combining these two, which is why the AUA still recommends that if you have a targeted biopsy, particularly if it's your first biopsy, if you're going to target a lesion, you should also sample the peripheral zone because you can detect cancer in the peripheral zone that sometimes is high grade. Now there's things that help you decide what the significance of that might be, like PSA density, like things that can help you try to decide, and the quality of the MRI is another thing, right? If the MRI is not good, you may want to certainly biopsy the peripheral zone, but standard of care right now is that targeted biopsy by itself should be combined with standard systematic biopsy. What are the techniques? Transrectal, the tried and true way. Sextant was the original way in which transrectal biopsy was performed. So 6 quadrants, 6 regions, sextants, basically. 3 on the right and 3 on the left. Saturation biopsies kind of gone away with MRI, because MRI is so good at detecting cancer that may not have been sampled before, that you don't need to go in and put 50 needles into a prostate to try to find a cancer if you have a normal MRI. Risk of infection with transrectal biopsy is often talked about. That risk increased with the development of with the E. coli, Cipro-resistant E. coli, and we saw that. And most of us have changed the regimen to add another antibiotic, usually an IM cephalosporin, in addition to oral Cipro or something like Cipro. So that combination actually keeps the infection rate with transrectal biopsy quite low, but it requires antibiotics. And some would say that in terms of antibiotic stewardship, that's you could potentially avoid that if you do a transperineal biopsy. Transperineal biopsy, again, low infection risk, but with transperineal biopsy, there's it's generally more painful, which is why it often needs to be done with sedation or anesthesia. There's some suggestion that it has a higher bleeding risk. Similar cancer detection rate between the transrectal and transperineal, although transperineal biopsies access the anterior and apical parts of the prostate more efficiently. So if you have an anterior located tumor and you want to get to it and make sure that it's sampled well, rather than putting the needle from the rectum through to the other side of the prostate, you can actually come at it from a transperineal approach. There was a randomized trial that was presented at last year's AUA, which actually showed there was no difference in the cancer detection rate and no difference in, interestingly enough, the infection rate. So the infection rate is 1% or less with both techniques. Now it's lower in the transperineal, but they're both the risk is pretty low. So again, transperineal is done very commonly in Europe and highly recommended. In the United States, it's kind of taken hold a little bit, but we're waiting for. There's no randomized trials that actually has showed that it's superior. What about risk assessment? Most important thing is the grade of prostate cancer. Read all that. This is the original image from Gleason. Gleason was a pathologist who described the Gleason grade, rating it from 1 to 5. How much time do I have? I don't want to go over. It's my. Do we know when I started? I'm just sorry. I just don't want to. All right. So pattern Gleason grade. I got 20.
Yeah, you have 20 minutes. 20 minutes.
20 minutes. Okay.
Yeah.
Okay, good. So this is Gleason grading, which we all know about, one of the strongest assessments of prostate cancer aggressiveness. You can assess this more definitively with a prostate after it's removed, because you can see the entire gland, so you can assess the entire cancer. So we often see upgrading at the time of prostatectomy. We might think we have a 3+4 cancer, but when we actually look at the whole cancer after prostatectomy, it's now a 4+3. And perhaps we have tertiary patterns too. Tertiary is a third pattern that we sometimes see, especially if we're seeing tertiary grade 5. That's a negative prognostic factor in radical prostatectomy. The grade group system has been adopted recently in the last 5 years or so, and so grade group 1 is the 3 3s, 2 is the 3 4s, and the 4 3s are the grade group 3. One of the other things that has changed is the introduction of this cribiform pattern, which is more commonly described by urologists or by pathologists now than in the past, and that is a label of a more aggressive cancer. There's also much discussion about whether Gleason grade or Gleason grade group 1 should be called a cancer. So particularly if you have a small Gleason 3+3 cancer and it's very small volume, it doesn't behave like a cancer. It behaves much more like a benign lesion. So many have argued that, why do we call grade group 1 prostate cancer cancer? And so there's a lot ongoing debate about that, which is interesting. Risk stratification goes down to, you were looking at the AUA risk categories and the NCCN risk categories. So the low, intermediate, and high risk categories are very similar between these two, some subtle differences here. This goes back to the kind of the D'Amico, Anthony D'Amico, the radiation oncologist, who sort of came up with this risk stratification categories many years ago. But the NCC has thrown in very low risk and then very high risk to this. And the very low risk takes into account everything. Less than 3 positive cores, less than 50% core involvement, and a PSA density less than 0.15. So truly small volume, low PSA, low grade, not a small number of cores involved. When should we image? Well, for low-risk cancers, there's no indication to do it. And again, I see that that's still not uncommon practice, where I will be referred somebody with a relatively low-risk cancer that had a bone scan and a CAT scan, and they weren't really indicated. For intermediate risk prostate cancer, bone scan should be recommended if the PSA is over 10 or it's a clinical T2, so palpable lesion on digital rectal examination, or the lymph node, the probability of having a positive lymph node. There's a couple of nomograms that can be used to predict the chances of harboring positive lymph nodes. That would be another potential reason to get a CT scan. More commonly today, we're doing MRI. We're doing MRI imaging to assess the pelvis, so assessing the prostate and the lymph nodes within the pelvis with the MRI rather than the CT scan. So we're doing less CT scans and more prostate MRIs to rule out lymphadenopathy. And then for high-risk disease, imaging is appropriate. And I'm not going to talk today much about the PSMA PET imaging that we have, but that's a game changer in terms of how we can detect metastatic disease or regional metastasis with prostate cancer, and how is that going to change our management strategies when our management has always been based on the results of a bone scan and a CAT scan. So now we have a much more sensitive way to detect metastatic disease. How are we going to change our management as a result of that? Now, what about treatment for prostate cancer? You know about these. If the life expectancy is limited, then watchful waiting is appropriate. Active surveillance is really the most appropriate management strategy for low-risk prostate cancer. For favorable intermediate risk disease, basically, you can find these grade group 2, so 3+4 prostate cancer, grade group 2. These are the cancers that sometimes we can watch if we can determine that they're small, and these are the kind of cancers that I might get one of those biomarker genomic tests to help me know that it's not genomically high risk before we watch it, particularly in younger men. Unfavorable intermediate risk disease, the more unfavorable cancer you have, the more often ADT is utilized when radiation is considered. So ADT would be considered combined with radiation for unfavorable intermediate risk and for high risk. And sometimes people ask about ablation therapy, things like HIFU or cryotherapy, really not appropriate for high-risk prostate cancer. We have to keep in mind the sort of difference in grade and what it means in terms of impacting life expectancy. And this is the classic paper by Peter Albertson that looked at grade in terms of how it relates to whether you are what your chance of dying from prostate cancer might be. And this is from the Connecticut Tumor Registry. And basically these black sort of lines are the death from prostate cancer. And you can see, and then at the bottom here is age. So you can see as the Gleason score increases, then you're much more likely over 20 years to die from prostate cancer than if you have these low risk, low grade cancers, even if you diagnose that at a younger age. So this is just sort of a classic sort of look to this image that we see, and sort of help us to realize that grade does drive prostate cancer mortality. Active surveillance, PSA, DRE biopsy is important. The frequency of repeat biopsy is somewhat debated and can be tailored depending on how long you have been watching this cancer, and also the grade. Perhaps a higher grade cancer, you're biopsying more frequently. MRI can be thrown into it when we do MRI and active surveillance. It's nice if we can see a lesion that actually is biopsy positive. We can confirm that, yeah, that's where that That's where that lesion is. And then with MRI, show that that's not significantly changing over a period of time, so that can be reassuring. But a lot of these low-risk cancers, the MRI is negative, so it's not really helpful. But we still sometimes add it into the surveillance regimen over time. What are the outcomes? There's how many, if you start with active surveillance, you have a low risk or perhaps a favorable intermediate risk prostate cancer, and you embark on active surveillance. How many guys continue on active surveillance to the end of their life? Well, within 10 years, about 50 to 68% go on to, or 56 avoid treatment, but about up to 50% of treatment of patients will go on to treatment for a number of reasons. Now, the whole rationale for active surveillance is that if you pick the right cancers to watch, when you have that treatment, say 5 years later, it should be equally effective. Radical prostatectomy or radiation therapy should be equally effective to the day that the cancer was diagnosed. So that's why it's so important to pick the right cancers to watch. And again, intermediate risk patients, so the ones that have a component of Gleason pattern 4, right? So 3 plus 4, but there's 4. I always like to know the percent of pattern 4. How much of the cancer is that Gleason pattern, more aggressive pattern 4? That can help you kind of, and then that genomic testing can sometimes be helpful. But these are the folks that you got to watch more closely, because studies have shown in a cohort from Canada where these patients were watched for a long time, there's a much higher risk of progression to a less curable cancer. And this is just a graph that shows the reasons to leave active surveillance. And this goes over 15 years. You can see progression is the number one reason, and then conversion without any evidence of progression. And we talk about progression. We talk about progression with prostate cancer, with active surveillance. Is it really progression, or is it reclassification? So we'll refer to it as, I often refer to it as reclassification. So if we do a biopsy and you have 3 plus 3 in 4 cores, and then 18 months, 12 months later, you do another biopsy, and now you have 3 plus 4 cancer in 2 cores. Is that because the 3-3 became a 3-4? No, it's just because it was always there, and now you're sampling differently. So it's reclassified. It's not truly progression of the cancer that you originally diagnosed. Radiation therapy is another treatment approach. As you know, external beam, both conventional and hypofractionated. Hypofractionation means that basically the entire dose of radiation therapy is given in a shorter period of time. So instead of 1.5 to 2 gray every day for 30 treatments, you can increase that to 3 gray per treatment to decrease that length of treatment to maybe a month. And then if ultra hypofractionation is the SBRT, where you can actually give perhaps up to 8 gray or so every day for 5 days in a row. There's ways to do that, and there's potential risk to that, but that is sometimes utilized as well. Proton beam is a form of external beam radiation therapy. You use protons instead of photons. There's some thinking that perhaps that can deliver more radiation to the prostate without it impacting surrounding structures, but the data hasn't really confirmed that to be true yet. There are ongoing trials to look at that more closely, but there's no there's no evidence now that proton beam radiation therapy is more effective than well-performed IMRT, intentionally modulated radiation therapy. Some people will add brachytherapy, low-dose or high-dose brachytherapy to external beam radiation therapy as well. And the other important thing about protons is that it's about 3 times as expensive. So radical prostatectomy is the least expensive curative treatment for prostate cancer. External beam radiation is about 2 or 3 times that, and then proton beam is about 3 times radiation's cost. So that's just FYI. A lot of insurance carriers in the States are not covering proton beam because there's no evidence that it has greater efficacy or has fewer side effects. So there's no difference between the two, and one costs dramatically more. Side effects, urinary symptoms and bowel symptoms are associated with, again, rectal toxicity from the radiation therapy, erectile dysfunction, especially with concurrent ADT. So again, I told you with radiation, if we're dealing with a grade group 3 or higher prostate cancer, we're combining external beam radiation therapy with a course of ADT. And again, that combination can have significant effects on erectile function recovery after treatment. And that's some of the long-term effects of radiation, or those effects on the bladder, or the effects in terms of recovering erectile function. And then the risk of secondary malignancy, and that is a true risk. It doesn't increase the risk, a dramatic amount, but it definitely increases the risk. So we talk about that a lot in younger men. So a young man that diagnosed with prostate cancer in their 50s, they're going to live long enough because the secondary malignancy risk doesn't really manifest itself or become evident for 15 to 20 years after the radiation has been delivered. So it's less important to the 75-year-old man who's not going to live that long than it is to the 55-year-old man who's definitely going to be exposed to that risk. And it's one of the reasons that radiation oncologists will often direct young men towards surgical treatment rather than radiation therapy treatment because of the fear of secondary malignancies. Again, we talked about this a little bit when we go up in terms of the risk group, we add ADT if we're dealing with an unfavorable intermediate risk, so Gleason 4+3 cancer. Then radiation is usually given with a shorter course of androgen deprivation, usually around 6 months or so. Sometimes external beam is combined with a brachytherapy boost. That's operator preference, honestly, radiation oncology preference. But high-risk prostate cancer is very important to have a longer course of ADT because there's lots of level 1 evidence that shows that long course of ADT combined with external beam radiation therapy has significantly better outcomes than radiation therapy by itself. And generally what we do is 2 years. The BOLA study originally investigated 3 years of ADT. There's other studies that suggest that perhaps 2 years, but we usually go with 2 years combined with radiation therapy for these high-risk prostate cancer patients. Again, here's saying that again, brachytherapy is sometimes added, so it's sort of triplet or triple therapy. The ASCEND trial looked at the difference between external beam radiation therapy combined with brachytherapy, prostate brachytherapy, and whether there were more significant side effects compared to external beam radiation by itself, and indeed there was. Grade 3+ toxicity was greater in the combined group than in the external beam group itself. And many of these toxicities are long-term toxicities were GU related, so genitourinary toxicity, most commonly urethral strictures. So there is an increased risk if you combine 2 modalities of radiation therapy. There is a greater risk to that combination than if you do one by itself. But again, in high-risk cancer patients, sometimes that brachytherapy boost with the external beam is recommended because actually the treatment effect is more significant, but the trade-off is a higher risk of side effects. Surgery, nerve sparing, we can do in many cases. Lymphadenectomy is, how do we do it? Should it be a limited? Should it be an extended lymph node dissection? There's no good evidence to support doing it one way or another, as opposed to perhaps in bladder cancer, although I'll talk to you later today about that. Adjuvant radiation therapy should not be offered post radical prostatectomy because we can have evidence now that I'll show you here in a little bit that salvage radiation is appropriate as well. Neoadjuvant androgen deprivation therapy was something that we investigated many years ago when I was first starting my career, given 3 to 8 months of hormonal therapy, androgen deprivation therapy prior to surgery. We found that the margins and the stage, the possibility of extracapsular extension was affected by that, but the ultimate cancer effect, the probability of recurrence, was not affected by neoadjuvant androgen deprivation therapy, so not indicated prior to surgery. Some ask, well, is surgery better than just watching cancers? And these are 3 trials that have documented or actually investigated that. And again, this is the Swedish trial here, that surgery versus watchful waiting, and there was improved overall and disease-specific survival. So that was the SBCG4 trial, published initially in 2014. And then the PIVOT trial was a VA trial. Lots of issues with that trial because, well, the comorbidity level of patients was significant. 50% of them died within 10 years, so it wasn't really a population that was consistent with the population that we usually do surgery or active surveillance on. And importantly, there was a higher risk of metastases in those who had PSAs more than 10, so intermediate risk cancers. Gleason 7s or above, and PSAs above 10 with surveillance had significantly worse outcomes than with surgery. And then the PROTECT trial, a big trial that compared 3 different management strategies: surgery, radiation, and active surveillance, showing no difference in overall survival. But radiation therapy and radical prostatectomy were better than active surveillance in preventing the development of metastatic disease. This is just some slides showing, again, the metastatic disease was affected, but the survival, both at 10 years and 15 years, was not affected. We mentioned earlier about the difference between adjuvant. You know, before we would often consider adjuvant radiation therapy based on pathologic features found at the time of prostatectomy, and we had actually level 1 evidence to support that. But many of us kind of moved away from that with ultrasensitive PSAs. Since we can detect these recurrences so early, why can't we delay the radiation? Because we're going to be over-treating some people if we don't. So these are some trials that looked at that, and were recently published. Basically, they showed that there's no advantage to adjuvant. And I'm sure you all know adjuvant means you're treating the prostate with no evidence of, or you're treating the pelvis with no evidence of cancer, so undetectable PSA. But you're giving radiation based on pathologic findings of prostatectomy. That's adjuvant treatment. Salvage treatment is, well, you watch the PSAs come up, and now you're salvaging. So there's a difference there. And these studies showed that the salvage approach was just as good, and what it does is it limits overtreatment on those patients that may never have developed a detectable PSA. One important thing about salvage radiation therapy is earlier is better. Lots of data to show that the PSA level predicts success of salvage radiation therapy. So the lower the PSA, when you administer salvage radiation therapy, the higher the success rate, which means that, you know, when we see that PSA rising after prostatectomy, we don't want to wait for it to be high before we do the radiation oncology referral, because it's important to get that radiation done earlier to improve outcomes. And when we do salvage radiation therapy, there's now data to show that ADT could be, you know, combined with it. A couple of trials with 6 months of androgen deprivation therapy here that improved progression-free survival, and then the use of bicalutamide was Shipley's paper in the New England Journal from 2017. So again, the idea now is that if you get salvage radiation therapy, before salvage radiation therapy was given without combining it with androgen deprivation therapy, but now salvage radiation therapy should be combined with ADT because there's level 1 evidence now to support that. And what about disease recurrence, PSA persistence, or PSA recurrence? So PSA persistence, where you do the prostatectomy and the PSA drops, but it doesn't go down to undetectable levels. That's persistent prostate cancer remains. Recurrence would be PSA goes to 0, but then you get a biochemical recurrence later with a rising PSA. What should be the definition? Well, the standard definition is a PSA level of 0.2, but honestly, if a PSA is trending upward and it exceeds 0.1, and there's high-risk features at the time of radical prostatectomy, I'm not waiting for it to get to be 0.2. We'll get them to the radiation oncologist, at least have a discussion about it when their PSA is going upward and it reaches a level between 0.1 and 0.2. But the definition is really 2 determinations above, 0.2 nanograms per milliliter. And then the biochemical success definition for radiation therapy is the Phoenix consensus panel recommendations, where PSA nadir, so lowest PSA obtained, +2 is definition of failure of the radiation therapy. Now, there's issues you have to consider, like PSA bounce. Sometimes PSA can bounce after radiation therapy, so it goes up and then comes down. But if the PSA is truly 2 points higher than where it went to at its nadir, that's the definition of persistent cancer after radiation therapy. Now, how should we manage biochemical recurrence? Well, you can either observe patients, and that's been the long-term recommendation, is just observe. But I don't have a whole lot of men that just want to watch their PSA going up after surgery without doing something about it. So we'll talk about radiation therapy. We'll talk about androgen deprivation therapy on occasion. And in these patients, they're kind of ideally suited for intermittent ADT rather than continuous ADT. So you can do intermittent ADT, which means you give, say, 9 months of treatment, and then you see the PSA come down, and then you see the testosterone recover, and then the PSA starts to go up, and then you have a threshold to re-trigger another 9 months of treatment, intermittent ADT. So particularly in this kind of lower risk, low volume cancer setting, that's certainly appropriate. And then imaging, we talked about a little bit, but how PSMA PET is sort of changing the landscape documenting recurrence, and that's what it was originally sort of approved for. We're now trying to use it in staging, pre-treatment, but PSMA PET scan really is the most sensitive way to detect recurrence. But the problem is it's dependent on the PSA level, right? So the PSMA PET scan is more likely to be positive, give you information to go by if the PSA level is high. But I just told you maybe we don't want to wait for the PSA level to get high because radiation therapy won't be as effective. So sometimes there's a dilemma there about, well, should we wait for the PSA to get up so we can do a PET scan? Because if the PSA is 0.1 or 0.2, PET scans are often negative, and often falsely, negative. So again, that's another ongoing debate. This is two papers. I just want to talk, just the left one, do folks who have lymph node positivity at the time of radical prostatectomy, do all of them recur? Because the Messing trial, which you may not be familiar with, but it's a trial, randomized prospective trial that showed that early androgen deprivation, if you had positive lymph nodes at the time of surgery, was beneficial in all oncologic endpoints. So early ADT was given. If the lymph nodes were positive, you were started on ADT, and again, the outcomes showed the improvement in those who got that early ADT compared to those who had delayed ADT. But even in that Messing trial, there was about 20%, 18% precisely of men who didn't recur, who didn't get ADT. So those who were not treated with ADT were just treated with surgery. There's about 18% or so that didn't recur, meaning that surgery was able to cure those who had lymph node positive disease. But usually those were patients who just had a single lymph node positive, not multiple lymph nodes and positive. And this is another study that sort of showed this. This is from Memorial Sloan Kettering, but this shows 28% of those folks, didn't have PSA recurrence, which is why, at least in my practice, if I come back and somebody has the lymph nodes that are positive, particularly if they have one positive and their PSA goes to undetectable levels, I'm not arguing for early ADT at that point in time, because sometimes we'll follow those guys and they'll keep an undetectable PSA for a long time or even indefinitely. But again, it's not a large subset. It's much more likely you're going to have biochemical recurrence, but there is that subset that you might want to watch before you just knee-jerk administer ADT. And then this is basically a study that's showing that, in lymph node positive disease, there is some evidence that local therapy with radiation therapy actually improves outcome. You wouldn't think that because you think, lymph node positive, more of a systemic spread of the cancer, that maybe local therapy wouldn't be an advantage. But this study actually showed that indeed local therapy with radiation therapy, even though lymph nodes were positive, was a advantage. And I'm going to kind of go through this quickly so it can end here. There's a lot in this space to talk about, the agonist and the antagonist, the mechanism of action. You should be familiar with these drugs, and then decreasing androgen production, that's the abiraterones or the ketoconazoles. We used to use ketoconazole because it basically does that. It is toxic to the adrenal and inhibits androgen production. And then these newer agents, first generation anti-androgens, those are the older ones that I grew up using. But now the newer ones, these second generations, are more specific. They actually impact the process at three different spots, not just at the level of the prostate cancer cell. There's side effects that we all know about from androgen deprivation therapy. Long list that you have to talk about. Cognitive dysfunction is something that's being more recognized, particularly in older men who are on long-term ADT. And then bone health is important. So these guys on ADT should be taking, vitamin D and calcium, and making sure that because osteoporosis is a big deal, and often there are these bone protective agents that are prescribed, which can have their own set of side effects. And one to know about denosumab and zoledronic acid is that osteonecrosis of the jaw can occur with both of them. So these bone health agents that we give to try to prevent bone loss in those who are getting ADT, and there's data to show that these agents actually decrease the chance of skeletal related events, which can be fractures and other things. They do have their own set of side effects. Talked a little bit about intermittent ADT before. There's two trials here that show that there's no real difference between intermittent and continuous androgen deprivation. Although I'll say that if somebody has widespread metastatic disease, Most will recommend a more continuous ADT approach to that. But if you have lesser, like the biochemical recurrence after treatment, that's the ideal candidate for if you're going to give ADT. That you can give it intermittently. In those trials, about 45% of the time you were off treatment, so you can avoid the side effects, at least for periods of time during that intermittent ADT cycle. And then again, second generations, these are the newest medicines, abiraterone. Again, it impacts steroid or androgen production at the level of the adrenal. The problem is that it could cause hypocalcemia, and you need to supplement it with prednisone because of its adrenal toxicity. And then you have these androgen receptor blockers, again, the newer ones that affect. Here's the androgen receptor, lies in the prostate cancer cell cytoplasm, and the testosterone impacts it, and then it goes into the nucleus. It can impact that process as well, and then it also impacts the binding of the androgen receptor to the DNA itself. These are, this is one of the meds, enzalutamide. One of the interesting side effects that's been shown in trials is seizures, so you got to watch for that. And then hormone-sensitive and castrate-resistant prostate cancer, 2 categories which we manage differently. And again, I think I'm running out of time, so I'm not going to go into this in much detail. But if you have castrate-sensitive prostate cancer, but it's metastatic, then you can think about ADT or ADT and adding these other agents. So studies have shown that a combination now, when you have documented metastatic disease by imaging, is better than the ADT by itself. These are some of the level 1 evidence that shows that to be true. By adding these other agents to standard ADT, you benefit the patient in many ways in terms of cancer recurrence and progression. Hormones, these are just some of the recommendations too. What you should offer. Again, consider I think the take-home message here is that ADT, and particularly with PSMA PET now documenting more lesions that we didn't see before, there's evidence that ADT by itself is not as good as ADT in a second-generation androgen treatment, like enzalutamide or abiraterone. So that combination is more commonly utilized today. And then castrate-resistant prostate cancer. What's castrate mean? Testosterone less than 50, PSA rising and greater than 2, and no evidence of metastatic disease. Again, I won't go through this in detail. Studies that show that the addition of these newer second-generation medications increases effectiveness and prevents metastatic disease, which is important. And again, for M1 castrate-resistant prostate cancer, you could have a whole talk on this, the number of medicines that are available. This is the recommendations. A lot of it has to do with what you've been exposed to prior. If you've had chemotherapy prior, there's a list of drugs that you can be given. And then this is the level 1 evidence to support in castrate-resistant prostate cancer with metastatic disease. A lot of these studies have shown that, again, the combination of treatment is beneficial compared to ADT by itself. And I won't do that. And finally, this is my last slide. We have come to realize that germline genetic testing should be recommended in many men with prostate cancer, particularly with strong family history or advanced aggressive prostate cancer, because there are these germline gene mutations, particularly in these DNA repair genes, like BRCA1, BRCA2 would be examples of that. And we have find that in about 11 or 12% of prostate cancer patients. So it's not a big percent of the men that have prostate cancer, but when you do have a BRCA2 mutation, and then you usually can be associated with a more aggressive prostate cancer, and so some of those guys you want to treat perhaps more aggressively or follow more closely. And it's the other reason that you should take a family history. Right? I mean, if somebody has a family history of breast cancer, ovarian cancer, in the female side of the family treat, then they could be passing down a BRCA1 or BRCA2 mutation. So germline testing is recommended, and we're doing it much more commonly now than we did in the past. So that's all. Again, it's hard to cover that. I could go into more detail, but you don't want to hear that. This has been a long day already, and half a day. So anyway, appreciate your attention, and thanks for the opportunity to talk with you.
Yeah, thank you for your excellent and concise, not missing the important aspect. Actually, we are fall behind our schedule, but we This is the important lecture. So the time is actually the time we can spend more, and there are 2 restaurants available, and you can check the meal coupon, and actually the Saturday is a crowded. This is the popular area. Crowded people can be expected, and you can beat the crowd. Yeah, we will see we gather the 1 hours later and start the new session from 2 p.m. Thank you.
Good afternoon. I'm Juyong Lee, the Vice Director of Education and Training Committee of Korean Urological Association. In the afternoon session, I will moderate in KUA-AUA Resident Review course. This lecture is Professor Christopher Emling from Oregon University, Oregon Health and Science University. In the morning session, Professor Emling spoke about prostate cancer. In this session is bladder cancer. So please, great lecture. Thank you.
Great. Thank you again. Thanks for the opportunity to be here. Looks like the room thinned out a little bit, but I anticipate people will be kind of trailing in. So let's get right into it so we can stay on time. Again, here's some of the resources that utilized to put together this talk and that are available to all of you through the AUA, so guidelines, and then the core curriculum through AUA University. Talk a little bit about anatomy, then epidemiology, presentation, staging and grading, risk stratification, treatment, and surveillance. So let's start first with anatomy. So the vascular anatomy to the bladder is via the superior and inferior vesical arteries, and the veins are the superior and inferior vesical veins that drain into the internal iliac. So it's a little bit different. The arteries go through a branch of the internal iliac, so a little bit different drainage level. Lymphatic drainage is via level 1, internal iliac obturator and external iliac. So it's a concern when we're doing lymph node dissection for bladder cancer. That's really the level 1. And I highlighted the external iliac because often the standard lymph node dissection that we do is the internal iliac and the obturator lymph nodes, but doesn't necessarily include the external iliac. Level 2 nodes are the presacrals and the common iliacs, and then level 3s are the ones that go up the common iliac and above the bifurcation of the aorta. The urothelium basically has 3 cellular layers: the basal cell, the intermediate cells, which are 4 or 5 or 6 layers of cells, and then the umbrella cells. The umbrella cells are the uppermost layer of the epithelium. It's a very impermeable. I've been told that it's one of the most impermeable organs in the human body in terms of absorbing things. And it's inert, meaning it doesn't react to a lot of things either, which makes it ideal for storing and transporting urine. There's 3 layers of smooth muscle in the muscularis propria, and then of course the bladder dome is covered with serosa. And the epidemiology of bladder cancer, I talked about it with prostate cancer, but here's the global statistics again. The 10th most diagnosed prostate cancer was first. This is the 10th most frequently diagnosed cancer globally. You can see the number of cases and deaths. There's a male to female difference in terms of the risk. It's about a 4 times increased risk for men to develop bladder cancer compared to women. About 75% of cancers diagnosed are non-muscle invasive. 25% are muscle invasive bladder cancers. And of the non-muscle invasive cancers, 40% of them are high grade. So 60% of the non-muscle invasive bladder cancers are the low grade papillary tumors, of the bladder. In the United States, again, based on 2002 American College of Surgeons estimates, it's the 4th most incident prostate cancer in males, and the 6th most common cancer overall in the U.S. for men. Caucasian, more commonly in Caucasians than African Americans, than Hispanics, and Asians being least commonly acquiring this cancer. The median age of diagnosis is 73 years, so this is a disease of older folks with often with multiple comorbidities, and because smoking can be a part of the reason they develop their prostate cancer, these are somewhat often fragile patients. And interestingly, women are more likely to have advanced tumors than men, and there's some thinking that might be a delay in diagnosis, since women are often treated with for recurrent urinary tract infections when they're having irritable bladder symptoms, and so that there might be a delay in the diagnosis of carcinoma in situ, for example. Risk factors: clearly, cigarette smoking is a risk factor. If you're a smoker, you have 2 to 3 times the risk of developing bladder cancer. If you're a current smoker overall, there's a 4 times higher relative risk. Former smoker, 2 times higher. It's estimated that 50 to 60% of all urothelial cancers are caused by smoking. You can decrease the risk of developing bladder cancer or urothelial cancer of the upper tract by 40% after you quit for 1 to 4 years, and then you can decrease that risk by 60% after 25 years. Smoking has been shown to increase the risk of local recurrence in non-muscle invasive bladder cancer, so when we do doing cystoscopic surveillance for recurrent superficial or non-muscle invasive bladder cancer, if you're a smoker, you have a significant increased risk for us to detect that. Occupational risks, many of the occupational risks, the exposures in occupations have been put aside, meaning that they're well recognized, and so there's ways to keep from being exposed to rubber and paint and petroleum and textiles like in the past, but these are clearly toxic to the urothelium of the bladder if absorbed in one way or another, and account for about 5 to 10% of all urothelial cancers. Other risk factors, these particular drugs that can increase the risk of you having bladder cancer, and of course pelvic radiation. We talked a little bit about that, but pelvic radiation can increase your risk of second malignancies, one of which is bladder cancer. Chronic cystitis, so recurrent infections or indwelling Foley catheter can result in the development of usually a squamous cell carcinoma. And then a history of schistosomiasis that has affected the bladder also puts you at risk of developing a squamous cell carcinoma, although some of these people do get adenocarcinomas, so different than standard urothelial carcinomas. So recurrent infections, indwelling catheter, basically irritation or inflammation of the bladder can result in squamous cell carcinoma. And then there's these other exposures listed at the bottom here that have been linked to the development of bladder cancer as well. There are several inherited tumor syndromes. This is a list of some of them. Know about Lynch syndrome. That usually comes up on examinations. Lynch is more commonly associated with the development of upper tract urothelial cancer rather than bladder cancer itself, but it's something to know for your examinations. In general, it's thought that there's a non-invasive and an invasive pathway to the development of bladder cancer. The non-invasive pathway results in mutations of oncogenes or loss of heterozygosity to chromosome 9q. So mutations to oncogenes, FGFR is the common one that we think about, fibroblast growth factor, that can result in the development of low-grade, non-invasive prostate or bladder cancers. The invasive pathway is more mutations in tumor suppressor genes. So the tumor suppressor genes that suppress tumor growth are mutated, like P53 or RB1. So just a different way to think about how these cancers develop genetically. And then it's also known that bladder cancer risk increases if you have certain abnormalities in these detoxification genes, like NAT1 and NAT2 and GST. These are genes that support the detoxification process of some of these exposures. These work through the liver, and if you have these, and we call it the high or the low acylators, then if you're a slow acylator, then you have a much higher risk of developing this because you retain these carcinogens for a longer period of time, and therefore expose the bladder to them over a longer period of time. How does bladder cancer present? Usually with hematuria, as I think we all know. If you have microscopic hematuria, you have about a 3%. If you do a workup with cystoscopy and upper tract imaging, you have about a 3% chance of harboring bladder cancer. If you have gross hematuria, significantly higher risk, 10 to 13%. And irritative voiding symptoms, again, carcinoma in situ. Carcinoma in situ, 80% of patients with carcinoma in situ present with these irritative voiding type symptoms. And if you have these irritative symptoms and you have hematuria together with it, then it doubles your risk of having carcinoma in situ. So it's important to know that if you have hematuria and you're having irritable voiding symptoms, that's a person's at high risk for carcinoma in situ. So it definitely needs to be evaluated. Women are often missed, as I said earlier, because they're presumed to have recurrent urinary tract infections or persistent urinary tract infections, so there might be a delay in diagnosis. And the other way that these cancers are found is with incidental detection. So occasionally we'll do a CAT scan for another reason, and we'll see a filling defect in the bladder or the upper urinary tract. Diagnosis is clearly made by an office cystoscopy. You can do anesthetic, meaning anesthesia cystoscopy, if you believe that you're going to need to resect the tumor. So if you have an image, you have a positive cytology in a CT urogram that shows a big bladder mass, you don't necessarily need to do an office cystoscopy. You can do it in the operating room because you're going to need to resect that cancer to start with anyway. There are urine-based tumor markers, but they're not currently recommended for the initial evaluation of hematuria, although they can help they can help us decide whether a cytology, an atypical cytology, is truly positive or not, which we'll talk a little bit about. Urine cytology is very specific, but not sensitive. So the way to think about urinary cytology is it's much easier to detect high-grade looking cancer cells than it is to detect cancer cells that look very much like normal urothelium. So cytology, if positive, if you're seeing cancers with that big nuclear to cytoplasmic ratio and the other chromatin marking and things like that, it's easier to detect that than for low-grade tumors. And those kinds of cells more often shed from the surface of the bladder than do lower-grade types of tumors. So it's low in sensitivity, meaning it doesn't detect low-grade or intermediate risk cancers, but it can, if it's positive, it's usually truly positive, meaning it represents a cancer that is present, so very specific. Diagnosed by transurethral biopsy or transurethral resection. Bimanual examination is always referred to, when we diagnose bladder cancer and we're in the operating room, it's often useful to do a bimanual examination. Now, I would argue that if it's a small little 2-centimeter tumor, they're not going to gain much from a bimanual examination, but if you're dealing with a large tumor that you're considering perhaps might require cystectomy, then you kind of want to know if that tumor is fixed or get a sense for whether you think that cancer might be extra vesical in its extension. TURBT has evolved over the years, almost always in the past. Monopolar electrocautery was used, and now we almost always do these with bipolar, which has decreased the risks significantly. Cold cut biopsy can be done in some very small tumors. Complete resection is the norm and the standard. And when you do these resections, you want to have muscle in the specimen so that you can actually make a call with regard to the depth of invasion and ruling out lamina propria or muscularis propria invasion. What is commonly done is resecting the tumor and then send that as one specimen and then do a base of the tumor resection where you're getting deeper into the bladder wall and actually sampling the bladder muscle to rule out lamina propria and muscularis propria involvement at that time. It's important to document well when you're talking about these tumors, how big, location, when you're documenting in the medical record. What about cystoscopy? Well, white light cystoscopy is the standard that has been used forever, and it's the mainstay of the diagnosis and the staging and the management of these cancers. But the problem is that flat tumors and carcinoma in situ may appear normal by white light cystoscopy. And you can see, I don't know how well you can see this image to the right, but there's some kind of red areas or thickened mucosal areas here. This is white light, you could see that. But in some cases, flat tumors or carcinoma in situ might not be visible. So folks have discussed enhanced cystoscopic techniques. And one technique is what's called narrowband imaging, and it sort of came about in about 2008. And what narrowband imaging does is it essentially takes the white light and it splits it. And it splits it into blue light and green light. And what this does is allows vascular structures in the bladder wall to be enhanced, typically. And sometimes if there's a small lesion, you can maybe see it a little bit better. Now, narrowband images is not as sensitive as blue light cystoscopy, we'll talk about here in a minute. But you can see to the right here, if you look at this, the vascular structures are highlighted when you do this blue-green light narrowband imaging. And the guidelines here say that in a patient with non-muscle invasive bladder cancer, a clinician may consider use of narrowband imaging to increase detection and decrease recurrence. So may consider is the important part of that statement. Blue light cystoscopy, another way to enhance cystoscopy. And these photoactive porphyrins are placed into the bladder and usually placed there for a couple of hours. And then they absorb into the tissue. And this causes fluorescence under blue light cystoscopy. So what you'll see on blue light is you see something like this, where there's a hot pink area. Now it's not always as clear as this picture shows. Sometimes if the blue light's at an angle, you can get a sense that there might be some of this hot pink area, but it can be the refraction of the actual. So you got to be careful about overcalling some of the lesions that you see. But this has been shown to decrease recurrence rates and also to increase detection of some of these cancers that may not be visible on white light. So, not everybody has blue light cystoscopy. It's kind of expensive technology, but if you have it, it is something that, at the time of tumor resection, at least in the operating room, to use it to make sure that you're resecting the tumor that you see, but are there other areas in the bladder that you might resect as well? And by doing so, decrease the chance of recurrence in follow-up of those non-invasive tumors. What about second look TURBT? So when do we do that, and why do we do that? Well, when we have a high-grade tumor that's TA, so just involving the epithelium, not the lamina propria, and then high-grade T1, which involves the lamina propria. If you go back and you re-resect, after you initially resect that tumor, there's about a 50% chance you'll find cancer for high-grade TAs and T1s. But there's about a 30% chance that you'll upstage, so if you go back for T1. So that's why it's recommended, and this will be, if it's ever asked on a test, you'll know the answer, because this is standard of care. When you have a high-grade T1 cancer, the reaction is, yes, we have to go re-resect, because there's a 30% chance when you re-resect that you'll find that there's muscle invasion, which changes your treatment paradigm. You should do this within 2 to 6 weeks of the initial resection. And this is some of the guidelines here. I pointed out that for high-risk, high-grade TA tumors, you should consider. But for T1, like I said, you should perform. So it's definitely strongly recommended, and it would be sort of standard of care to go back and re-resect for a T1. But a TA, particularly if it's small and you feel like you had complete resection, maybe there's not as much of a need to go back and re-resect. But you can see that, again, residual cancer and in some cases muscle invasive disease can be detected on repeat TURBT. What about urinary biomarkers? We talked a little bit earlier about cytology. It's very specific, 90 plus, so if it's positive, it's 90+% of the time it's correct. For high-grade tumors, has low sensitivity for lower-grade tumors, so it can't be used, for example, instead of cystoscopy. And there are some limitations to cytology. One, it's expensive. It costs quite a bit. And also, like a lot of things, it's dependent on the person actually looking at the specimen. And there's requirements for the adequacy of the specimen. There has to be a certain cellularity and volume of cells for you actually to be able to make the call. And so a cytopathologist who has less experience will often say these are atypical cells. But atypical cells can be normal cells. They could be reaction. They could have sat in the bladder too long. So atypical cells is not a positive cytology. But again, depending on the expertise of the cytopathologist, you can get different reports back. So you got to understand that you want somebody with experience to look at these cytologies. And the other negatives is if you do have atypical society, then you're usually going on to, well, what do I do about this? So you got to get additional testing to be able to know that this is not a positive cytology. So that's a real common area of difficulty when we're doing assessment of cytology on recurrent to determine whether there's recurrent bladder cancer. And what does this cytology really mean? Is it falsely positive? Is it truly positive? Those kinds of things. So there are markers that can help sort of query that. and several of them are FDA approved, and I've listed some of them here. Some of them are based on proteins in the urine that are related to bladder cancer. Some are, like the CX bladder, is related to certain gene abnormalities that bladder cancer harbors. Eurovision Fish is looking at the heterozygosity of the chromosomes to determine whether these cells are abnormal or not. But none of them are the standard as yet in terms of being used consistently to assess for bladder cancer recurrence or to work up hematuria or any of that kind of thing. And some people will do that. They'll get one of these tests, you have hematuria, but that's really not guideline recommended. And so you can see here that in surveillance of non-muscle invasive disease, the clinician should not use biomarkers in place of cystoscopic examination. And then in a patient with non-muscle invasive bladder cancer, a clinician may use biomarkers to assess response to intravesical BCG or to adjudicate equivalent cytology. So again, if you if you want to assess how a cancer has responded to intravesical therapy, that's where these might have a role. Or as we were talking about, taking a positive cytology, the atypical cells, and determining whether it's really atypical, really could be a cancer cell or not. And imaging, I think we're all sort of familiar with this, but hematuria, whether it's microscopic or gross hematuria, is the usual workup is a CT urogram or an MR urogram if there's renal insufficiency that won't allow contrast administration. Or the other option would be retrograde studies, and often these are done in the operating room, so a little inconvenient. So usually if we can get a CT urogram, that's the way that we go. But CT urogram plus cystoscopy is the adequate workup for either microscopic or gross hematuria. When we find bladder cancer and we're monitoring for recurrence, upper tract imaging is recommended. Usually, every couple of years, depending on the risk level of the tumor. If the cancer that you're looking to recur was high grade or higher risk, then you might do these upper tract imaging studies more often, because the chance of developing upper tract urothelial carcinoma is higher in higher grade, higher risk types of tumors. What about staging and grading of bladder cancer? So to the right here, you can see this nice picture of the different levels of invasion of the bladder wall. And also there's a couple of special cases here that when you have a bladder diverticulum, the diverticulum sort of pushes through the muscularis propria. So there's actually no muscle layer here. So there's no T2. T2 would be muscle invasion, right? Invasion into the inner half of the muscular. But if there's no muscle to invade because the diverticulum has pushed the muscle aside, then there's no T2 with a bladder diverticulum. And then the staging of urachal remnants varies and might not be exactly like we see here. And then urethral involvement is always interesting, because if it's direct invasion of the urethra or the prostate by the cancer in the bladder, then that's really pathologic T4, so advanced cancer. But if there's a cancer in the bladder and then there's superficial involvement of the prostatic urethra, that's not T4. That would be two separate stages, a stage in the prostate and a stage in the bladder itself. And this is how it all kind of breaks down. I think, again, T2, superficial and deep muscle invasion. T3 through the bladder wall, either microscopically or macroscopically. And then T1, the lamina propria carcinoma in situ, flat tumor. And so I think we're all pretty familiar with that. What about grading? So basically, the old system was that we graded these cancers on a 1, 2, 3 basis, and 3 being high grade, 2 being sort of intermediate, and then 1 being low grade. But the grading system changed, so that we're just lumping them together as either low grade or high grade cancers now. And then there's this urothelial neoplasm of low malignant potential, which again is something that's not commonly called in my experience, but it is another, and this is a low grade, non-aggressive type of cancer as well. And then there's all these other things that you can see in the urothelium that the WHO pathologists have put together for this 2004 system, which we still utilize today. Conventional histology, 90 to 95% of these are urothelial carcinoma. 5% of the bladder cancers that we detect are squamous cell carcinoma. So again, increased risk in those who have indwelling catheters or, for example, spinal cord injury patients, and again, patients with a history of schistosomiasis that has involved the bladder with cystitis are significant increased risk of developing squamous cell carcinoma over time. There's about 0.5 to 2% of adenocarcinomas of the bladder, and this can either be at the dome of the bladder involving the urachal remnant, or it can be elsewhere in the bladder. So always try to, if you have an adenocarcinoma of the bladder, it's important to sort of distinguish between the two because they're treated and managed in different ways. Adenocarcinoma is significantly more common if you've had a history of exstrophy, of course, but inflammation and infection are the more common causes of these. One of the sort of guidelines is that if you have an adenocarcinoma of the bladder, since it's such a rare cancer, you should make sure that that adenocarcinoma, which is common in the colon, is not invading the bladder from the colon. So colonoscopy is typically recommended when you have an adenocarcinoma of the bladder that's not at the dome or at the urachal remnant of the bladder. What about variants? We really come to realize these histologic variants over the last 5 to 10 years, and that they, in general, represent a more aggressive subtype of these cancers. And it's not variant to have squamous differentiation or glandular differentiation. That's sort of normal. That's urothelial carcinoma that has differentiated into these other subtypes. That's not really a histologic variant. That's very common to see in these urothelial cancer, and a similar prognosis whether you have that or not. But pure squamous cell or adenocarcinoma are, again, they're much rarer, and they're often understaged, often deeply invasive or more advanced at the time that they are detected. And one of the rare kinds of bladder cancer or neuroendocrine type bladder tumors, you can stain with these entities to determine that. This is what small cell carcinoma of the bladder looks like. They are small cells. And the important thing, and this will come up on an exam, is that if you have a small cell carcinoma of the bladder, the first treatment is not cystectomy or neoadjuvant chemotherapy. It's this kind of chemotherapy with platinum and etoposide, because this is thought to be a systemic disease. This is such an aggressive variant of bladder cancer that it often is systemic, even if it's not evident on imaging studies. So always in these cancers, we start with chemotherapy before we decide whether cystectomy is even indicated. And these are the kind of cancers that can recur early too. Just a month or two ago, I had a young man who's 50-something, had a small, 2-centimeter tumor, just superficially invasive of the muscle of the bladder. Resected it completely, re-resected it, gave it chemotherapy, and then eventually, hey, there's no evidence of disease, did a cystectomy. And like 3 to 6 months after his cystectomy, he had metastatic disease show up in his liver. And it's one of those kind of tumors that's very aggressive. So this is a subtype that you need to be aware of. And again, chemotherapy, systemic treatment is the first step for those kinds of tumors. There are other variants, plasmacytoid, nested variants, which are also more aggressive. Micropapillary, which here's the micropapillary pattern over here to the right. This is one that we more commonly see. It's been thought to be relatively chemo-resistant, but there's been some reconsideration of that, honestly. And so, in other words, the answer was always, you have micropapillary, you should go do the cystectomy without neoadjuvant chemotherapy. And that was kind of the teaching of the past. But now we know, that some of these cancers, often they can respond as long as you're closely monitoring them while you're on that therapy. And micropapillary variants, it all depends on how much micropapillary you have, because sometimes you'll just have, it's not pure micropapillary. You can have micropapillary, histology within the normal urothelial carcinoma, high-grade urothelial carcinoma. So if you have 1% of the tumor is micropapillary, it doesn't mean you necessarily need to run to do a cystectomy, right away. Sarcomatoid, however, is very aggressive, and that warrants a cystectomy up front. And again, the general rule of thumb is that, remember, these histologic variants are aggressive, and they they are often understaged. So these are the kind of cancers that you got to be careful of and treat more aggressively than the run-of-the-mill urothelial carcinoma. Risk stratification. So it's important to define the risk of progression and recurrence, the need for adjuvant therapy, and the duration and the frequency or the protocol with regard to recurrence. Now there's some nomograms or risk calculators that can determine what the probability of recurrence and progression might be. I have to say I don't use those on a regular basis. This is a study that was done to calculate recurrence and progression by giving tumors a certain score. And you can see here that if you have more than 8 tumors, you get a 6 here rather than a 0 for a single tumor. Tumor size, did it recur previously? Was there carcinoma in situ associated with it, and the grade? And you throw those all together to get a score, and then you can use that score to actually determine more precisely what the chance of recurrence and progression might be. Again, you can use that information. Typically, it doesn't honestly change the management, at least the initial management. So this is important. So we have risk stratified these tumors, and the treatment approach to these tumors are based on this risk stratification. So a low-risk tumor is a solitary tumor that's low-grade and small. And then the punlap that I talked to you a little bit about. These are just benign entities. These are low-risk cancers. Intermediate risk is if you take this solitary low-grade tumor and you make it, and it recurs, then that puts it into the intermediate risk category. Or you take that cancer and you make it big, that puts it into a intermediate category as well. And then if it's multifocal, or if it happens to be high grade but small, but it's superficial, that's intermediate risk. And I have hardly ever seen a low-grade T1, because usually T1, it's invading the bladder wall, it's invading the lamina propria, so that usually doesn't happen with low-grade tumors, but it can. If it's a low-grade T1, then that's an intermediate risk cancer. And then all the other tumors are the ones we worry about, which are the high-risk cancers. High-grade T1, any recurrent TA that's high-grade, big tumor that's high-grade, carcinoma in situ, BCG failure. We talked about variant histologies, LVI, lymphovascular invasion. If you see that pathologically, that's another high-risk feature. So low, intermediate, and high risk is how we categorize these tumors now, and we manage them appropriately. So one example would be, a high-risk cancer. BCG, induction BCG would be recommended, and depending on the response to that, maintenance therapy would be recommended. Maintenance BCG therapy would be recommended for 3 years if you can get your patient there. Sometimes the intolerability of the intravesical BCG makes it such that maybe you can only give 2 years of treatment. But if you can do 3 years for these high-risk cancers that respond to BCG, that's the goal. Now, if you have an incomplete response to the first induction, and when I say induction BCG, we're talking about the 6-week weekly course of BCG. That's the induction. And so, TURBT, re-resect if you need to, and then 6 weeks of intravesical BCG. And then if you have an incomplete response, you can actually give another 6-week induction course, because about half the people that don't respond to the first 6 weeks induction can respond to the second 6-week induction course. And then, of course, you initiate maintenance therapy. But for high-risk cancers, it's 3 years maintenance with BCG. For the intermediate risk cancers, it's 1 year of maintenance therapy. And for the low risk, BCG is not indicated. This is complicated, so I won't go through it, but it kind of talks about what I just talked about. It's all about the risk category: low risk, intermediate risk, high risk. I don't want you to read all this, but again, it just shows how we manage these. And again, low risk we can use postoperative, chemotherapy, meaning chemotherapy that's given at the time of TURBT or shortly thereafter. That's indicated, and we just surveil these. Intermediate risk, we manage differently, and then high risk, we again definitely do intravesical therapy with BCG because it's the most effective form that we have. What about perioperative chemotherapy? I mentioned that here briefly. So within 24 hours of the resection, if the cancer is presumed or thought to be low risk or intermediate risk, then intravesical administration of usually mitomycin C or gemcitabine is indicated because it decreases the risk of recurrence by 35%. So that'll be a question on your test as well. So we use gemcitabine because it's equally effective and much less costly than mitomycin C. But mitomycin C was the standard intravesical therapy that was used for many, many years. You can't use these if you suspect bladder perforation or incomplete resection of the tumor. So again, this is a tumor that's low or intermediate risk. Complete resection is done. You put this in the bladder. We usually put it in the recovery area. So we put it in there and have them hold it for a while. But by definition, within 24 hours of the resection, it will decrease your risk of recurrence by 35%. This is, I think, it's just, this is just data that supports that. This is a randomized prospective trial. It was published in 2018, showing that the recurrence rate with gemcitabine was significantly lower than the recurrence rate with intravesical saline. And patients who had low-grade non-muscle invasive disease, didn't benefit much from the treatment. Intravesical therapy adjuvantly, again, we talked a little bit about this. So adjuvant means we're resecting, the bladder's clear, but we're going to give chemotherapy or immunotherapy, BCG, to prevent recurrence. I talked a little bit about induction being 6 weeks and then the maintenance cycle being 3 weeks. So 3 weeks of intravesical BCG given on average every 6 months for that 3-year period of time. And again, indicated only in intermediate and high-risk patients, not indicated in low-risk bladder cancer. And these are the agents that you can put in the bladder. Mitomycin C, gemcitabine, doxorubicin, docetaxel is a chemotherapy, and valrubicin. Valrubicin is indicated for carcinoma in situ that fails BCG, but it's not very effective long-term with response rates long-term of less than 20%, so not used commonly. Gemcitabine has risks and side effects, as does mitomycin C. Chemical cystitis, this is a common exam question. The chemical cystitis are skin reactions we can see with mitomycin C. With doxorubicin, we don't use very much anymore, but it was associated with cardiotoxicity. BCG, avoided if there's an active infection, gross hematuria, or urethral trauma. And the reason is that if you have gross hematuria or trauma to the urethra or an active infection, you've opened up the possibility that BCG can be absorbed systemically. And if BCG is absorbed systemically, that's when it can give you, BCG sepsis, which you don't want. So it's not utilized for low-risk cancers. You want to retain it in the bladder for a couple of hours, if possible. Some patients aren't able to do 2 hours with the BCG. Induction is 6 weeks, and then the maintenance, as I said, for 1 to 3 years is the SWOG or LAM protocol, which is a 6+3. And what we found with the use of BCG and maintenance therapy is that you can decrease the recurrence-free survival decreases, about 20% by doing this. And we're dealing with high-grade cancer, so if you can decrease the possibility of recurrence of a high-grade cancer, and also it can be associated with an improvement in progression. Progression is the cancer coming back at a higher stage than it started from. So adjuvant immunotherapy is the standard of care in high-risk non-muscle invasive cancer, 19% or 20% or so, I said, and for recurrence-free survival, and then progression. It's been shown to maybe have an effect on progression, but it's more, so BCG can affect recurrence and progression, whereas intravesical chemotherapies usually have no effect on progression. They can have effect on limiting recurrence of bladder cancers, but not on preventing progression, which again is why BCG is the preferred treatment for these high-risk cancers. We talked about the 1-year intravesical therapy versus 3 years maintenance BCG, depending on the risk level of the tumor. People ask that, if you're immunosuppressed, this is an immunotherapy, so it's stimulating the immune response locally within the bladder. So if you're immunosuppressed, do you get the same kind of effect? And there's a lot of debate about that. In general, it's thought that it might be less effective if you're immunosuppressed, but it can be safely given, meaning that you're not exposing someone to more side effects or the risks of BCG sepsis by giving it. And the other two drugs to think about is warfarin and statins, which might impact the ability of the bladder to bind what it needs to bind to elicit the local immune response. Immunotherapy with BCG has side effects that we think are most familiar with. The common ones are these inflammatory side effects. About 10% of people get a sense of a flu-like syndrome. Usually that flu-like syndrome is just for a day or two after the installation. If they get it, fever is uncommon, but about 5%. And granulomatous prostatitis is something else to think about, particularly when you have a prostate nodule. We often can see people that after BCG and maintenance BCG will develop a prostate nodule. And that's the BCG actually has found its way into the prostate, and there's a granulomatous focus in the prostate, and it feels like a nodule like prostate cancer. So seen that quite commonly actually. And then the significant side effects are BCG sepsis and severe cystitis. For severe cystitis patients, we can try to prophylax a little bit during the time of administration, but sometimes this limits the ability to administer BCG. Or what we can do is dilute the installation even to as low as 1/3 strength. And at 1/3 strength BCG, the studies have shown that it can have equal efficacy as long as it's sort of stimulating the bladder immune response. But most would say that full dose BCG for the very high risk patients is more appropriate if they can tolerate it than 1/3 or 1/2 dose of intravesical BCG. BCG recurrence, there's terms to sort of describe this which are kind of confusing. Refractory is persistent disease in the bladder after 6 months, or no progression, or progression of the cancer at 3 months. So if you identify that the cancer is still there 3 months after you given BCG, that's BCG refractory disease. Relapsing is categorized as whether it's early, intermediate, or late, depending on when that cancer came back. So somebody might have a good initial response to BCG and maintenance, and then 1.5 years later they develop a recurrence. That would be relapsing. Intolerant would be inability to receive it, and then unresponsive would be refractory or relapse within 6 months. And in these patients, there's no benefit to additional BCG. I said this earlier, but if you don't respond to the initial induction course of BCG, another course of 6 weeks of BCG can be given, because about 50% of those who didn't respond to the first induction course will respond to the second induction course. And it's sort of, unless your cancer is persistent in the bladder at 3 months, at the first 3 months cystoscopy, it's recommended that we wait 6 months, because the immunologic effect on preventing recurrence and progression can sometimes take as long as 6 months to sort of manifest itself. So got to be, in other words, giving another 6-week course of BCG, even if it doesn't work and they still have cancer at 6 months, some of them will. That's why 50% respond when they didn't respond initially. So if they are unable to take BCG and unfit for radical cystectomy, and the cancer recurs and it's high grade, then there's other intravesical options that can be tried, which are in general less effective. And then now there's systemic pembrolizumab, which is a checkpoint inhibitor that has been shown to decrease recurrence in those who are unresponsive to BCG. And then just a couple of slides about the shortage of BCG. This has happened 3 or 4 times in the last 10 years where there's just no BCG is not available. And the AUA statement on this is basically sort of common sense. Don't use it in low-risk disease. Chemotherapy should be used instead of BCG for those with intermediate risk cancers. If BCG would be administered as a second-line therapy for intermediate risk disease, an alternative chemotherapy should be used instead of the second-line BCG. This is a way just to preserve BCG at times where we lack access to it, because we really want to have this available to the true high-risk cancers. Again, that's what that first line basically says, and I talked to you a little bit earlier about whether the dose can be reduced by 1/2 or 1/3, a dilution essentially. And then this again is all about the BCG shortage and how you manage maintenance therapy in that kind of situation. The main point being that BCG should be prioritized for those that have more aggressive high-grade tumors. I said most of this. Cystectomy can be considered too. Patients are fit to have a cystectomy and urinary diversion. BCG unresponsive, non-muscle invasive bladder cancer. So these are some of the newer agents that have been investigated. Pembrolizumab we talked about. These other agents. There are some situations where patients are BCG unresponsive, they don't want cystectomy, that they'll respond actually to gemcitabine and docetaxel chemotherapy. So, and we're actually doing a clinical trial now where we're comparing BCG to gemcitabine docetaxel with the idea that perhaps we can define that gemcitabine docetaxel is equally effective to BCG, and therefore at times of BCG shortage we can utilize that more commonly. I talked a little bit about this checkpoint inhibitor. This was Keynote 057 study where the pembrolizumab is given IV every 3 weeks for 2 years. So it's kind of intensive, labor intensive to be coming in and getting an infusion every 3 weeks. But it has been shown to decrease the probability of a complete response and a durable response in those who don't respond to BCG. And again, this is the population that we have challenges with, right? I mean, if they respond to BCG, great, but if you're unresponsive to BCG and you want to keep your bladder, can we find other medications that can allow you to keep your bladder that are equally effective? And this is another, again, a medicine that has been investigated in the same way. What about surveillance? So this is guideline suggested and has changed. But for a low-risk cancer, you can do your first cystoscopy 6 to 9 months after that resection, and then annually. So it's not like every 3 months for 2 years like we do for the higher-risk cancer. So based on the risk level of the cancer, again, the recommended surveillance regimen is different and more intense the higher the risk the cancer might be. You have to be fit for surgery to have a cystectomy, but if you have high-risk, persistent, high-grade T1, so non-muscle invasive disease, then that's certainly a patient that cystectomy should be considered strongly for, particularly if they have variant histologies or lymphovascular invasion, and especially if the cancer is associated with carcinoma in situ. These are the kind of cancers that are going to quickly progress, so cystectomy is definitely something that should be in the conversation. So this is a non-muscle invasive cancer that perhaps would be best treated by cystoscopy and urinary diversion. Some have asked the question, well, what about some of these low-grade cancers? Can we just watch them? Can we just surveil them? Why do we need to resect them? And this is a study that actually showed that can be successful in a significant. Again, it's all about picking the low-grade cancer that you're watching. But if you have, and as often we'll do a cystectomy, we'll see this little 2-millimeter papillary lesion in the bladder. That's of no clinical significance, and you don't need to, do a resection of that. You could watch that, and you could do that very safely because it's low grade. And so this is just a study that documented that can be done. Cystectomy, just briefly, again, neoadjuvant chemotherapy should be considered in those who can tolerate it prior to radical cystectomy because it has a 5 to 8% absolute survival advantage with neoadjuvant chemotherapy. So for muscle-invasive bladder cancer, if you do, this is the USC data. John Stein is basically showing there's about a 60% chance, if all comers, of bladder cancer for you to survive in 5 years. But it's very much stage related. So if you have a T2, just muscle invasive without extension outside the bladder, then it can be as high as 65%. And if you were pathologic T0, so you got the chemotherapy, and then at the time of cystectomy there was no tumor found in the specimen, then your 5-year survival goes up significantly to 85%. But again, anybody that can tolerate neoadjuvant chemotherapy. Now, because this is cisplatin-based chemotherapy, there's a lot of elderly folks that have renal insufficiency and other reasons that they may not tolerate this type of regimen. But if you can get it done, it does improve outcome overall. Lymphadenectomy. So for many years, well, forever really, lymphadenectomy was a important part of radical cystectomy. The question always was, to what degree should you do the lymph node dissection? You know, if you listen to the people from Southern California at USC, they'll say you need to remove all the lymph nodes, up to the middle of the retroperitoneum, which seems a little extended. But does it change or optimize disease control to do that kind of extended lymph node dissection? And this is a SWOG trial that was it's not even published yet. It was just presented this year at ASCO. And this is an interesting study. First of all, to do a surgical study where you're randomizing patients to one level of lymph node dissection to another level is difficult to actually get patients enrolled in, but that's what this was done. And the surgeons who participated in this trial had to verify that they could do a high quality lymph node dissection by sending in videos and tapes and stuff about their work. And so the surgeons were of highest quality, and they were randomized to an extended versus a limited lymph node dissection, limited being kind of standard up to the external iliac vessels, so obturator, internal and external iliac, versus an extended, which would be above that up to the aortic bifurcation. And this was just reported, but there was no difference in disease-free or overall survival between these two approaches. And number of nodes removed in the extended node dissection were higher, as you might expect, but there's no difference in the probability of finding lymph node positive disease, which was interesting. And the adverse events were significantly higher when you did an extended lymph node dissection. So this is level 1 evidence now that we don't need to do these very high, more morbid type of lymph node dissections when we do a radical cystectomy. I'm not going to get into this. This is just FYI, stuff that you can review about some of the metabolic disturbances that go along with urinary diversion, be familiar with hyperchloremic metabolic acidosis and how to manage that. And these are, I'll just leave this to you to review, but these are the kind of things that people like to write exam questions about. And then bladder sparing. I talked about this earlier in the week at another presentation, but I'm not sure how many of you were there, so I'm not going to kind of go into this in detail, but it is guideline supported, meaning can you treat muscle invasive bladder cancer with other modalities besides removing the entire bladder and doing lymph node dissection? Well, bladder preservation with chemoradiation therapy is one of the options for patients that are motivated to keep their bladder, as long as you select the right tumor, right? And the tumor should be small. There shouldn't be hydronephrosis. If there's hydronephrosis, that usually means a deeply invasive or T3 cancer, no carcinoma in situ elsewhere in the bladder, and a visibly complete TURBT or even repeat TURBT. It's estimated only 10 to 15% of surgical candidates are in this category, but if you find somebody in that category, could you treat them with bladder-preserving treatments? I'm not going to go into this as I did earlier. I'll just come through some of this, but radiation therapy combined with chemotherapy has shown to be more effective than radiotherapy by itself in multiple studies. TURBT, depending on how radical your TURBT is important when you're doing these bladder-preserving types of strategies. And this is Harry Herr's paper that basically showed that, followed some of these patients who just had TURBT and followed them for 10 years, and there was a significant number of them that actually remained disease-free, but these patients were re-resected, so they had the resection and they went back and re-resected and were found to harbor no residual cancer, so they were favorably set up for long-term result from TURBT alone. And nobody recommends this by itself, but it just shows you that an effective TURBT is important in the management if you're doing bladder preservation. Partial cystectomy in some patients is an option. Tumors that are away from the base of the bladder, at the dome of the bladder, if they're solitary and the rest of the bladder doesn't harbor carcinoma in situ, then they are, that might be an option to consider, but chemotherapy neoadjuvantly, and also lymph node dissection still applies in these situations. Lots of times when we do partial cystectomies, we sort of forget about the whole idea of neoadjuvant chemotherapy and lymphadenectomy, but it should be still considered even though you're not removing the entire bladder. And then neoadjuvant chemotherapy, again, the gold standard is cisplatin-based chemotherapy, and dose-dense MVAC is becoming more and more the standard because the response rates, or the complete response rates, can be significantly higher compared to even gemcitabine cisplatin. The problem is defining who does have a complete response, because if you're going to do bladder preservation, you'd like to know that when you give chemotherapy that which of the patients had a complete response. You'll no longer have active tumor in their bladder. But this study showed that it's really hard to sort of know who those patients are. Radiation therapy alone is usually just a palliative indication. It's not guideline recommended as primary treatment for these cancers. The real question here is trimodal therapy, and so over the years this has become more and more something to consider. So first of all, it's radical TURBT, and then it's systemic chemotherapy combined with radiation. We call that radiosensitizing chemotherapy, and then the radiation is given, and then if there's no response, then radical cystectomy is done. That's a classic trimodal therapy description, and again, it has to be a certain patient population that's well selected. This is the Massachusetts General experience. They were the ones who initiated the whole idea of trimodal therapy for bladder preservation back in the 1980s. And basically they found that based on the stage of the cancer or the complete response or not, and also the completeness of TURBT, they all predicted both disease-free and overall survival. And as the years went by, they noticed that complete response rates improved and disease-free survival rates improved. So at this point in time, TMT can be considered for it's all about a well-selected patient. Because if you have a small tumor that's superficially muscle invasive, those are the ideal. The problem is if you're doing a TMT for a cancer that's deeply muscle invasive or extravesical, you're going to fail almost all the time. And this is given in either a split course where you give 40 gray of radiation, then you reassess, or you do the full 65 gray of radiation and then reassess. And then again, if there's persistent disease after that initial course of chemoradiation therapy, then cystectomy is where you should go next. And then follow-up is important. Cystoscopy on a regular basis, and CT urograms on a regular basis as well, because again, you've left the bladder intact. You don't know how much of a complete response you have, so these patients need to be monitored very closely. Is it comparable to radical cystectomy? Radical cystectomy has always been sort of the standard of care and thought to be superior to TMT treatment with bladder preservation. But there are some studies now that suggest that, again, in the well-selected patient, then the outcomes in terms of the cancer outcomes can be equivalent to cystectomy and urinary diversion. But again, it's about selecting the right patient. And this meta-analysis sort of showed that to be true, evaluating 12,000 patients. No difference in overall survival or disease-free survival between TMT and radical cystectomy. Now, I'm not going to talk much about metastatic bladder cancer, but basically we talked a little bit how it should be cisplatin-based if it can be. Some patients can't tolerate cisplatin, so other things need to be done. Immune checkpoint inhibitors are becoming more commonly utilized together with standard chemotherapy. And what has been found is that the response rates are improved to the treatment. And it's thought that the radiation can kind of upregulate the PD-L1 ligands, and so that allows these PD-L1 inhibitors, the checkpoint inhibitors, to be more effective, perhaps. So this is an area of active research right now, but it might be that if we do the chemotherapy and we add immunotherapy to it at the same time, we'd be more likely to have a complete response and more likely have patients that are candidates for bladder preserving therapy. This is some of the chemotherapy regimens that, and again, you can look at this in your slides. I'm not going to go through it in detail. And that's all I have to say about bladder cancer. Appreciate your attention. Thanks again for the opportunity.
Thank you so much for meaningful lecture. I especially appreciate your lecture from the anatomy to newly updated knowledge of blood cancer. Thank you again. Next lecture is Infertility and Andrology by Professor Hossein Sadeghi Nejad from New York University. Thank you for visiting, and I hope a great lecture for resident. Please, Professor.
Thanks very much. It's a pleasure to be here. I'm just going to set my own timer here to be sure I don't cheat. Give me 1 second. Okay, it's really nice to be here with residents. Are all of you from residents from South Korea? No, all different countries. A few from maybe Uzbekistan. Wonderful, welcome. So, by way of disclosure, these slides, I'm giving this talk on behalf of the AUA, so these are AUA slides, and I wanted to thank Sarah Vidge, who had made the slides. I made a few changes, and part of what I will talk about is what we teach and what's in the books. I will also try to say a few words about what we really do sometimes, which goes parallel with, but not necessarily exactly on the same course. I don't have any disclosures. So we'll talk a little bit about physiology and pathophysiology of male reproduction, evaluation of the infertile male, treatment of the infertile male, hypogonadism if there is time. That's why I set my timer, because there is just a lot of material to cover in 1 hour. So depending on how fast we go, if there is time in the end, I'll also talk about hypogonadism and testosterone replacement. In terms of the physiology and pathophysiology, one important concept for you to remember is the SRY gene, which causes cells of the genital ridge to differentiate into seminiferous tubules. Sertoli cells secrete the MIS, the Mullerian inhibitor substance, which causes Mullerian ducts to regress at 8 to 10 weeks. The remnants of the Mullerian ducts are the appendix testis and the prostatic utricle. I will just tell you that, again, this was in the slides, but that last part is controversial. I work with Dr. Ellen Shapiro at NYU, who actually did a paper way back when showing that the prostatic utricle is not a Mullerian duct remnant, but so that's controversial. Leydig cells form in response to SRY protein and start secreting testosterone, and that's how you get virilization of the Wolffian ducts. What I want you to take away from this busy slide is basically, again, the SRY. So that if you do have the SRY, right, you are going to get testicular development and the bipotential gonad develops into a male. If you don't have the SRY, the natural tendency, or the way nature has favored the system, is to go toward the ovary. And we always knew that females are on top and we're second, but that's nature's way of telling us that. So the Wolffian ducts develop into the vas deferens, the seminal vesicles, the ejaculatory ducts, the epididymis, and the cranial portion of the Wolffian ducts becomes the appendix epididymis. At 12 weeks of gestation, you already have continuity of the male gonadal tract, seminiferous tubules, getting to or evolving into efferent ductules, then the reedy testis, and finally the epididymis where the sperm mature. Again, if you don't have the SRY gene, then you get ovarian follicles. So this is a picture depiction of what I was just talking about. The very important concept for you to remember, I don't talk about it at length in this lecture, but the cauda epididymis and the caput epididymis have a different embryologic origin. So for example, when you have congenital bilateral absence of the vas deferens, you will have the head, you will have the caput epididymis, but the distal 2/3 of the epididymis will be different. You also can see here, you have the convoluted portion of the vas, which immediately follows the epididymis, and then, of course, goes into the straight portion of the vas, which is usually where we like to perform our vasectomies. Again, a picture of the anatomy of the testis showing the spermatogonia, Sertoli cells, the Leydig cells that secrete testosterone, the myoid cell, and then the basal lamina. And this is showing you the hypothalamic pituitary gonadal axis, again, mainly showing how hypothalamus secretes or responsible for GnRH release, which then affects the anterior pituitary, releasing LH and FSH, which then work on the Sertoli cells and the Leydig cells producing the testosterone. So spermatogenesis is a 74-day process that occurs in the testis, the immunoprivileged site, having been protected by the blood-testis barrier and the Sertoli cell tight junctions. You need to have a high level of intratesticular testosterone and DHT for the process to happen. The spermatogonial stem cells are divided into dark and pale spermatogonia, which are the pale cells are continuously self-renewing, and then the B cells, which are the immediate precursors to the primary spermatocytes. The important thing here is to remember that these are the cells that are most susceptible to gonadotoxins during development. So what about the physiology of male reproduction? Again, there are anatomic, environmental, iatrogenic, the pathophysiology of male reproduction, idiopathic infections and syndromes that can affect normal male reproduction. So this is an important slide because it shows you that much of male infertility still remains unexplained, right? We see these patients, we don't really have a good genetic cause for them, we don't have an anatomic cause for it. That's 34% of the cases. Varicoceles are a good portion, and then of course you have infection, sexual factors, undescended testicle, which can be responsible for infertility in 8%, and immune system factors. Let's talk about congenital bilateral absence of the vas deferens. This is something that is very near and dear to my heart because I trained at Boston University with Bob Oates, who is probably the smartest person that I know. And probably the best microsurgeon that I know as well. And most normal people, if they see patients with cystic fibrosis and they're missing a vas deferens, they basically go on taking care of them. If they need to do a testicular extraction, they would do it. But Bob started seeing these patients with cystic fibrosis, but then he was seeing patients who had the same exact anatomy. They were missing the vas deferens, right? But they didn't have cystic fibrosis. So the way his brain worked is, how is this possible? So he went to the genetics department at Boston University and he told them that he thought that this could be within a genetic spectrum, right? So then they did these studies and they found out about the mutation, meaning if you have two bad copies of the gene, typically the delta F508, but we know there are other genes involved, you could get full-blown cystic fibrosis, whereas if you have one bad copy and one mild copy, you could end up with CBAVD, and if you have two mild copies, you could again end up with CBAVD. So the condition can be unilateral, bilateral, partial, or complete. These patients have epididymal hypoplasia, but as I said, the caveat there, which I didn't add it to this AUA slide, but the caveat there is that the caput epididymis, the head is present. You're missing the distal 2/3, but the head is present. You will have seminal vesicle agenesis and hypoplasia, which is the reason, by the way, for our students, our residents, this is the reason why these patients end up with low volume ejaculate, right? Because 70% of your ejaculate volume comes from the seminal vesicles. So somebody who's missing the vas, you'd be thinking, well, why do they have low volume ejaculates? Well, you know only very little comes from the vas deferens. The reason is the seminal vesicles are atrophic. And they can also be associated with renal anomalies, especially in the congenital unilateral absence of the vas deferens, and that also was a Bob Oates paper. So you should check a renal ultrasound in these patients. As I said, the seminal vesicles are responsible for 60 to 70% of the seminal volume, and that's why the seminal vesicle contributions contribute to the pH of the semen being alkaline. So you do not need to do a fructose test. In your generation, less and less the labs are doing it. My generation labs were checking fructose, and it's totally unnecessary. If your pH is not very acidic, you know by definition there has to be a seminal vesicle contribution. Okay, so that's very important. Prostate contributes about 30 to 40% of the semen volume, and that's the acidic component, and the testes own under 5% of the semen volume. So overall, in the CBAVD patient, right, the classic CBAVD patient, there are two conditions, and I'll talk to you about them today, that will give you low volume low volume azoospermia, right? So one of them is congenital bilateral absence of the vas deferens. Can any of the residents tell me what the other one is? Low volume azoospermia. Just throw it out. If you're wrong, it's fine. Where? Correct, but you're warm. So ejaculatory duct obstruction, right? Because if you have obstruction at the level of the testicles, that's not going to give you a low volume ejaculate, because we said 70% of that volume comes from the seminal vesicles. So it's only if you have obstruction at the end of the road, at the level of the ejaculatory ducts, that's when you end up with a low volume azoospermia, right? So those two conditions, CBAVD, ejaculatory duct obstruction, are the two main causes of low volume azoospermia, and in both of them you're going to have very acidic semen analysis. Why? Because there is no contribution from the seminal vesicles. A clinical point. So in CBAVD, there are CFTR mutations identified in 78% of men, and 40 of men with CBAVD, and 40% with KUA-AUA, congenital unilateral abstinence. And in CBAVD, 46% have two mutations. Treat men with CBAVD as if they are cystic fibrosis carriers, independent of genetic findings. Why is this so important? So again, I may not finish my slides because there are points that I think are very important to emphasize, and this is one of them, right? So in the North American population where I practice, right, I tell people this is one of the most important things I could teach you, that if you have somebody with CBAVD, right, it is very, very, very important for you to do genetic testing, right, and genetic testing of the spouse. Because what are the chances that the spouse is a cystic fibrosis gene carrier? What are the chances? Throw me any number. 1 in, how much? Say it louder. 1 in 2,000? We have 1 in 2001, 1 in 2002. Any other takers? It's actually 1 in 25. It's very, very high. Carrier, right? Not cystic fibrosis, but just a carrier. That's why if I have a CBAVD patient, right, and he has one of those bad copies, and I didn't test the spouse, right, and the spouse has a 1 in 25 chances of being a carrier, I am now contributing to that baby being born with full-blown cystic fibrosis. Okay, this is very, very important. So please remember that. And the physical exam is the key to diagnosis, right? You guys are young, you're just starting. But if you've been in practice for a few years, I always remember Bob Oates telling me that if you're sitting there and you're really struggling to find that vase, well, the chances are it's not there, right? So you have to trust your exam. And I tell my residents that the vase feels like the al dente macaroni, right? So the rest of the cord is kind of a little bit mushy, and then the vase feels much harder. So if you're struggling to find it, just tell yourself, well, maybe this guy doesn't have it. And what are the other things that help you make that diagnosis? Well, we already talked about the pH, right? The pH is very acidic, and they have a very low volume. So that's important. So let's do this question. A 29-year-old male presents for fertility evaluation. His wife is 28 with normal workup. He has a history of left inguinal hernia repair as an infant. Semen analysis demonstrate an ejaculate volume of 1.2 cc's and azoospermia. Physical exam reveals a testis size of 26 cc's on the right and 10 cc's on the left. 26 right, 10 left. His right vase is not palpable. His left vase is palpable. The next step is, so these are your choices. CFTR, and we don't have the voting thing, so so you can do CFTR testing, you can do sperm retrieval and ICSI, ultrasound of the scrotum, or Y microdeletion testing. So let's see a show of hands for Y microdeletion testing. Y microdeletion testing. No show of hands. I hope we don't end up with no show of hands for all 4 choices, because that would not be a good thing. So ultrasound of the scrotum. Who wants to do an ultrasound of the scrotum? 1 person for ultrasound, 2, 3 ultrasound, 4, okay, more takers. How about sperm retrieval and ICSI? Let's take him to the operating room and operate. Sperm retrieval and ICSI, sperm retrieval and ICSI. Okay, and what about CFTR? So CFTR, by the way, I don't know if I mentioned this. So that stands for Cystic Fibrosis Transmembrane Regulator Protein, right? It's basically genetic testing. Who wants to do CFTR testing? No takers. Okay, so I'm glad we're doing this, right? I'm glad. So the answer is actually CFTR testing. And the reason is, remember, to go back, let me go back to this question, right? So you have a 25-year-old patient. You're doing a fertility evaluation. His wife is 28. So on one side, he had a left inguinal hernia repair, and his ejaculate volume is kind of low, and he's azospermic. But physical examination showed that one side was 26 cc's, that's a good size testis, and the other side is 10. Well, the size that's 10 is probably because of that hernia effect, right? That sort of became atrophic. But the key point, that's how you figure out the answer to this question, is this next sentence, right? His right vas is not palpable, right? So he has KUA-AUA, right? And you have to do genetic testing. So this patient has an absent vas on the right and an atrophic testis in the setting of prior hernia repair. The most likely diagnosis is KUA-AUA and contralateral testicular failure resulting in azospermia. He needs testing for CF mutations. He will also need a renal bladder ultrasound. So you were not wrong to say renal bladder ultrasound, but in terms of the order of things to do, I would say this one takes precedent. Karyotype and Y microdeletion are not indicated. We'll talk about those in a second. So those are not indicated in this patient with an anatomic problem. He has KUA-AUA. If his right testis is normal and obstructed. Were you to get a hormone profile, it should be normal, right? So because patients with CBAVD, KUA-AUA, they have normal production, they just have an obstruction, right? So that's a very different scenario than people who have non-obstructive azospermia. What about cryptorchidism? I actually had a patient, I was in New Jersey at Rutgers and Hackensack for 25, 26 years of my life, and as of May, I retired from those jobs and I got a new job as director of men's health at NYU. So since May, I have seen 3 patients, 3 adults with cryptorchidism. And one of them actually I operated on a couple of weeks ago. It's affecting 1 to 9% of infants, 7 to 30% of premature infants, and in 1 to 7% the problem persists. In other words, they could be born with it, but as they age, right, by 1 year of age, some of them, the testicle descends, but about 1 to 7% can still have cryptorchidism. The patient that I saw, that I operated on, was a 27-year-old man who came from Côte d'Ivoire, from Ivory Coast in Africa, and he hadn't gotten care. Nobody had really attended to this problem. One testis was upper inguinal, and the other one was intra-abdominal. And by the way, the textbook answer of what you do for the intra-abdominal testis, right, in a 27-year-old is you take it out, right? In this case, it was kind of just by the ring. He said sometimes when he exercises, he feels it coming down. So we may be bold down the line and try to bring that one down, although that's not technically the right thing to do. We're still working on it. The side that was upper inguinal, I was able to bring it down and leave it in the scrotum because in those patients, if you wait a year or 2, you can, in some cases, find some sperm. Anyway, so you will see history of cryptorchidism in about 20 to 27% of men with azospermia, and 3 to 8% of men with oligoacid or teratospermia will have a history of cryptorchidism. Then I want to talk about ejaculatory duct obstruction very briefly. That was, remember, the second diagnosis that I said. So the way the AUA slides are organized and are a little bit different also than the way I have historically given this talk. I actually also like to think about low volume azospermia and normal volume azospermia. So if you think about low volume azospermia, we talked about the CBAVD, KUA-AUA, and then this is the second one, right? The ejaculatory duct obstruction. So you can have a partial or complete obstruction of the ejaculatory ducts. You get obliteration, narrowing, or external compression by a Müllerian or Wolffian duct cyst or utricle, a prostatic utricle, right? And also stones in the ejaculatory duct could do this. So, by the way, have any of you seen an ultrasound of a patient with a prostatic cyst that has ejaculatory duct obstruction. You may not have seen it, but it's very interesting. These patients will present with low volume ejaculate, right? Like instead of the 2 cc's, they may have 0.1 or 0.2 cc's. And then when you do a transrectal ultrasound, it's as if you're looking at a black ping pong ball in the middle of the prostate, right? That's the prostatic cyst. And that cyst is blocking the ejaculatory ducts. And the solution, we'll talk about it in a second, is I guess I talk about it a little bit later. The solution is actually a 5-minute procedure, which we'll talk about. So let's also talk about varicocele. So varicocele are abnormal dilation of the spermatic cord veins. We don't like to use this term, but it still shows up in some textbooks as a sort of a bag of worms. Several mechanisms of fertility impairment have been proposed: hypoperfusion leading to hypoxia, heat stress, oxidative stress, and hormonal parameters. It's present in 15 to 25% of males, but 35 to 60% of men with infertility. So when I see a patient with varicocele, I tell them, look, I don't want you to be concerned about this. It's the same concept. Sometimes you see adults with very dilated varicose veins in their legs. This is kind of the equivalent in the spermatic cord, and it is very common. 1 out of 5 guys walking on the street could have varicocele, but if you have abnormal semen parameters, it's a lot more common. Up to 1 in 2 of them can have it. And it's the most common reversible cause of male factor infertility. This slide is a little too busy. It just shows all the ways that varicocele can affect fertility. I'm not going to spend much time on it. It is more common on the left side because of the right-angled insertion of the left spermatic cord vein into the left renal vein. You can also have the nutcracker phenomenon, which is compression of the left renal vein between the superior mesenteric artery and the aorta. So again, that back pressure leading to varicocele. You can also have pathologic venous compression from retroperitoneal tumors, etc. So that's why historically it's been said, if you see a very prominent isolated right-sided varicocele, have a little bit lower index of suspicion for doing imaging studies to be sure there's no upper tract tumor causing this, right? But again, that's not very common. The importance of this slide is the bottom part, right? We do not like to operate on subclinical varicocele. So we do not like to operate on varicoceles that have just been picked up on ultrasound, right? And we think of varicoceles as grade 1, grade 2, or grade 3. Grade 1 are those that are small, palpable with Valsalva. It's incredible how difficult it is to get men to understand how to do a Valsalva. I tell them, can you please do a Valsalva? And they go, whew. I said, no, please do not exhale. Just inhale and then bear down. And it takes sometimes a few tries for them to get it. But when you do a proper Valsalva, you can elicit it. Also, if they have been picked up by ultrasound, or if you're getting an ultrasound to confirm if on the other side there may be something, it's very important that the sonographer tells them to bear down, stand up, or increase intra-abdominal pressure. Grade 2, they're moderate, palpable when standing without Valsalva, and grade 3, they're standing and you could see this kind of bag of worm thing that we talked about. What about hyperprolactinemia? Present in 1% of the general population, prolactinoma is the most common cause of hyperprolactinemia. Prolactin inhibits pulsatile GnRH secretion, resulting in reduced LH, FSH, and testosterone. So one of the things that's very important is if you see a patient that you've checked their testosterone and it is low, it is very important that you check their prolactin level, especially if you do not see the LH and FSH changes we talked about. Elevation in prolactin on 2 occasions without a clear benign cause should prompt MRI of the pituitary. Prolactin to testosterone ratio of greater than 0.1 or prolactin greater than 25 are predictive of a positive MRI. And you could treat these patients. And the reason that's important is if you look at the lab ranges, patients can have very slight elevation. But if it is over 25, then you have a higher chance of the study of the MRI actually showing a prolactinoma. And you could treat these patients with dopamine agonists such as cabergoline. If there are larger adenoma, we refer them for surgery, and a neurosurgery or ENT team operate on them. All right, what about iatrogenic infertility? So we know that chemotherapy and radiation can cause infertility. This depends on the agent, dose delivered, the site, and the schedule. The cells that are mitotically and meiotically active are the most sensitive. Surgical causes, iatrogenic injury to vas deferens. Again, this is often seen when in the pediatric population undergoing hernia repair. It can also happen in adults, but they would not even be aware of it if the other side is unaffected. You can have testicular atrophy because of injury to testicular blood supply, and then of course the retroperitoneal and pelvic surgery that can result in anejaculation or retrograde ejaculation. What about syndromes? Cartaginer syndrome, this is a type of primary ciliary dyskinesia. It's an autosomal recessive ciliary disorder, affects 1 in 30,000. You have problems with sperm motility associated with situs inversus, bronchiectasis, and sinusitis. Have I ever seen it? The answer is yes, once. And so that's when you listen to the patient's heart on the left side and there's actually nothing and everything is flipped over, right? So it's a very fascinating case. Diagnosis made with electron microscopy, genetics evaluation, and the treatment is ICSI. Kallmann syndrome. So this is more common, absent GnRH production. The one thing that I will tell you right now that's not in these slides, but important for you to know, especially if you go into areas where you are dealing with andrology patients and infertility, not all hypogonadotropic hypogonadism patients have anosmia. So just because a patient does not have anosmia and they can smell it does not mean that they don't have this. There are variants of this that can be associated with normosmia. All right. So typically those associated with anosmia poorly develop secondary sexual characteristics and hypogonadotropic hypogonadism. These patients have absent pubertal development, no secondary sexual characteristics, a delayed growth spurt, low libido, and sexual dysfunction. And as we said, because that GnRH system is not working well, think of low LH, low FSH, and low testosterone. You treat them with testosterone replacement, GnRH, HCG, and HMG, that's human menopausal gonadotropin or recombinant FSH. 84% of these patients have return of sperm to the ejaculate by 18 months. Okay, it's very, very reassuring and nice to see these patients who had zero sperm, and with medical therapy a year later, all of a sudden they have normal spermatogenesis. It's very, very nice for them. Okay, Klinefelter syndrome. This is kind of a popular one in all the textbooks. All of you remember it from your medical school days, and everybody talks about it. And the fact is, not all Klinefelter's patients are created equal. And I'm not even talking about the mosaic versus the non-mosaic. Even in the non-mosaic version, there is a very wide variation of these patients. Overall, Klinefelter's is present in 1 in 500 to 1 in 1,000 men, and 11% of azoospermic men can have the problem. It's the most common sex aneuploidy anomaly in men and results in substantial germ cell loss, but there's significant phenotypic variance, as I said. The patients can have increased rates of diabetes, lung disease, cancer, epilepsy, cerebrovascular disease, breast cancer. Breast cancer is an important one. I've seen 2 patients with that, and non-Hodgkin's lymphoma. The treatment is you have to treat the hypogonadism as well as the infertility. Now, in these patients, remember, just like everybody else, if you put them on testosterone, per se, at some point, if they have any spermatogenesis, you could shut it down. So you have to be careful with that. But again, these are patients who typically will have very low testosterone. And if you do a microsurgical testicular sperm retrieval, you can find sperm in about 44% of them. Okay, what about evaluations? So first of all, who do you evaluate? Couples who fail to achieve a pregnancy after 12 months of regular unprotected intercourse, but you could have a justification for earlier evaluation if the medical history indicates it, or the female partner is older than 35, the reason being that timing is of the essence. These patients may need high-level assisted reproduction. You don't have to have them wait 1 year before you do the workup. It's also justified if a man has a concern about their future fertility and comes to you asking for that. We ask for timing and frequency of intercourse. So these are all important things to think about, right? When you're starting your practice, seeing these patients initially, things to ask, the timing and frequency of intercourse. It's amazing how many of my patients don't know about the normal ovulatory cycle. I mean, you could have all the sex you want the first 5-10 days after the cycle. You're not going to get your wife pregnant, you know, and it's amazing how many patients don't know that. Duration of infertility, prior pregnancies, childhood illnesses, specifically mumps, systemic medical conditions such as diabetes, upper respiratory tract infections, prior surgeries, medication, sexual history, exposure to toxic chemicals, radiation and heat, family reproductive history and social history, illicit drug use, tobacco, and alcohol. All very important. How about physical examination? Look at where the meatus is. Does this patient have hypospadias? Is the problem that they cannot deposit the sperm where it needs to be deposited? Measurement of the testis size. If the patient has a soft, small testis, you already have a very high chance of having this patient having non-obstructive azoospermia or oligospermia. Are the vasa there? We talked about that. Is the epididymis there? Now, this is a harder thing to tell. I will tell you that even after years of practice, it is difficult. In the old days, the urologist would examine the patient without gloves, right? Seems like crazy to us nowadays. Like, who would examine a patient without gloves? But they would examine the patient without gloves. Well, you had a better chance of telling if somebody had an epididymis or not than if you're double gloved, you know, with these thick gloves. But it is important to at least think about it. Presence or absence of varicoceles, secondary sexual characteristics like body hair distribution, body habitus, and breast development. All right, semen analysis. This is a cornerstone of an evaluation of our infertile patient evaluation. Excuse me. You do not want to base your decision on just one semen analysis, right? So especially if you're going to operate on a patient, it should be based on 2 separate semen analyses that are about a month apart. I added this slide to the AUA slides because this one is critically important that you be aware of it. First of all, even though I come from a very sophisticated city, I come from New York City, and I use dedicated andrology labs, it is incredibly disappointing to see that some of the dedicated andrology labs are still using some of the older criteria. They are, for example, if the Kruger morphology, let's say, is 10%, I have seen these labs send to the patient a report that says abnormal morphology. Well, hello, that changed a number of years ago, and I don't understand why they haven't changed it, but the patients get very, very perturbed about that. So this is the updated number, the volume 1.4, and by the way, volume is a little bit more subjective because you have to be aware that if the patient is going to the lab, right, to produce a specimen in the lab, there may be a collection issue. So if he doesn't tell you, or the wife doesn't tell you that he normally has a tiny drop of ejaculate, you know, I don't worry about the volume being 1 cc or 0.9 cc. I worry about the guy who has 0.5 cc and a very acidic pH, right? So that's important. Concentration, 16 million per cc. Total motility, 40%, and 4% morphology. But this is Kruger morphology, right? So we tell patients, you are looking at absolutely perfect sperm, right? So that's very important. So 4%, they see the number 3%, they're flipping out, oh my God, I'm 97% abnormal. No, if you were 4, you'd be normal, right? So that's very important to remember. Endocrine evaluations. So these are from the American Society of Reproductive Medicine recommendations. Patients who have abnormal semen parameters, impaired sexual function, other clinical findings suggestive of an endocrinopathy, or failed ART cycles, assisted reproduction cycles, or recurrent pregnancy loss. At a minimum, you should evaluate testosterone FSH. So any patient that comes to my office for fertility evaluation, I do an FSH and testosterone. Now, in reality, in my practice, because it's so hard to get back to come and see me, it's so busy, I may order LH, FSH, and testosterone, as well as prolactin and estradiol. But at a minimum, you should do a testosterone and FSH. What about a post-ejaculatory urinalysis? Well, let's think about it. Why are you doing this? Well, you're thinking about retrograde ejaculation, right? So consider in the setting of absent ejaculate, low volume ejaculate, high risk for retrograde ejaculation with oligospermia. There is no defined cutoff for normalcy in non-azo patients. The AUA best practice statement tells us that it should be performed in men with ejaculate volume less than 1 cc, except in patients with CBAVD, because as we said, we know that they're going to have low volume, or those with significant hypogonadism. Additional testing, ultrasound of the scrotum. It is not routinely recommended as part of your fertility workup. Okay, so it's not routinely workup. When do I get an ultrasound? I get an ultrasound if I, for example, have a clear-cut varicocele on one side. The patient is going to the OR, and I'm really not sure about the other side. In that case, I may get an ultrasound, and if they fulfill the ultrasound criteria of a varicocele on the other side, I'll tell the patients, look, we're going to the OR. If you want, I can fix the other side as well, even though right now it's not a definitely clinically palpable varicocele, and so we do that in that setting. Transrectal ultrasound of the prostate, as I said, we do this as part of the assessment for ejaculatory duct obstruction. You can consider in cases of low volume ejaculate with oligospermia, seminal vesicle AP diameter more than 1.5 centimeters is consistent with ejaculatory duct obstruction. Anti-sperm antibodies, I would say nowadays in 2023, this actually goes back probably 10 years, we rarely do it. There's hardly an indication for doing it because even those patients who have anti-sperm antibodies, now they're candidates for IVF, so it's really not going to change your management. Same with checking for reactive oxygen species or leukocyte quantification. The one thing that is listed here as plus minus, and I will tell you that in real life happens, is we sometimes do DNA fragmentation testing. These are patients with unexplained infertility who have varicoceles, but who have varicoceles who have a normal semen analysis. If the DNA fragmentation testing in those patients is abnormal, it is a soft indication for going and fixing their varicoceles. What about karyotype? Karyotype testing is very important. I said when we were doing the questions, I said we'll talk about this in a second, right? So this is indicated in men with non-obstructive azo or concentration less than 5 million per ml, recurrent pregnancy loss. Y chromosome microdeletions, this is indicated in men with non-obstructive azo or concentration less than 5 million per ml. And cystic fibrosis gene mutations are indicated in men with CBAVD, KUA-AUA, or idiopathic obstructive azospermia. Now, why microdeletion testing? This occurs in the AZF region of the long arm of the Y chromosome. You are familiar, you've heard of the terms AZF-A, AZF-B, and AZF-C, right? So remember, A is awful and B is bad. A is awful and B is bad. If a patient has those problems, you are not going to find sperm doing a testicular sperm extraction. You do not take them to the operating room, right? That's a mistake. AZF-C is a different ballgame. You can proceed to microtesting. Sons of individuals with Y microdeletions will inherit the abnormality and have infertility, okay? So this is an AUA slide. It's a great slide, but there is a caveat to this, okay? So the reason this is so important is, as I said, in AZF-C patients, we can find sperm, right? So let's say one of you guys, a patient, goes to the patient, God forbid, goes to the doctor, they do the testing, you have AZF-C, you're devastated, but the doctor tells you, look, we can actually go and do a biopsy and find sperm, right? So let's say they do that and the offspring is a boy, right? So the fact that they found sperm in you was great. But what you have to be aware of is that will the son have the same problem as you? Will they or no? Who would say the son will have the same problem? Show of hands for who says the son will have the same problem as the dad. Only one taker. The rest of you think the son is going to be perfectly fine? 2 takers. The son will have exactly the same problem, but it could be worse. Because the fact that I found a sperm and was able to get a pregnancy meant that there was a sperm. But they should be told that the son could be completely azo, and we may not find any sperm. So that's very important information for them. Okay, how about medical treatment of infertility? Well, you could give them Clomid, you could give them anastrozole, HCG-FSH, and the antioxidants. What is clomiphene? Clomid is a selective estrogen receptor modulator that blocks negative feedback at the level of the hypothalamus and the pituitary. It therefore will lead to elevation of LH and FSH and therefore testosterone. So just a fun clinical caveat about Clomid. Some of you who may have been to some of the sexual dysfunction lectures that we give or in your attendings practices, you may have seen that Clomid is also used to raise testosterone. It does, and it's very good for that. But there is a but. And the but is that because it blocks the estrogenic system, one of the more common reasons why it is given is to the patient who has low libido, right? And interestingly, even though it brings up the testosterone, we find that for many of those men, it doesn't fix the libido problem. Their testosterone comes up, but they still have low libido. So this is kind of like an infertility 202 lesson. It's important for you to know. Yes, the testosterone comes up, but because of this anti-estrogenic effect, the libido may not improve. What about anastrozole? So this decreases estrogen production by reversible inhibition of aromatase. So who is a good candidate for this, right? Any of you, just throw, who is a good patient? Well, I'll start it for you. Who is a good patient with low testosterone who could be a good candidate for anastrozole? It decreases the estrogen production, right? So what enzyme converts testosterone to estradiol? Aromatase, right? And where do you have a lot of aromatase? Where? Fat, exactly, right? So the overweight patient who has low testosterone and you keep giving him testosterone and he's getting breast enlargement, you know, that's a patient who would benefit from anastrozole, right? So it's a good clinical thing to remember. What about HCG? I use HCG a lot because in my practice, I get a lot of guys who come in. They're these ex-bodybuilders. Their arms are the size of 2 of my legs put together, but their testicles are the size of a pistachio, right? Very, very small, right? So these are patients who've been on androgenic steroids for a while, right? They are very, very fit with very, very small testicles, right? And what's amazing, though, is that if you stop testosterone, first of all, depending on how long they've been on androgenic steroids, some of them can recover testosterone production and some of them can get a decent testicular size. And then if you put them on HCG, right, and the dose is pretty high, you put them on something like 2,000 units 3 times a week, you know, a lot of them after a while will start producing testosterone. And those that don't, and their semen analysis improve. And those that don't, you could treat with HMG. So it's a first treatment for LH. So first treat LH deficiency. It's cheaper. Occasionally is not only agent required. So HCG, as we said, 1,500 to 2,000 units 2 to 3 times weekly for 18 to 24 weeks. I would say 24 weeks is usually the minimum. The thing to remember about HCG is that basically it's an LH analog, right? So biologically equivalent action to LH and centrally stimulates release of LH and FSH. That should be and FSH. And your goal is to get the testosterone to be more than 300. If necessary, you could add FSH. That's a recombinant FSH until pregnancy is achieved, and you could use human menopausal gonadotropin or recombinant FSH. And the outcomes we talked about already: increased testicular volume. Average increases in studies have been shown from 4 to 12 cc's. Induction of sperm production. Ideally, we want to get over 5 million, and natural conception may be positive. Okay, what about ejaculative dysfunction? One is premature ejaculation, and for premature ejaculation, SSRIs have been used. This is off-label use, at least in the United States. SSRIs have not been approved in the US for this use, but typically we give them things like Zoloft, low-dose Zoloft, and again, this is not in these slides, but the way I do it in my practice is that I give them 50 milligrams daily for a month. Then I tell them you could go to every other day the next month. Then you could go to every 2 days, and then of that cohort, a certain percentage can actually use it on demand. I would say it's about a quarter of them, but it is very effective. A topical lidocaine has been used as well, but this particular one, the topical lidocaine per se, is not very pleasant because one of the effects is that it also affects the partner, right? So there is one particular one that's called Promescent, which is a very fast-acting one, and that one is actually more effective. It's a spray, and that one I have found in my practice to be more helpful. Retrograde ejaculation. For this, we give them alpha agonists, phenylephrine and imipramine. Now, so what is phenylephrine? Basically Sudafed, right, that we take for colds. Now, the regular Sudafed that we buy from pharmacies in the US, I don't know if it's probably the same here and in your countries, is 30 milligrams. right? So you have them take 4 tablets, or better yet, they could take 3 to 4 tablets 2 or 3 times a day. Okay, that's a very high dose. And some of them get headaches and they can't tolerate it. But if you're going to affect the system by closing down that bladder neck, you have to give them higher doses. So you could give them up to 4 tablets 2 or 3 times a day, very high doses, and see if that works. You also alkalinize the urine with sodium bicarb and harvest sperm from urine for IUI. IUI, as we said, is intrauterine insemination. And ejaculation, these are patients who may need penile vibratory stimulation or electroejaculation. When I was in my residency in Boston, we did electroejaculation. It's done in some centers, but it's very, very specific. When I was in New Jersey, I didn't do it because we have a very major a spinal cord center that took care of Superman. If you remember, he was Christopher Reed's when he got paralyzed. He went to that center. So those guys were doing all the electroejaculation. So I just don't do it in my practice. But obviously, it's a very important part of treatment for some patients. And of course, you could do surgical sperm harvesting for those who do not respond to those treatments. All right. How about the surgical treatments? It's not necessary to establish the cause of azoospermia in patients with findings suggestive of non-obstructive azoospermia. You can consider diagnostic testicular biopsy in women with normal testis size, at least 1 palpable vas, and normal FSH. Now, in my own practice and the way I have learned, I am against a diagnostic biopsy in almost all cases. Because the moment you do that diagnostic biopsy, well, first of all, the reason I'm against it is in 99.9% of the cases, with the information that I shared with you, you can make the diagnosis before that. I don't need to take the patient to the operating room to make that diagnosis. And the moment that you take them for a biopsy, you put them back 4 to 6 months, because that's how long it's going to take for that testis, typically a small testis, especially if it's a non-obstructive azo, to recover function, right? So if you're going to do it, you might as well combine it with a sperm cryopreservation procedure. But be that as it may, you can do biopsy in certain cases. And the way you could do it is, they're showing you here is a fine needle aspiration, or you could do what you see on the right side. You could use a biopsy gun. I've done this in some post-vasectomy cases where the patient really did not want to pay for the operating room. They just wanted the least expensive way of getting sperm, and you could use a biopsy gun. This is the same thing pretty much as was used for prostate biopsies to get testicular tissue. In an obstructive case, you're going to have plenty of sperm, and that's enough for the IVF people. So who should we treat for varicoceles? These are the indications for repair by the AUA and ASRM. Those with palpable varicoceles, we talked about this, documented infertility. Now, this part is very important, right? I should not do a varicocele repair if the wife for sure is going to need IVF, right? Because unless the patient has azoospermia, and that's a very small group of patients who have varicoceles and azo, that's a special group. But in general, for patients who have sperm in the ejaculate, if the wife is at an age where they're going to need IVF, there's no point for me to fix the varicocele. They should have abnormal semen analysis, and of course, adolescents with varicocele and ipsilateral atrophy. These are the different ways where varicoceles can be operated on. By the way, I'm going to give you another quick anecdote that's not here. So when we talk to patients about varicoceles, we should also talk to them about the other way to fix a varicocele. So you see all of this, right? So what is another way where varicoceles can be treated? Embolization. All of you have read your textbooks. Excellent. It's the right answer, but it's a bad option. Why is it a bad option? Because, these are my opinions. This is not the AUA. This is Seregi. So the reason it's a bad option is that it's billed as a minimally invasive procedure. It's actually not that minimally invasive when you consider that a microsurgical varicocelectomy can be done through a very small incision. In my 26 years of practice in New Jersey and now in New York, I have never, ever had a patient where I went in there, tried to do a varicocelectomy, and closed them up and said, I'm so sorry, we could not do your varicoceles, right? It just doesn't happen, right? I've been at NYU since May. I've already seen 2 patients who were referred for embolization, and the surgeon said, the radiologist said, I'm sorry, we couldn't do the embolization, right? Because they don't do a lot of it, because most of the varicoceles are seen by infertility specialists. So even though I love our IR colleagues, they bail us out when we have kidney bleeding, all kinds of problems, this is not something that I would recommend going to them for. That's number one. Number two, and I kid you not, this is the honest truth. Again, I've been there since May. I gave the same spiel that I'm giving to you to one of my patients. The next day, I get a call from my sister-in-law, who's a very famous cardiac surgeon in London. She's the only professor of cardiac surgery who's a female in London, England. And she calls me and says, "What the hell are you guys doing, putting coils in people's scrotum?" I said, "What are you talking about?" "I don't put coils in people's scrotum." She said, "Yeah, I just got a call from some of our urology colleagues. They're panicking because they had sent a patient for embolization, and these coils have made it to the heart, and now I have to go and crack the guy's chest to take the coil out." Right? Of course, that's a rare case, but I begged her to please publish it, because this is what I've been saying all along. This is not the most non-invasive, benign procedure. So bottom line is, now, if you're going to do the varicoceles, I'm also a very big fan of the subinguinal approach, because I think when you do the subinguinal approach, you see most branches and the chances of recurrence are less. I think laparoscopic approach is doable, but in many ways it's more invasive than making a very small incision that we use for doing a microsurgical approach. When I was in New Jersey, because I also worked in the government hospitals, I also, believe it or not, I shouldn't really say this because it's a waste of resources, but we didn't have a good microscope, but I learned to do robotics, and I used a robot to do extracorporeal varicocelectomies and extracorporeal vas reversals, because any of you who have used a robot know the optics are absolutely amazing, right? So we didn't have a good microscope, but we had a great robot. So I learned to do robotic varicocelectomies. I learned that from Andy McCullough, who was at Leahy Clinic, and it worked well. Anyway, so this is how varicoceles look in the OR under microscope, of dilated veins, and we put little micro clips on them. I tell patients, it's important to tell the patients, we don't strip these veins out so they don't come back and say, "Well, doc, I still feel something here." Or you're going to feel it. And you also tell them that when they go through the airport, those titanium clips are not going to buzz, so they don't need to worry about it. But it is very, very effective when you operate for clinical varicoceles. They show the lymphatics here. This is important. So in 26 years of doing this, I have never had anybody with hydrocele, but you should tell patients that there's a 2% chance of hydrocele formation after varicocelectomy. I think when you use the microscope, you see the lymphatics, you coagulate them or you clip them, so the chance of it is very low, but it can happen. You can also have about a 2% chance of recurrence. And this is a meta-analysis of all important varicocele studies that was published by Agarwal in urology, showed that overall sperm density increased by 9.7 million, motility increased by 9.9%, sperm morphology by 3%, and as I said, also improved DNA fragmentation that we use in select cases. The point here is this is only clinical varicoceles, right? Palpable varicoceles. All right, question. 32-year-old male has the following semen parameters. The volume, well, actually, the concentration is 4 million per ml. Concentration 4 million per ml. 30% motility. Ejaculate volume is 2 ml. He has a grade 2 varicocele. His wife is 39 years old with irregular cycles. The next best step is hormonal profile, varicocele repair, testicular sperm extraction, or referral of wife to reproductive endocrine and infertility. So who wants to do a TESI? We're surgeons. Who wants to do a TESI, testicular sperm extraction? We love surgery. No takers. Good. Who wants to fix the varicocele? He has a grade 2 varicocele. No takers. How about hormonal profile? Who wants to refer the wife? All right, you guys are smart. That is the correct answer. Patient has severe oligoastenospermia. He has a total motile count of 2.4 million. His wife is 39 with potentially abnormal ovulation given her irregular cycles. Although varicocele repair may improve his hormonal profile, time is of the essence. She may require assistance. Input from a reproductive endocrine would be welcome. All right. What about surgical correction? I have 6.5 minutes to go. Surgical correction and retrieval of sperm for IVF ICSI. Well, This is what we talked about in terms of obstructive azoospermia, right? So one is congenital bilateral absence of the vas deferens, where these guys are missing, and one is iatrogenic or post-inflammatory bilateral vasal obstruction. That's at this level. And this one is post-inflammatory bilateral epididymal obstruction, right? So that's actually an interesting category. Those are typically kids that would have had, let's say, bilateral epididymitis as a child, right? They often will remember a very bad infection, very big swelling of the scrotum, let's say, and they will have obstruction at that level. And then, of course, we talked about the ejaculatory duct obstruction, and we'll talk about that in a second. So this is, again, is an AUA slide. I will tell you that I told you that I'll tell you what we have in the books and what we do in practice. In practice, I never, ever do a vasogram. I have not done or seen a vasogram since I was a medical student in McGill. It's just, there's pretty much no indication for it, because you should be able to tell anything that it's going to tell you based on the history. Now, you could say that, well, I may see an obstruction from a hernia repair at the inguinal area. Well, I will tell you, yes, you may, but good luck finding those vas ends. You will never find them in a hernia scar. It's just a complete waste of time. I do not recommend it. So what do we do for transurethral resection of the ejaculatory duct? Well, it is used to treat ejaculatory duct obstruction. There are several techniques that have been described. One is to inject contrast dye or indigo carmine into the seminal vesicles under truss guidance, followed by resection. So I can tell you that a lot of people reading textbooks will see that first bullet and are immediately turned off. They're like, okay, I don't know how to access the seminal vesicles to then inject indigo carmine, or you don't need to do it. I'll tell you right now, you do not need to do it. Now, the operation is very delicate, because has anyone seen a turret? Has anyone seen a transurethral resection of the ejaculatory duct? Yeah, I'm not surprised. It's not very common. Again, since I've been at NYU, I've had 3 patients with this, because somehow they're all kind of collected, and this is a very satisfying operation, because remember, this is the case where you have that midline prostatic cyst and ejaculatory duct obstruction. You do a TUR, and the TUR that you do is basically you are chopping off the top of the verumontanum, and the moment that you do that, you have this gush of fluid in most of these cases, right? It's a 5-minute procedure. But the reason that it is scary is that you know that, especially in a young person, the prostate is not far from the rectum, right? So when you're chopping off that verumontanum, initially you may not see that gush, so you want to take a little deeper bite, and now you're getting worried, am I getting too close to the rectum? The fact is, if you've done your truss and you know they have a big cyst, you are safe. You don't need to take a huge bite. Once you take a decent bite of that verumontanum, you're going to open and you're going to see a cavity. Now, one other practical thing that I'll tell you is that imagine they have this prostatic cyst. They have this kind of hole that you've now unroofed. Imagine an egg. You've just taken the top of the egg off. Sometimes when the ejaculate comes, it goes into the bottom of that egg. So they may not initially see a lot of ejaculate volume coming out because it goes and sits there. But with time, that cavity will close, and almost all of them will have return of the ejaculate. The complications, reflux of urine in the ejaculatory ducts, yes, this can happen, but is rarely clinically significant. So that's, again, the picture of how we go, and you try to just take that top of that verumontanum off and go a little bit deep to free it up. Vas reversal, I'm not going to spend much time on this other than telling you that microsurgical reconstruction of the reproductive tract is preferable to sperm retrieval with IVF-ICSI in men with prior vasectomy if the obstructive interval, that should be less than 15 years, and no female fertility risk factors are present. The success is based on the interval. So, for example, if a patient has had a vasectomy 3 years ago, the results are very different than if he's had it, let's say, 15 years ago. Whether or not when they did a vasectomy they use clips or not, the female age, and then, of course, whether or not it's the same female partner. These are some depictions of a vasovasostomy. The intussusception technique is what's used nowadays for VEs, the vasoepididymostomy, which is a significantly more difficult problem. I think the important point here is that when you do a vasectomy, if you see a copious clear fluid, the chances of success are higher if you just do a vasovasostomy. But if you have a white, thin, or thick toothpaste-like fluid, or if you have a dry end of the vas, when you do it, if you just do a vasovasostomy, the success is less, and you should do a vasoepididymostomy, which, as I said, is a much more difficult procedure. Again, these are a few images of the vasovasostomy, and here the vasoepididymostomy and the intussusception technique. The outcomes in general are very good, and as I said, is very much dependent on the year. So if a patient has had a vasectomy under 3 years ago, there's a 97% chance that they will be patent, right? So that's a very, very high success rate, and that's important to emphasize. If it's more than 15 years, that number drops to 71%, which is still very good when you compare it to patients who are just going through IVF. Again, we talked about obstructive azo. This is fine needle aspiration, microscopic epidermal sperm aspiration, which again, the MESA we do for what cases? We do the MESA for the CBAVD cases, right? And we prefer to go to the epididymis because the sperm there is more mature than testicular sperm, but nowadays most good embryology labs are very comfortable using testicular labs as well. And then you could do a TESI or a micro-TESI. The micro-TESI is more effective in non-obstructive cases. Again, the concept is you're using an operating microscope so you can tell the difference between the fatter, fuller tubules versus the ones that are more flat. In terms of the surgical sperm retrieval, here you could see that the spermatogenic failure is much higher if you have a higher FSH. Again, this is not something that's new to you. And the pathology on testis biopsy is very variable, anything from hypospermatogenesis to maturation arrest or Sertoli cell only. I just want to add one thing about maturation arrest. Remember how I told you that I don't like biopsies in general? Is true. The one exception is patients who have azospermia and varicoceles. And if you have a varicocele and azospermia and you biopsy them, if they have an early maturation arrest, varicocelectomy is unlikely to make any changes. But if they have delayed maturation arrest and you do a varicocelectomy, then a subselect group within that cohort will go on to have improved spermatogenesis. So that's the one indication I think where biopsy is okay. These are the predictors of surgical sperm retrieval. FSH is not a predictor, remember, so if a patient has an FSH of 30 or 40, it doesn't mean that you cannot find sperm. Testicular volume is not a predictor. The best predictor is histology on the prior testis biopsy if you have done it, but again, as I said, I don't like to do it because I think that biopsy itself is traumatic to the testis. I'd like to combine it with a cryo preservation procedure. In 68% of Klinefelters, we could find sperm, 70% of AZF deletions. And remember, these are patients who 40 years ago would have been told there's no possibility of sperm retrieval. So I'm already 1 minute past my time. I'm just going to do one more question before wrapping it up. So 28-year-old male presents with azospermia. Exam reveals testis size of 10 cc bilaterally, palpable vas deferens. His history is unremarkable. FSH is 18, LH is 11, testosterone is 410. The next step is micro-TESI, testicular sperm aspiration, genetic testing, or empiric treatment with Clomid. Who wants to give him Clomid? No one. Good. Anyway, so here the answer is C. The patient has a clinical picture of non-obstructive azo. Gonadotropins are elevated. He's not a good candidate for empiric medical therapy. Genetic testing is a critical next step, right? Remember, we talked about for these patients, you don't need to do CF testing. You're doing Y chromosome microdeletion testing and karyotype. This is the last slide. So these are the reproductive techniques that's important for you to know, right? So the total motile sperm count is what allows us to decide what treatment is best for each patient. For IUI, they need a minimum of 5 million motile sperm. I will tell you that's in many books, but the real number is that they don't like to do it unless they see about 10 million motile sperm. Most of my female reproductive endocrine colleagues like to see about 10 million motile sperm. With 1 million straight IVF can be done, and if it's very few sperm, of course, they go on to ICSI. So this is the last slide. I thank you very much, and it was a pleasure being here. Thank you so much.
Thank you so much, Professor. I really enjoy your lecture with beautiful cases. Because of time delay, we are going to run the afternoon session without break. If you want to go to the restroom, you can do so quickly and quietly. Next lecture is Female Urology by Professor Santiago Lastra from UCSD. In the morning session, Professor shows an impressive lecture with Korean and English slides. I also expected praise.
Thank you. Thank you so much. So for those of you that are rallying and staying seated, I want everyone to just stand up in your seats. Let's get a stretch out, hands out, look up, stretch out. We're in the home stretch. We're gonna end on time so that everyone can get to where they need to be. So let's get started with our last lecture of the day, Adoring Your Pelvic Floor. So we'll start a little bit with a history lesson. So, pelvic reconstructive surgery, pelvic medicine has advanced a lot in the last centuries. This is a German woodcut from the 16th century. Hippocrates and a lot of other physicians at the time really didn't understand the pelvic floor very well. They had a lot of ideas about the animalistic nature of the pelvic floor, really not understanding what it was about or why things happened and how things were interconnected. A lot of really bizarre stories would come out of their writings. Hippocrates had a theory that the uterus was like an animal and would just pop in and out of the vagina like a tortoise, somehow related to the presence or absence of sperm. So, really, really strange ideas. You can see that the first pessaries were pretty rudimentary and looked like instruments of torture. This is another device that was used for prolapse correction, very painful. Sometimes this can be a little funny, to see how our medical field has evolved or not evolved, throughout time. But within that are also stories that we do need to know and we need to tell that are very sobering and often even sad. So this is a painting that depicts the surgeon J. Marion Sims. And Dr. Sims, for many years, was very revered in the fields of urology and gynecology for being, one of the fathers of pelvic surgery. But the reality is that a lot of the knowledge that Dr. Sims obtained about surgical techniques, many of which I was mentioning to you today with regards to fistula repair, was actually obtained through surgeries performed on enslaved women without anesthesia, without their consent, and it is a sad, day when you realize that a lot of the knowledge that you use to take care of patients actually came from the mistreatment of these women, and they were very complex. We know that there were many of them. We know one by the name of Anarcha, another one is Lucy, another is Betsy. And they were really complex women. They were nurses, and they figured out how to heal and help each other get better from the numerous operations that he would practice on them. And I think it's really important for us to honor that history and recognize it so that we can treat our patients and look to the future and innovate, but yet remember, the mistakes and the false beliefs that doctors had before us so that we don't commit the same types of atrocities that these patients had to endure. And I think that at this meeting, it's been really great to see. One of the things I notice about Korean culture is that it is a very linear society in that you have so much respect and reverence for your elders and for those who came and developed before you. So I think it really will resonate with you and your values and your core values. This quote from Howard Atwood Kelly that says that no group should ever neglect to honor the forebears upon whom their contributions are based. Great is the loss to anyone who neglects to study the lives of those he follows. And so the reason I mention that as we are discussing pelvic floor is that, it's not always been easy to be a woman suffering from pelvic floor disorders. And I think we are improving in our understanding of pelvic reconstruction. There's still a long way to go, but one of the best things you can do, even if you're going to do oncology, even if you like endourology, if this isn't necessarily your field, is to understand that as a urologist, you have a unique power of knowledge to really help patients who may be suffering from these conditions. So let's talk a little bit about the pelvic floor to start. One of our colleagues today mentioned something when I was talking about the urinary tract infections. And so I was talking about the index patient, right? The index patient, you do a pelvic exam and it's totally normal, right? The only thing you might notice is the menopause symptoms. But sometimes with young women, they don't even have menopause symptoms and can still get infections. So that is a reality. But there is, as he mentioned, you didn't talk about constipation and you didn't talk about some of these other things that functionally can affect women and cause them to experience these pelvic floor symptoms, and that's what we're talking about now. Look at how interconnected that pelvic floor and that pelvic support is. You can see that the levators encompass 3 organ systems that may be treated by different specialties, but they all function as a cohesive unit. They're not separate. They behave and function together. So if you have constipation, if you have an enlarged uterus, if you have an inflamed bladder, your constellation of symptoms is going to all be intermixed together. And that's why it can be really challenging to see patients with pelvic floor disorders because they don't just come in with one complaint. They're going to come in with many. And it's up to you to, like a detective, figure out what's happening, what can you help them with, what is going to take time, what needs surgery. It can be difficult to parse through all of that and decide what you need to do. And it is super common. 1 in 3 women will experience a pelvic floor disorder in their lifetime, and most struggle with more than one disorder that we know. Prolapse, incontinence come together, pain, accidental bowel leakage, voiding dysfunction, and then GSM, which we talked about. So some of the hurdles are that it's not only a bothersome problem, but people are embarrassed. And they're also told by many, and even including physicians, that it's just a normal part of aging. And we already discussed in previous lectures that as our generation of working women get to menopause and beyond, they're not going to want to just think of it as a normal part of aging. They want to remain youthful. And for clinicians, it's, part of it is just not knowing or understanding what is happening. So hopefully we can clarify that today. One of the things I do for my women patients so they understand is actually to show them a diagram of their anatomy and call the vulva, the vagina, show them where the urethra is, where the clitoris is, the labia, everything, so that they really understand why they're experiencing what they're experiencing so they can come with you on board and have buy-in for their issues. And we already talked about these genitourinary syndrome of menopause symptoms, so that is more of a form of review. So let's go to incontinence. Patients will often delay seeking treatment for their urinary continence for a long time, and there's a bunch of reasons why that might be, but they perceive sometimes that it's a low priority. They have other problems that they need to address, so they don't really mention it, and they rarely get asked. Most women aren't examined, and they just manage it. And we can see in the United States that the sale of incontinence supplies has really skyrocketed. I can be certain that it's likely to be increasing quite a bit also in Korea with your aging population. And so as that population ages, this is going to become more important. Up to 70% of the elderly report some form of pelvic floor disorder when they're asked. And one of your faculty here at the KUA meeting mentioned that in geriatric medicine, it is becoming an ever-increasing problem. It's billions of dollars a year, and then in the era of climate change and resources, it also fills the landfills, so overall, a very important problem. So how do we start to diagnose this? Firstly, the two most common types of urinary incontinence are going to be urgency and stress. Asking the patient, do they have bladder symptoms that are troublesome? And this slide is really not for you because you know this. You will ace this on the exam. It's also about communicating that to your functional medicine doctors, your internal medicine doctors, so that they understand before just sending the patient to urology, there's a lot that they might be able to do to help the patient without resorting to surgery or necessarily needing to see the urologist. So this is another type of slide that I show patients. I show them, this is your bladder, this is the urethra, this is the pelvic floor. When the bladder squeezes more than expected, it's an overactive bladder. When it's weaker than expected, you can have stress incontinence. And the symptoms of overactive bladder are a symptom complex. So you can have a patient with genitourinary syndrome of menopause, and they have urgency incontinence and overactive bladder. You can have a patient with stress incontinence, they can have it. A patient with prolapse as well. Doesn't live in an isolated way. But these four symptoms are characteristic of the problem: urgency, frequency, nocturia, which is a challenging one, and then urgency incontinence. And it's important to remember those. So for the physicians that are going to refer us patients, what are those red flags that we want the patients and the physicians to be aware of? An abnormal neurologic exam, because then it stops being just overactive bladder and can be something more. Hematuria, as Dr. Amling mentioned, that can be a really major reason why we are not diagnosing bladder cancer as early in women, because we're kind of discarding their symptoms as part of a pelvic floor problem. Patients who might have prolapse beyond the hymenal ring, and we'll go over that. Patients with an elevated residual, patients who you can't pass a catheter, and then patients who just don't get better with regular treatment, or patients who have pain. One of the biggest ways to follow our patients with these symptoms and to verify whether our treatments are adequate and to be able to sort out the symptoms is to use validated questionnaires. And I rely a lot on validated questionnaire. We can see here that there's a validated Korean version of the pelvic floor distress inventory. And the reason why that's important is that it helps take something subjective, which is what the patients are experiencing, and it helps to quantify it objectively so you understand the severity. And that is one of the guideline-driven recommendations for the evaluation of these problems, is to really have that as your essential criteria for diagnosis. The urinalysis, the post-void residual urine volume, and the pelvic exam are going to be essential in order to really delineate what is happening with your patient. As you can see, other studies that urologists like to perform, like urodynamic cystoscopy and ultrasound, really don't come into play for the patient who is experiencing these symptoms, who does not have an elevated residual or who does not have any other striking neurologic or other red flag like the ones that I mentioned earlier. So firstly, when you suspect that there's a patient with overactive bladder, you have to distinguish it from other conditions that can give the patient the symptoms, but for other causes. And we're gonna focus more on nocturia because it can be really bothersome to the elderly patient, but it's not always a bladder issue. It could be nocturnal polyuria, which increases with age and is associated with other disturbances like sleep apnea. The way sleep apnea works is that you have the release of natriuretic peptide. And that natriuretic peptide, by its very function, will make the kidneys produce more urine at night. And so the patients are having nighttime urination or maybe even enuresis, but it's not because they have any issues specific to the bladder. It's an issue that's separate. It's not urologic in nature, and that's really important to understand. Patients can also have polydipsia. They could also have peripheral swelling. All of those things can cause nocturnal polyuria. And here we can see that a frequency volume chart, as you can see here on this slide, can be both diagnostic and therapeutic because it allows us to see how much volume is a patient consuming in a day. Is it around the recommended 64 ounces? Is it more? Is it less? It can tell us how they're managing their fluid, what their diet and behaviors are, whether they're consuming a lot of caffeine or alcohol or other types of triggers. And that can help us institute that first line of treatment, which is going to be behavioral modifications. Another important first line treatment for overactive bladder is pelvic floor exercises plus minus pelvic floor physical therapy. This is an example of a patient firstly doing biofeedback early on. Notice how very little recruitment of their pelvic floor muscles, and then with directed treatment for their levators and pelvic floor muscles, they're able to really recruit those muscles and improve after receiving biofeedback. So it is effective, but it won't be effective for all patients, and we'll talk about those in a moment. So for urgency incontinence and overactive bladder, medications exist aplenty. There are so many of them available on the market. And as far as your examination is concerned and getting ready to be a practicing urologist, as we discussed earlier, very important to understand what these medications can cost your patient, what those side effects of the medications can be, and what the actual outcomes of those medications will be. What can the patient expect to improve? Most incontinence studies, most overactive bladder studies, for something to be considered effective, it had to produce at least a 50% or more improvement in symptoms. And so that's the benchmark by which these medications have been compared to each other in mostly non-inferiority studies. So when you have patients on anticholinergics, and we're going to go over the pros and cons of that, there's going to be a lot of side effects. Anticholinergics can cause dry mouth, constipation, blurred vision, gastroparesis, even mental fogginess that has made it prohibitive sometimes for patients above the age of 70. But specifically for side effects like constipation, this is something that can be managed. But you also have to be careful with polypharmacy. This is a very common question, particularly for elderly patients who may have serious side effects when these medications are taken in conjunction with medications mentioned here. So have a lot of caution in the frail patients. Recently, there have been several studies expressing concern and showing a significant association between any anticholinergic use and the development of dementia later on in life. The risk is very low. It's a similar risk as having a car accident, so not zero, it's there, but we still go out in our cars. But it's important for the patients to be informed and to know about it. Because of this side effect, the American Urogynecologic Society has cautioned avoiding anticholinergic medication to treat overactive bladder in patients older than 70. Even so, for many insurance plans in the United States, patients must try a medication that's in the anticholinergic category before insurance will even approve their taking medications in a different category. And these are the medications here. So this is a little slide that I always include, special considerations with each of these drugs, and then the ideal patient. Not that I would prescribe this medication, but when I prescribe this medication, I think about who that patient would be. And in general, I always try to find a way to ensure that the patient will have access to a beta agonist. You are very fortunate that in Korea, you have access to a generic version of mirabegron, which is really great, because in the United States, mirabegron can cost up to $400 US a month. So it's very, very expensive. So when medications are not effective, and again, what the data shows about the medication is that most patients are not going to be on the medication at a year. So only 20% of patients will actually still be on the medication at 1 year after starting the prescription. And many don't even fill it. And they cross back and forth between beta agonists and anticholinergics and often will discontinue. So third-line therapies are really important to understand so that you can offer them to your patient. Even so, only around 10% of patients with overactive bladder will actually transition to a next-line therapy like the 3 that we mentioned, that we show here. I do know that sacral nerve stimulation is not commonly used in Korea, I think because of insurance coverage, but it is considered an important therapy, and I include it here for your knowledge. It has been compared head-to-head with Botox with very minimal clinical significantly difference between Botox and sacral nerve stimulation, with Botox being slightly more effective. Botox has been a game changer for overactive bladder. It has longish effects. Most patients, it'll be about 6 months in effect, but it can last up to 14 months. 50% of patients with wet overactive bladder have become dry in the randomized controlled trials, and 80% of the patients report symptom improvement. And remember that symptomatic improvement for these clinical trials means 50% improvement in symptoms. Some of the risks that are important to know are the risks of urinary tract infection and then transient urinary retention. And one thing to remember is that Botox has to be done sequentially, right? You have to re-inject. If a patient gets their first Botox injection and comes back for another, and they didn't experience retention with the first injection, it is almost likely that they will not experience retention with their subsequent injections. So it's really important to counsel them for that first one and to check their residual urine volume and make sure that if they void, they are able to empty their bladder. But if they are successfully emptying, the likelihood that they will continue to empty will be there unless you increase the dose. So let's transition to stress urinary incontinence. So I tell patients something that one of very famous urologist, his name is Alan Wien, and he's was the former chair at the University of Pennsylvania, and he's one of the men on the cover of the Campbell's textbook, his name is there, is that he tells his patients that the bladder is an unreliable witness. And it is very true. Patients will give you subjective symptoms, and it's up to you to find objective data to support those symptoms so that you can appropriately triage them into the right treatment option. And with stress urinary incontinence, that is very important by way of the cough stress test. So a cough stress test is when the bladder is modestly full, it doesn't have to be super full, and you have them cough or strain when you're doing their clinic evaluation so that you can make sure that the symptoms that they're expressing, you have documented and you have visualized. But it's not the only finding that you'll have. You can also determine their severity by the pad usage that they have. You can also use the degree of bother that they have with the symptoms to factor into your decision making. And then you also use the pelvic exam to make sure that there aren't other findings happening at the same time, like atrophy, genitourinary syndrome of menopause, prolapse, and some of the other findings that we discussed earlier today. There's a lot of non-surgical therapy for stress incontinence. I noticed one of the abstracts that was presented at this meeting was by a group that was looking at an intravaginal device intended to manage stress incontinence. So even now there's a lot of innovation in this space. Biofeedback, like we discussed, can be successful, but the results will decline unless the patient continuously implements what they learned. So it can be cumbersome for an older patient. Pessaries, especially knob pessaries, can be successful. And unfortunately, not really any strong evidence for the use of medications, although some people will prescribe imipramine or phenylephrine to help with incontinence, but what the data has shown is that it really is no better than placebo for symptoms. So we'll talk a little bit today about the data regarding stress incontinence surgeries listed here. But prior to considering surgery, there are some additional evaluations that I want you to really consider in these kinds of patients. So firstly, if you're not able to demonstrate stress incontinence on exam, that is, something important before you embark on placement of a sling or some kind of intervention which can have, really significant consequences for the patient. You really want to make sure you document that the stress incontinence is occurring, and that may be a time when you want to consider a urodynamic study, again, because the bladder is an unreliable witness. If you suspect neurogenic lower urinary tract dysfunction, because those patients may have a higher risk of urinary retention if you treat their bladder outlet. The abnormal urinalysis, as Dr. Amling mentioned earlier today, when their symptoms are urgency predominant. So having a discordance between the exam and what they're reporting to you. Patients who have an elevated residual and patients who have an abnormal POP-Q beyond the hymen, and patients who may have voiding dysfunction. Red flags there that you want to look into further. So the first and least invasive of the operations for stress incontinence is the urethral bulking agent. And the urethral bulking agent exists in many forms. The one that I currently use is Bulkamid. It's a polyacromide gel that has some decent data. The longer term data is coming in, and again, similar to previous injectables like collagen, macroplastique, coaptite, they're all pretty much the same. There has not been one injectable agent that has shown superior performance to the others. Patients who choose to have the bulking agent will often do so to avoid a longer recovery time. Once you have a bulking agent, you can go back to all your regular activity without restriction. And the other way in that it helps as an instrument is to enhance incomplete improvement after a sling surgery of any type or a birch. And then we get to the sling. The takeaway from the sling is that it is considered the gold standard treatment for stress incontinence. It is the most tested, it has the most clinical trials supporting its performance. And there have been decades of effectiveness documented for the synthetic polypropylene mid-urethral sling. There are different kinds of slings. There's transobturator, retropubic, the single incision slings. And there are some differences here and there. The transobturator has a lower rate of bladder perforation, which is why it was invented in the first place, and you can see it here. The retropubic sling may have more earlier complications of intravesical trocar passage, but there might be in some of the clinical trials a slightly higher effectiveness and durability of the operation. Top-down approach, bottom-up approach, however you want to pass it, the results are pretty similar across the board for the sling surgery. So some considerations when you are looking at a patient considering sling surgery, and we discussed this earlier. Do not place a synthetic sling if the urethra is inadvertently injured at the time of procedure. So similar to when you're placing an artificial sphincter and you have a urethral injury, it's game over, put a catheter in and come back to fight another day. It's the same for the sling. Similarly, patients who have undergone some form of urethral reconstructive procedure are probably not great candidates for a synthetic sling. Similarly, patients who have been radiated or patients who have any relative contraindication to sling surgery, like very poorly controlled diabetes is an example. There's also the autologous pubovaginal sling. And the autologous pubovaginal sling has 87 to 92% improvement in symptoms. Also, many randomized controlled clinical trials that have documented its success. The autologous pubovaginal sling is a more morbid procedure. The voiding dysfunction that results from the surgery itself can be associated with more morbidity, typically lasting upwards of 6 weeks. It is also a tensioned sling, whereas the retropubic sling is tension-free, so there's differences there with the rates of retention. And in general, it has been outperformed by the synthetic sling for the index patient who does not have any of those other red flags that we discussed earlier. And now we're going to get to pelvic organ prolapse. The reason today I chose to perhaps emphasize a little bit more about pelvic organ prolapse is just based on my observations of the types of abstracts that were submitted to and presented to the meeting. And so I wanted to ask a few questions now. How many of you in your residency program are routinely performing prolapse operations? Raise your hand. Okay. One of you. So that's, so that's important, right? As we discussed in the beginning of the slide, these pelvic floor disorders don't exist in isolation. So you will very frequently encounter a patient who has really profound incontinence and also has severe prolapse and is bothered by both. And certainly you can collaborate with your gynecology colleagues to find the best care for the patient, but often we don't have that luxury. We might be the only provider who's available, and we want to be able to at least evaluate and understand objectively what is troubling our patient so that we can make the best surgical decisions. And prolapse is incredibly common. Less than 10% of the cases will be truly symptomatic, and we'll go over why. And there are many reasons why this can be developed. Parity and aging play a very, very strong role. Most women with mild prolapse have no symptoms, and I think a rule of thumb is if the bulge, the vaginal bulge, is not protruding beyond the hymen, and we'll look at some examples, it is very low likelihood that it is going to be bothersome to the patient. But some of the common symptoms are feeling a bothersome bulge, some fullness, difficulty emptying bladder or bowels, and then splinting. So splinting means putting pressure on the perineum or in the vagina to help evacuate the bladder or the bowels. And many women with bothersome prolapse will have to splint to fully be able to evacuate. I keep double clicking. Okay. So in the evaluation of prolapse, any prolapse to or above the hymen is unlikely to be clinically relevant. And a lot of the studies that have been done on the success of prolapse operations actually are able to bring the vaginal bulge to a place that's close to, but not beyond the hymen. So what does that mean? That if the patient has a bulge that's potentially bothering her, but it's not beyond the hymen, and it is very unlikely that you will be able to correct that with surgery. And if you find that scenario, many of those patients can have another pelvic floor disorder, like all of the symptoms that we previously discussed, and that might be somebody who might benefit from a pessary fitting to see if their symptoms are alleviated by the support before deciding to actually do surgery. And you also want to include a post-void residual for very advanced prolapse. This is called procedentia. You can see this is the cervix here. So this vagina is completely inside out. And then referrals may come to you when there are bleeding or erosions along the vagina. That can be treated with estrogen. When prolapse is very advanced, like the one we see here, or when patients have urinary retention or even hydronephrosis, because the prolapse interferes with bladder emptying and patients have chronic obstruction as a result of that. So let's do a case scenario and kind of go through how we quantify prolapse, because that's important and it is very testable on the AUAs in service. You have a 64-year-old postmenopausal woman. She's a very bothersome bulge. She tells you that she needs to splint to have a bowel movement. She feels constipated, and she feels like she's incompletely emptying her bowel and her bladder. So let's talk first about the levels of support. This is a very early description of the different levels of pelvic floor support. Level 1, the uterosacral ligament, is the support for the vaginal apex or the roof of the vagina, and there's a POP-Q measurement that goes with that. We'll discuss it. Level 2 support has to do with the front, side, and back walls of the vagina. And that's typically where we treat anterior colporrhaphy, posterior colporrhaphy procedures. And then level 3 support is the bladder, neck, and urethra, and then posteriorly the perineal body. And many prolapse repairs, if they don't take into consideration restoring each one of these levels of support, the patient will be more likely to have an operative failure, early operative failure, and need reintervention at an earlier time frame. Here you can see the levels of support from the side. Level 1, apex. Level 2, front, lateral, back walls of the vagina. And then 3, perineal body, vesicle, neck, and urethra. Again, a sagittal view of the vagina. And then this is the pelvic organ prolapse quantification tool. It's the best and most widely studied way to objectively quantify pelvic floor descent. There's also the Baden-Walker scale, but again, the POP-Q has stood the test of time. These are the different measurements, and I'm hoping to explain those to you today so that it's a little easier to understand. These anterior and posterior wall measurements are going to be the internal measurements of descent. The genital hiatus, perineal body are right at the opening of the vagina, and then total vaginal length is actually the only one of all of those measurements that's done without the patient straining. So let's go through it. So this is point AA. Point AA is a fixed point on the vaginal wall, 3 centimeters from the urethral meatus. So since it's a fixed point on the vaginal wall, it can only swing out to plus 3 centimeters. It can't go out any farther than that. So if you ever see a POP-Q with point AA being greater than plus 3, it's wrong. It's a fixed point. And that point there is where we place a sling. It corresponds to that urethrovesical crease. So when patients have urethral hypermobility that we talk about on pelvic exam, great candidate for sling, that's actually a loss of level 3 support, and we correct it with slings. So that's this measurement. So point BA is the most distal portion of the remaining upper anterior vagina. So let's say the patient is straining, let's say it's this same patient here, and the point that comes out the furthest is right at the hymen, so 0. Then that means that that is the leading edge. So AA would be 0, and BA would also be 0. Point BA is always going to be the number that is furthest out and most distal to the vagina. And so it has to be the largest number on the anterior wall. Here you can see, for example, if I were to do this measurement, point AA, the most it can come out is to plus 3. but point BA will be the cervix, because that's the leading edge of the vaginal bulge. And because this patient has procedentia, it's probably going to be somewhere equal to the total vaginal length, because that vagina is everted. And we'll go over that a little bit. So similarly, posterior wall points AP and BP, so A posterior, B posterior, very much the same. Point AP is going to range from -3 to +3, and point BP is going to be the leading edge of that bulge. And we can see those numbers here. So as with point BA, it can range from -3 in a patient that has excellent support. So -3 means that it is proximal to the hymen, to total vaginal length in cases of complete eversion like what we saw earlier. Point C represents the most dependent edge of the cervix or the vaginal cuff. In cases like this patient where there is complete procedentia, point BA and point C are going to be the same, because point C is the leading edge. So that can happen. And this represents the vaginal apex, and the range can be minus total vaginal length to all the way total vaginal length outside of the hymen in cases of eversion. Point D doesn't always exist. So point D represents a location of the posterior fornix, and you can see it right here, in a woman who still has a cervix. And why is that point important? Look at these different cases of cervical elongation. So some women who have prolapse, they don't actually have a bulge of the entire vaginal canal. What they have is a cervix that elongates and continues to elongate until it protrudes from the vaginal opening. But their vagina itself is still well supported. So that's a different case of prolapse. For example, here, where the cervix is short, then this cervix, which is very long and might be coming out of the vagina, but yet the uterus is still remaining with its support. So that's why point D exists. When women have had a hysterectomy, there's no need to have a point D. You don't need to measure it. And so all we do is delineate it as an X, because the cervix is gone and we no longer need that measurement. The genital hiatus and the perineal body are measurements obtained of the vaginal introitus. And genital hiatus is measured from the middle of the urethral meatus to the posterior midline hymen. And the perineal body length is measured from the posterior margin of the genital hiatus to the mid-anal opening. Genital hiatus and perineal body measurements are really important because it is the restoration of the genital hiatus to a normal size that has the strongest predictor of the prolapse coming back after having an operation. And most genital hiatus measurements considered to be within normal range are around 3. So what are the objectives of the POP-Q? The POP-Q, it's not intuitive, and it can take some time to learn how to do it. After you do it, if you get used to doing it, if you want to treat prolapse in women, it becomes a really useful tool, and I'll show you some examples. It helps you quantify the prolapse. It helps you compare the outcome of your repair pre and post. It is the standard by which we measure our clinical trials. It allows us all to do a similar exam and for it to be reliable from one person to the other. And it's the standard for abstracts and publications, etc. There is a staging system for the POP-Q, and we're going to go over its clinical significance here. So one thing that you'll notice is that stage 2 is actually a very interesting stage because half of the measurements are going to still be within the vagina, and half of the measurements are going to be coming out of the vagina past the hymenal ring. And what I mentioned earlier holds true. Look at the percent of patients that feel like they have a vaginal bulge, around 50%. Remember, I mentioned in this stage, patients who have bulge that is within the hymen, most of those patients are not going to have symptoms. You can see that that transitions into where most patients start to have symptoms of a vaginal bulge when the measurement comes outside of the hymenal ring. So very easy when you're doing a pelvic exam, the patient feels like they have a bulge. One very good rule of thumb is to see whether their straining shows you a bulge that exits the hymenal ring, you can see coming out of the vagina, or whether it's within the vagina still. So we're back here to our patient who's very, very bothered with all of her symptoms, and we want to do a POP-Q. And so what are important evaluation points to consider when preparing for an exam to evaluate your patient with prolapse symptoms? Again, a cough stress test. It's very important that if they have a bulge, similar to the ones that we saw earlier on those pictures, that we reduce the prolapse before we evaluate for a cough stress test. Why? Because if the vagina is protruding or you have a big bulge, that might actually mask the incontinence, and they might actually have a negative cough stress test when they actually have urethral hypermobility. We want to see their voided volume. We want to look at their residual urine volume. We want to do that POP-Q, and we want to assess vaginal estrogenization because the durability of the repair and their ability to hold a pessary comfortably is going to really depend on that. We want to look at their comorbidities. Are they actually surgical candidates? And then we also want to know, what their expectations are. You can't fix not bothered. So even if a patient has a really significant bulge, if they're not bothered by it, you're not going to correct them with surgery. So this is an example of a POP-Q assessment we could see in that patient. Does anyone want to tell me what vaginal wall seems to be affected here? Is it the posterior wall or the anterior wall? Anterior wall. 1 second. It says anterior wall. This is a positive number, negative number. So this is still within the hymen, and this is beyond the hymen. You can also see that the patient has a total vaginal length of 8.5, but her cervix is all the way down to -2, and her posterior fornix is down to -4. And the part of that bulge is outside of the vagina. So this is pretty clinically significant. This is another example. Here we can see the leading edge of the vaginal bulge is not at the urethrovesical crease. It's actually a little ahead of that. And then we can see that there is 5 centimeters of descent for the vaginal apex. So if I were to choose an operation for this patient, I look at my POP-Q and I say, okay, anterior wall, I keep clicking on it. Anterior wall is affected. The apex of the vagina is affected. So we have loss of level 3, level 2, and level 1 support anteriorly. If we look posteriorly, the posterior wall is at the hymen. So we've also lost level 2 and 3 support posteriorly as well. We have an enlarged genital hiatus, which we will also want to correct, and we want to rebuild that perineal body. And so all of that I can obtain from looking at a POP-Q, and that's how they'll present the questions to you on an exam. They'll show you a POP-Q, and you determine what type of operation this patient might benefit from and how you will counsel them. So how do we manage the prolapse? There's expectant management with physical therapy is an option. Most patients with prolapse are not going to get better just with expectant management, but it is very likely that their symptoms may not progress too much worse than they currently are. Doing physical therapy can be helpful. Anatomic regression is very unlikely, but symptom improvement is possible in up to 70% of patients. Pessaries can be helpful in patients who do not desire surgery. And vaginal estrogen can also be quite helpful in alleviating some of the symptoms of the vaginal ulceration and tearing that can sometimes be experienced when the bulge is out pretty far. There's all different hosts of pessaries, and that can be really helpful. And it can also help you counsel the patient, maybe try a pessary for a little bit if she's unsure whether surgery might help her, might be able to try a pessary for a little bit before she makes that decision. Decision-making for prolapse surgery is also really important. The surgical approach has to be decided on. Is the patient going to have vaginal surgery, or are they going to have abdominal surgery? And abdominal can be open, laparoscopic, robotic. If they still have their uterus, do they want to have a hysterectomy? Will it be a supracervical hysterectomy or a total hysterectomy? Or are they going to preserve their uterus? Women also have opinions about that and need to make the decision. And then will they use a mesh-augmented repair, which can be more durable but is associated with more mesh-related complications? Or are they going to have a native tissue repair, which shows more likelihood of recurrence of the prolapse at 5 years based on many of the clinical trials, but lower complication rate? So let's take a look at a little bit of a prolapse operation called the anterior colporrhaphy. This is, if you are a general urologist, it'll be one of the more common operations that you may perform. Let's see if we can. All right. So here we see that vaginal bulge, right? Like the one we measured before. That's the urethral vesicle crease. And here we're marking the midline of that vaginal bulge. And you can see the dissection of the vaginal tissue off of the pubocervical fascia. The pubocervical fascia, and behind that is the bladder. So we want to free that up. And the landmark to look for when you're doing your repair is at the point when you can place your sutures right behind the pubis. And then these are our anterior colporrhaphy sutures. It's important to lay those sutures like a lattice around this defect so that we can give it the support that it needs. And this is a very common operation that urologists will do because it often happens concomitantly with the placement of a sling. Again, urethral hypermobility is a loss of level 3 support. And if you've lost level 3 support, it's very likely that you could have lost some of your level 2 support. One very important thing for all of us to remember is that if you have very severe loss of that level 2 support, so point BA, if you notice point BA is at +3, it's very likely that your vaginal apex or your point C, your cervix or your vaginal cuff, is also coming down. So just doing an anterior repair may not help your patient's symptoms. You also need to treat the roof of the vagina or the vaginal apex. So these are all, there's more than 20 different operations that you can do to help prolapse. And obviously we have a fellowship and special training to do that. So it's not necessarily an essential that you need to know how to do all of these operations when you finish your residency, but you should understand what they are and who would be the best candidate for these operations. For example, a colpocliesis is an obliterative procedure where the vaginal canal is actually closed to reduce the vaginal length to under 2 centimeters. That is a procedure that restores all the levels of support, but renders the vagina unusable for having sexual intercourse. So it's important to know that. It's important to know the uterine sparing operations like hysteropexy, both vaginal and abdominal. And then understanding sacrospinous, sacrocolpopexy, and then reasons why we might perform, for example, a hysterectomy. In general, if my patient doesn't feel strongly about having, keeping their uterus, hysterectomy is very reasonable. It does reduce their risk of experiencing any form of uterine cancer. And the trials comparing uterine preservation with hysterectomy have shown pretty equivalent results. So it is a nice thing to let the patient decide how they would like to proceed. As far as whether to use mesh or not, especially for younger women who present with high-stage prolapse, the mesh-augmented options do have a lower risk of recurrence. For native tissue operations, so surgeries that use their own tissue, the risk of recurrence of the prolapse is more than 30%. And that's at 5 years. So that means that for those patients, 3 out of 10 women who have native tissue surgery for high-stage prolapse are going to have symptoms again within 5 years, which is why the sacrocolpopexy has become and is considered to be the gold standard, especially for younger women with prolapse. This is an example of a patient with severe vaginal bulge after a hysterectomy who underwent an obliterative procedure. So you can see here the big change that happens here. For this operation to look like this from this, we had to obliterate the vagina and unite the anterior posterior walls of the vagina, and then also perform a perineorrhaphy to reduce the size of that genital hiatus, which is quite large in this patient. Another surgery is the uterosacral ligament suspension. You can remember from the initial slides showing how the uterosacral ligament is the one that determines the level 1 support for the uterus and the vaginal apex. So this is something that's accessible robotically or transvaginally. It's easy to identify the uterosacral ligament. It's straightforward because of the anatomy being so easy to identify. But one of the risks is ureteral kinking. As the uterosacral ligament is tied down to the vaginal apex, it can cause delayed drainage of the ureter. So it's important to do a cystoscopy to assess for that at the end. I have a better slide for this one, I think. This is the uterosacral ligament. Let's look at this one instead. This is the uterosacral ligament. This uterosacral ligament is right there sacrospinous ligament is right there at the ischial spine. You can see the sacral nerves turning into the pudendal nerve right there. It's an area where we do pudendal nerve blocks. That is a very strong ligament, very easy to identify. It's an extraperitoneal procedure and can be done unilaterally or bilaterally to restore pelvic floor support. So I don't think we have time to look at this, but this is available online on the AUA core curriculum. And then we have, again, the gold standard for durability of apical prolapse repair, which is the sacrocolpopexy. How many of you have performed or assisted in a sacrocolpopexy in your residency? Raise your hand. Okay, excellent. So the sacrocolpopexy is considered the gold standard not just because of its durability, but also because it preserves vaginal length, whereas some of the other procedures do not. So when you're thinking about a younger woman with prolapse, that is a very important consideration. Here you can see creation of the canal through which the polypropylene mesh is going to lie. Here we can see, similar to that other procedure we saw with the fistula, how we're creating these rectovaginal and vesicovaginal planes. So that is another benefit of pelvic reconstructive surgery. The case of the fistula was made much more straightforward by our knowledge of these tissue planes, which are the exact same planes that we used in the other case, except the other case was inflamed and sick and infected, and this one is not. But these types of things are what helps you use your knowledge of anatomy to apply it to other cases that aren't necessarily prolapse related. Here we can see I'm using some Gore-Tex sutures to tack down the polypropylene mesh along the anterior and posterior aspects of the vagina. The sacrocolpopexy also addresses that level 1 support by attaching the vagina to the sacrum. And it also addresses the level 2 support by those arms that come anteriorly and posteriorly. They're sutured onto the anterior and posterior vaginal walls so that the vagina in its entirety is suspended as a unit. The only thing that a sacrocolpopexy will not do is restore your level 1 support. So if you have a wide genital hiatus or the patient has stress incontinence, that's going to be something you will need to address additionally. Did I exit? My mistake, sorry. I think I just have the conclusion slide. In conclusion, pelvic floor disorders are going to come in an amalgam of symptoms, and it's up to you as a detective to determine what's bothering the patient, what do you objectively observe, and what tool can you offer the patient to help them get better. This is just showing a hysterectomy, which we don't have to look through. So patients will suffer for a long time. So when they come to see you, they expect a solution. Always offer non-surgical solutions, even if you think they would be better served with surgery. Always offer that. Always offer that to the patient so they have that option. You're not going to be able to help them without performing that pelvic examination. How bothered the patient might be is going to make a big difference. And then don't forget, and this is, again, essential for an exam and also for the real world, you have to rule out any urinary or vaginal abnormalities. You have to do a urinalysis, and for the reasons we talked about earlier, a speculum examination is also going to be a must. Thank you so much.
Thank you so much, Professor Santiago Lastra. Yeah, I respect you and your effort to Korean slide. Now today, review course has finished, and I'm very grateful to all people in this course. So I suggest final photo with the final people in the course. Let's take a picture with the final people. Come here.